One thing my prostate cancer hasn't changed: this place. We've made some great memories here, and we're making one today with a little help from Nubeqa.
Nubeqa is a prescription medicine used to treat adults with prostate cancer that has not spread to other parts of the body and no longer responds to a medical or surgical treatment that lowers testosterone.
I was on hormone therapy, but my PSA was rising, so my doctor recommended Nubeqa.
In a clinical study, men lived 2 times longer without their prostate cancer spreading when they added Nubeqa to ADT. Nubeqa may also extend survival. Nubeqa may cause serious side effects, including heart disease and seizures. Tell your doctor right away if you have chest pain or discomfort, shortness of breath, loss of consciousness, or seizure. Nubeqa can harm unborn babies and cause loss of pregnancy. Common side effects were changes in liver function tests, decreased white blood cells, feeling more tired than usual, arm, leg, hand, or foot pain, and rash. Nubeqa helps you live for what you love. Ask your doctor about Nubeqa.
This meeting has singularly been able to propel forward many of the concepts that are changing the field throughout the world. So even though you guys think that you're just sitting there as participants or audience, just through your social networking, just by sharing ideas, just by changing referral patterns, other institutions are going, well, crap, you know, we better set up a PET scanner, or gee whiz, we better get into a more aggressive mindset about therapy. I like this meeting. I like talking to patients. I think patients get it much better than doctors. So for me, that's why I come and speak to you. And for me, the privilege is simply that some of you are doing better, all right? That's all I need.
Hey everyone, it's Alex from the PCRI, and welcome to our 2023 Prostate Cancer Patient and Caregiver Conference. We are honored to have you today, and we have an action-packed event lined up for you this weekend, and we will get things started very soon. But first, we're going to have a quick invocation for this conference.
Well, it's great to be with you this AM via Zoom, and I totally thank God for technology. I met Dr. Schultz during my own 7-year journey through prostate cancer. And thanks to God and thanks to Mark and several other skilled medical folks, I'm alive and well, and thankfully through a journey I never wanted to be on in the first place. And through it all, Mark and I struck up a lasting friendship. I love that guy. So I'd like to invite you, if you want to join with me and call upon God in a brief prayer and ask for clarity, peace, direction, the purposes of heaven to be made manifest in this gathering, that everyone here would have open ears to hear, open hearts to sense God's love and presence, open minds to process all of the solid medical intel and sound advice that's been carefully prepared by people who truly care about your successful health journey. So I'll pray as I was requested. I'll ask God of heaven and earth to bless this conference. Feel free to exercise your free will to pray or exercise your free will to not pray. He is so good, he offers each of us that option all the time. So, Lord, I come before you right now, Lord, with probably many praying along with me, and we bless you, and we ask, God, that your spirit, your shalom, clarity and peace, God, would be upon this conference, and ears and hearts and minds would be open. The speakers, God, would speak clearly, God, and people would be able to receive and process that which is from you and that which is for them. Lord, I pray a blessing over this place and every attendee, God. We pray this in your precious name. Amen.
Thank you, Rabbi. Now, just a few things before we start. If you aren't subscribed to this channel yet, go ahead and click that subscribe button. Not only does it help support us, but it helps you stay up to date. This conference will stay here on this YouTube channel after the broadcast, so you can reference it in the future. Also remember that this event is free because of donations from people just like you. Thank you to everyone who donates to PCRI, and if you would also like to donate and support our cause, you can do so at pcri.org/donate. The link is in the description below. Also on our website at pcri.org/2023-conference, we have the agenda in our virtual exhibit hall. Make sure to visit that page for many resources, more information, and information about our speakers. I also want to thank our many sponsors who have helped to make this event possible. Bayer, Pfizer, Astellas, Janssen, Novartis, Dendreon, Sumitomo Pharma America, and Sanofi. This year, we're presenting this entire conference virtually, but next year, on September 7th and 8th, we'll be hosting this conference in person, live here in Los Angeles, California. We're going to bring together world-renowned prostate cancer experts covering every type of prostate cancer, and you will have the opportunity to get your personal questions answered in person. From the companies who create the treatments, to the support groups and the advocacy groups around the country, to the speakers in every field of prostate cancer, and the patients and caregivers who are experiencing the same type of cancer as you. This conference will bring together some of the most powerful and incredible resources any prostate cancer patient can have. And I promise you, you don't want to miss it. There's no better way to learn about prostate cancer than from world-renowned experts, getting your personal questions answered, and then having a community supporting you at the same time. Sign up today at pcri.org/2024-conference. I'm so excited. Next, we have Dr. Mark Moyad. He will give us an intro to our conference. He's the Jenkins Poe Kempner Director of Complementary and Alternative Medicine and Education at the University of Michigan Medical Center Department of Urology. Now, Dr. Moyad has moderated over 23 of our PCRI conferences. He's been a longtime friend to Dr. Scholes, myself, and the PCRI. But more than that, he's helped thousands of patients learn about their disease by breaking down complex concepts and putting everything in context for us. From helping find world-class experts to advising PCRI on our education and helping us stay up to date, PCRI would not be the same without him, and we're so grateful for his help. So here is Dr. Mark Moyad.
Hey everyone, welcome to the 100th annual, feels like that, we've been doing this a long time, PCRI Fall Conference. I'm so excited you're here. Rather than doing a regular introduction, I have so much Q&A with these expert speakers that I'm going to get my opinion in at that point, rather than you being sick of me and just putting my opinion in up front. As always, me and my companion, Grazie Boy, who believes in quality of life, and you're going to see his video after this. We are together. He's looking at me right now, and we're just excited to be essentially making sure that this conference takes off. This is the moment where everything gets going. So sit back and enjoy it, because we're about to cover everything you could possibly think of in prostate cancer from A to Z. And let me tell you, a lot of things happened this year, and we got some of the best out there. Thanks to the entire team at PCRI. Also, thanks to Dr. Scholes out there. It's a great event. Sit back and enjoy it, because we're going to make sure that the speakers act appropriately and they pass on their knowledge. And look how excited my dog is for the event. Grazie, are we excited for all the speakers in PCRI? Yep, he said that we are. So lots of love to everyone out there. I hope this is the kind of information you're looking for, because we're excited to be giving it to you. And I'll see you along the conference and all during the Q&As. Mwah!
Thank you, Dr. Moyad. Before we get started with our first presentation, I just wanted to remind everyone to visit the exhibit hall on our conference webpage, where you'll find lots of helpful information about treatments, payment assistance programs, and so much more. Our next speaker is Dr. John Mulhall. He's the director of the Male and Sexual Reproductive Medicine Program and the director of the Sexual Medicine Research Laboratory at Memorial Sloan Kettering Cancer Center. He's an incredible expert in his field, and he will present on sexual health and function after prostate cancer treatments. Right after his talk, the Q&A session with Dr. Moyad will begin, and you won't want to miss it. Without further ado, we welcome to the conference, Dr. John Mulhall.
Thank you, Alex, for the introduction. It's my pleasure to be here at the annual PCRI conference. This is my 6th time at this conference, and I want to thank you for viewing this video, and I'm hoping that this will help you in your decision-making about your prostate cancer therapies. I'm a urologist, I'm a sexual medicine physician, and I work at Memorial Sloan Kettering Cancer Center in New York City. As I'm wont to do, these are my disclosures. So I'm a penis doctor. I'm not an oncologist. When patients come see me, I never interfere with their plans for their cancer therapy, whether it be prostatectomy, radiation, or hormone deprivation. I am direct. I am very straight shooter, and so I'm going to be very honest with you today. And of course, I don't have a dog in this fight. I'm not a prostatectomist. I don't deliver radiation. I don't deliver hormone therapy in prostate cancer patients. I'm a sexual medicine doctor, and I'll help you as best I can, at least understand what to expect. I hold all physicians of all kinds to a very high standard. We have a huge responsibility in the management of you and the care and your decision making. And it's our job to give you the best information possible so you can make the best decision for yourself. I'm consumed with the truth in science, ergo the title of the talk. And so I won't present a lot of data today, but I would like you to think that at the end of this, that this is a science-based opinion discussion. I speak very quickly, and if you would like to follow me on Twitter, this is my handle, Save Your Sex Life. John Hewlings Jackson was a neurologist at the beginning of the 20th century, and I love to introduce this topic and many topics with this quote. It takes 50 years to get a wrong idea out of medicine and 100 years to get a right one into it. And the wrong idea is, Mr. Jones, your PSA is undetectable, and why aren't you happy? And the right one is that we should be looking at each patient in a holistic fashion and look after everything, including their quality of life, which is the basic tenet of the concept of survivorship. There is nowhere on the prostate cancer journey continuum where sexual dysfunction doesn't play a part, even a man after diagnosis, given that adrenaline is the world's most potent anti-erection chemical. The stress associated with the diagnosis alone can tip men over into erectile dysfunction. We're only as good as our last erection as a man. So if we've one or two occasions when our erectile function isn't satisfactory, then every time following that is a problem, and it becomes a snowball effect. And it becomes a snowball effect not just on erectile function, but of course men become avoidant when they don't have good erections. I don't play pool very well. How often, Mr. Jones, do you think I play pool? Not very often. The same tenet occurs in the erectile function sphere also. A man who has persistent problems with his erection rigidity or his sustaining capability becomes avoidant. And that's often perceived as low sex drive. Subsequently, men often have problems with rapid ejaculation or even delayed orgasm because the adrenaline load is so huge in the bedroom scenario. Whether it be active surveillance, whether it be definitive treatment in the form of prostatectomy, radiation therapy, or even hormone therapy, or towards the end of the continuum, sexual dysfunction becomes increasingly problematic. So optimal outcomes. To achieve optimal outcomes requires fully informed consent before treatment, which requires that the clinician, I use the word clinician very carefully here because a lot of healthcare is now delivered by non-physicians, so nurse practitioners, PAs. It's important that they all give realistic expectations about the effectiveness and the side effects of treatment, which sexual dysfunction is one. The word cancer is scary. I certainly understand. I see about 600 new prostatectomy patients a year at Memorial Sloan Kettering Cancer Center. I see about 150 radiation patients and about 150 triple therapy patients. Surgery, radiation, and hormone therapy for high-risk disease, biochemical recurrence, PSA elevation, after surgery, after radiation. So it's a very large volume oncosexology practice. And I understand very well that the term cancer is very scary. But in the vast majority of cases, you have time. You have time to read, to research, to meet more than one physician and make your decision. There are types of prostate cancer that are more urgent, and we can talk about that later during the Q&A session. My goal today is to give you advice to help you enter any treatment program with your eyes wide open. That is the most important thing for me. Remember, I don't do prostatectomies, I don't do radiation therapy, and I don't administer hormone therapy. I just want you to be able to do your therapy and look back over your shoulders and have no regrets about your choices. From a treatment effect standpoint, the only sex-friendly strategy is active surveillance or watchful waiting, where no definitive therapy is done. Even in these men, there's PSA anxiety and active surveillance where people are obsessively monitoring their PSAs, and that alone can cause them to have problems with their sexual function. But certainly prostatectomy, radiation therapy, and hormone therapy can have significant effects, at least transiently and frequently in a permanent fashion. So the barriers to optimal sexual function outcomes: clinician bias, patient bias, knowledge deficit on behalf of the patient or couple, if one exists, or the clinician, technical expertise factors, whether it be the use of the most modern robot or the use of the most modern radiation therapy delivery systems, technology factors, infrastructure, support, and insufficiency in that front. So I happen to have the luxury of having 4 nurse practitioners and 3 nurses in my practice that support our penile rehabilitation program, which is very labor, time, energy intensive. And then financial factors. The biggest financial factor historically was, of course, the cost of these PDE5 inhibitor drugs. Viagra, Levitra, Cialis, and Stendra, the 4 drugs available in the United States. There are several others available throughout the world. But the biggest issue historically was the cost of those drugs, which now in generic forms are very, very affordable. Barriers to good sexual health care, physician discomfort. The average physician gets about 2 hours of sexual health education during medical school. How can that make the average human being comfortable talking to men about their erections, about their ejaculation, about their orgasm? Almost impossible. By the way, not every urologist is comfortable, and not every radiation oncologist is comfortable in having the sex discussion. If you get the sense from those physicians or clinicians that they're not comfortable, then perhaps you should seek somebody who does this for a living. And there are many of us who do this for a living. And if you're interested, you can go to the Sexual Medicine Society of North America at smsna.org for a physician locator. Physician bias. The evidence, I think, is pretty clear that if you go to a prostatectomist, it's very likely you're going to get a prostatectomy. And if you go to a radiation oncologist, it's very likely you'll get radiation therapy. So seeing both in your decision-making process is not unreasonable at all. Physician projection. 72-year-old man diagnosed with prostate cancer, needs therapy, and you've got a 65-year-old physician sitting in the office. Well, Bill, you've had a good innings, right? That's not what we should be thinking. We do not practice ageism in sexual medicine. The only thing that matters to me in my practice is the motivation of the patient or the couple where one exists. The concept of physician as a technician. In the modern world, in contemporary medicine, increasingly, radical prostatectomists are just technicians. They'll see you, you need an operation, they do the operation, and then many times, those patients are never seen by that doctor again. They're seen by middle-level practitioners, physician extenders, nurse practitioners, physician's assistants. I don't think that's good medicine. Time constraints in clinical practice is a massive problem. Post-COVID, in revenue recuperation mode, there's pressure on doctors to see more patients in a shorter period of time. This is not a conversation that can be done very rapidly. So when you're going to see your doctor, have your ducks in a row, know what it is that you want to talk about, and if you don't get it talked about in a single visit, don't be afraid to suggest, I'd like to come back on another occasion, Dr. Jones, and I'd like to talk to you more about this. Ageism we've talked about, and then the challenges of the patient with pre-treatment erectile dysfunction. There is a concept, certainly, among prostatectomists that if a man has erectile dysfunction at baseline, we don't really need to do nerve-sparing surgery. In fact, there is literature to suggest that men who have baseline erectile dysfunction are 5 times less likely to get nerve-sparing surgery. Here's the problem. A man who comes in to see me, who's had a diagnosis of prostate cancer for, let's say, the last 6 months, where he's trying to make his decision about what treatment he's going to pursue, his erectile function a year ago may have been perfect. And the diagnosis of cancer and the stress associated with trying to make a decision may in fact have caused his erectile dysfunction, and his immediate pre-prostatectomy or pre-radiation erectile problems may in fact not be his real, true physiology. That his machinery is actually very good, but the decision to save his nerves or not is based on his erection function the week before the operation. Okay? So just be cautious about that. Again, you may hear me say this many times during this conversation today. Make sure that your treating physician is aware of what your interest is in your future sex life. The single patient, the patient who hasn't had a partner in several years, who hasn't had sexual activity with the partner in several years, may still want to have sexual activity with the partner in the future. If you're a single man undergoing prostate cancer therapy, it's imperative that you declare what your interest in your future sex life is. And then the gay patient. I think it's well accepted that these men get short shrift. There is a level of discomfort among treating physicians in talking to a gay man about his sexuality. Realistic expectations? I think you should seriously think about a referral to a sexual medicine physician before your treatment if your future sexual function is very important to you. I accept that there are people who are probably looking at this for whom it's not that important. Discussion of frequency of the major sexual problems, discussion of the time course. One of the most common errors I see in my practice is men coming in who thinking, well, my erection should be fine 6 months after surgery, when in fact that's really an 18 to 24 month time frame. Discussion of ways to minimize long-term effects and discussion of strategies to treat the side effects. They really fall into the realm of a sexual medicine physician. I wouldn't expect any urologic oncologist or radiation oncologist to be facile with those discussions. That's where you benefit from seeing a sexual medicine clinician. So there are a host of sexual dysfunctions that are associated with prostate cancer therapies. Many patients have more than one. Erectile dysfunction, the consistent inability to obtain and or maintain an erection sufficient for satisfactory sexual relations. Interestingly, that's a patient's self-report definition. Okay? It doesn't require you to fail 50% of the time. It doesn't require you to have no erections whatsoever. So you decide if your erectile dysfunction is satisfactory or not. Decreased sex drive. Of course, with prostatectomy, all men are never going to ejaculate again. And what's interesting to me is that 40% of prostatectomy patients, when surveyed after surgery, don't remember ever being told that they will never ejaculate again. The most basic sexual problem after prostatectomy, 40% of men don't remember ever being told. That's not necessarily saying that they weren't told. They may just not have remembered. They may be so focused on get rid of my cancer, doctor, that they don't hear the other topics of conversation during that pre-therapy visit. Difficulty achieving orgasm, reduced orgasmic intensity, orgasmic pain known as dysorgasmia. Sexual incontinence, we have men who were 2 years after prostatectomy, 3 years after radiation, who have very good erectile function, but ejaculate urine every time they have an orgasm. Okay, and that's a very stressful thing in the bedroom scenario for some men. And penile length or volume loss, again, another very distressing sexual dysfunction in this population. So the causes of ED after surgery and after radiation are as follows. There's blood vessel damage. The lining of our blood vessels is called the endothelium. It is a critically important regulator of blood flow into the penis. All right, so damage to those that lining in the blood vessels is a negative thing. Radiation causes that damage, and surgery can cause that damage also. There are blood vessels that travel very close to the prostate called accessory pudendal arteries, which can be damaged at the time of the operation. Nerve injury. That's probably the least important of the three factors in the radiation patient, but in the surgery patient, the maneuvers that the surgeons use to protect those nerves cause nerves to go to sleep. They go to sleep for 9 to 12 months. It takes another 9 to 12 months to wake up fully. That's why erectile functional recovery after radical prostatectomy is an 18 to 24 month time frame. And for the patient who's been told by their surgeon, well, you should be fine in 6 months, Mr. Jones, and it takes longer than that, that's very distressing, and they fall into a sense of hopelessness. Nothing's going to work anymore. They withdraw, and they don't even come to see somebody like me. Radiation therapy effects. The maximum effect on erectile function after radiation is probably in the 3-year mark or even longer. Endarteritis obliterans, that endothelial damage that occurs with radiation, takes very, very long to happen. So about 3 years after radiation is typically where we see men reach their nadir, their low point. But the final common pathway to permanent erectile dysfunction after surgery, after radiation, after hormone therapy is smooth muscle damage. And I love the analogy of your penis is like your biceps, Mr. Jones. If you put your hand around your penis, most of what's inside your penis is a muscle. Think of your arm in a plaster cast for a 12-month period of time. You take the cast off, what happens to your biceps? Oh, it undergoes atrophy, Dr. Mahal. That is absolutely correct, and the same thing happens in the penis if we're not getting erections. The problem with atrophy in the penis is that it's permanent. It cannot be reversed. It indeed is not even atrophy, although we use that phrase all the time in clinic. It is collagenization, deposition of collagen, scar. So the muscle turns from a nice spongy, like a new sponge you bought at Bed Bath & Beyond, day one, absorbs all this water in the bath, and you're using the same sponge every day for a year, and it turns into a gnarly, hard sponge. That's what happens to erectile tissue when erections are not happening. You don't use it, you lose it concept, for sure. And that's the final common pathway to permanent ED, and men with significant muscle damage generally fail to respond to the Viagra drugs and frequently don't respond even to penis injections. So erectile function preservation, as physicians, as surgeons, how can we preserve a person's erectile function? So nerve sparing, right? Now let me make a comment on nerve sparing. The maneuvers that the surgeons use to protect the nerves cause them to go to sleep. So it's routine that even when the nerves were perfectly preserved, that they actually have some level of trauma. When the trauma is mild, they recover. It's called neuropraxia, and those nerves recover over a kind of 18 to 24-month time period. Historically, surgeons will say to you, well, both nerves were saved, bilateral nerve sparing, one nerve was saved, unilateral nerve sparing, or there was no nerve saved, non-nerve sparing. And that really doesn't hold a lot of water in the modern era because nerve sparing is said to be incremental. There are grades of nerve sparing, depending on which layer of tissue the surgeon is operating in. The surgeon, if they do prostatectomies for a living, should know whether the nerves were saved or not. And it's perfectly reasonable for you to speak to the surgeon before surgery and definitely after surgery. I work at an institution that collects huge amounts of data, and we have our own grading system. 1, the nerves are perfectly preserved, 2, mild damage, 3, moderate damage, 4, the nerve is gone. Erectile functional recovery is very intricately related to the level of nerve sparing. The better the degree of nerve sparing, the better the erectile functional recovery after radical prostatectomy. Preoperative erectile function. The better your erectile function going into surgery, radical prostatectomy, going into radiation therapy, the better your outcomes are going to be, for sure. If your erectile function is poor, that portends a poor prognosis after your treatment. Now, when a patient comes in to see me, as I've alluded to already, I always ask them about their erectile function before their diagnosis of cancer. Because that is, although there's recall bias, got to remember a year ago, let's say, that's much more important to me than what your erectile function is now, because we know, again, the stress level associated with the diagnosis of cancer and the decision making about which treatment to pursue causes erection problems. Patient age. The older a person is, the less likely they are to do well after surgery. And generally speaking, if you're below 60 years of age, you have good erectile function before surgery, and you have bilateral nerve sparing, high-grade nerve sparing on both sides, the chances of you being a Viagra drug responder at 2 years after surgery is very, very high. The chances of you being a pill responder in the first few months after surgery is very low. Why? Because those nerves are asleep from the trauma of the manipulation that occurs during the operation. Physician experience and physician volume are very, very important. There's good medical evidence to show that that's absolutely true. Okay? If you've had 3 years of experience versus 30 years of experience, if you do 10 a year versus 100 a year, these are factors that play into your long-term outcomes. It is not unreasonable, in my opinion, for you to say to a surgeon, by the way, whatever operation you're having done, these are true. How many of these do you do a year? How long have you been doing this, Dr. Jones? Medical conditions. There are several medical conditions that if you have them are going to make your outcomes worse, whether it's surgery or whether it's radiation therapy. Diabetes is top of the list, obstructive sleep apnea, and very low levels of testosterone. So at Memorial Sloan Kettering, we now routinely measure testosterone levels before surgery. All right? So we know whether the person is starting off with a low testosterone level. Why is testosterone important? Testosterone, would you believe or not, actually is involved in the nerve recovery. If you have very low levels of testosterone, the erection tissue, that muscle gets damaged, but also the nerves fail to recover in an expeditious fashion. Diabetes is bad for nerves. That's why men with diabetes often have a nerve damage in their hands or feet or their bladder or their bowel. Okay? And sleep apnea is a very interesting condition. During sleep apnea, the partners are looking, they say, oh, he snores terribly, right? So if you're male, if you're over 50 years of age, you have a neck size over 17 inches, if you snore at night, you're at high risk for obstructive sleep apnea. The problem with sleep apnea is there's fragmentation of sleep. You don't go into REM sleep at night because you're essentially asphyxiating yourself. And that alone hurts erectile tissue. Remember, the average man gets 3 to 6 erections every night of his life from the time he goes through puberty, and the purpose of those nocturnal erections is to protect that muscle inside the penis. The absence of those, whether it be post-prostatectomy or a 10-year history of obstructive sleep apnea, puts you in a danger category. So these 3 medical conditions, diabetes, sleep apnea, and very low levels of testosterone, put you at increased risk for long-term sexual dysfunction. If you have androgen deprivation therapy, Relogolix, Lupron, Degarelix, all of these drugs that have been used for decades in the management of prostate cancer patients in association with radiation or as a treatment for advanced disease, androgen deprivation therapy deprives us of our testosterone. I've already told you, very low levels of testosterone are bad for erectile tissue health. And I've already alluded to the pre-treatment testosterone levels. So if you have a radical prostatectomy, there's some things to remember. Number one, it has an immediate effect on erectile dysfunction. ED stands for erectile dysfunction. So immediate effect. Have an operation on Tuesday, had sexual activity on a Monday night, Wednesday you'll have no erections. That is the vast majority of patients. 85% of patients at Memorial Sloan Kettering Cancer Center within the first 3 months of radical prostatectomy fail to respond to a PD-5 inhibitor drug. Viagra, Levitra, Cialis, and Stendra. Why? Because those drugs need the nerves to function, and as the nerves, as I said already, go to sleep for a period of time, the pills, it's almost impossible for those pills to do well, and that's where penile injection therapy comes in as a rehabilitation strategy, which we'll talk about in a little bit. The low point in erectile function after radical prostatectomy is about 3 to 4 months after surgery. It's very common that men come in to see me and say, well, I had an erection the day after the catheter came out, but now I'm not functioning 4 months later. And if you have an erection, let's say post-op day 10, that's very encouraging. You can imply from that that the nerves are well saved. And what happens is the swelling and the scarring that occur around those nerves after surgery cause those nerves to go into a state of dysfunction, and the same pattern, 9 to 12 months for recovery, really 18 to 24 months for maximum optimal recovery of those nerves. 20% of men get back to baseline, BTB, back to baseline. I'm the same rigidity after surgery as I was before surgery. But if you look at men who are over 60 years of age, that figure is only 5% of men get back to their baseline function without having to use medications. So if you're 65 years of age, it is extremely unlikely that you're going to get back to the same level of rigidity after surgery that you had before. Doctor, I didn't need to use any pills before the operation. Now, without pills, no erections in the bedroom. I cannot have sexual intercourse. That figure is about 15% if those men use a Viagra-type drug. So 15% of men over 60 years of age get back to baseline by using medications. In young men, that figure is as high as 60% if they're using medication. Recovery, as I've mentioned before, patient age, erectile function before surgery, and the degree of nerve sparing. And we'll talk about rehabilitation as a concept in a little bit. What about ejaculation? The ejaculation apparatus is removed at the time of radical prostatectomy. The prostate, which contributes about 20% of semen, the seminal vesicles, about 75% of semen, and only 5% of semen is actually sperm. And there is a radical vasectomy done behind the prostate. So the ejaculatory apparatus is gone. And this is why men fail to ejaculate after radical prostatectomy. If you come in to see me after surgery and say, no, doctor, there's clearly fluid coming out of my penis. If it's watery, it's almost certainly urine, and we'll talk about sexual incontinence in a minute. If it's clear, sticky fluid, what's more vernacularly called pre-cum, it's just secretions from the glands in the urethra, the urine channel, and it is not a true ejaculate. If you happen to be a man for whom reproductive health, fertility is of interest to you, going forward, you need to declare that to your surgeon before surgery. It's not uncommon for me to have to do sperm extraction after prostatectomy because the man had no idea that he would not be able to ejaculate and father children in the future. Typically what we would suggest you do in that scenario is bank sperm before your radical prostatectomy. Orgasmic pain is not that common. It's about 15% of men. The most significant consideration here is that men think that they're doing damage to themselves. They get orgasmic pain, tip of their penis, in the testicles, lower abdomen, perianal area, in and around the time of orgasm. That may last seconds, but sometimes last hours. It's usually of a nuisance value on a pain scale from 0 to 10, where 10 is the worst. There may be a 3 and a 10-point scale. But we do have men who have crippling pain after orgasm. This is a muscle spasm phenomenon, believed to be, and it is responsive to alpha blocker drugs like tamsulosin or alfuzosin. And that's something that if you have it, first of all, you don't need to worry that you're doing damage to yourself, but you should bring this up to your doctor. Sexual incontinence, leaking urine during sexual activity. There are two kinds. One is called climacturia, leakage of urine at the time of climax. This occurs in about 60% of men on at least one occasion after radical prostatectomy, and about 20% of men consistently throughout the first year. So it's not uncommon at all. For many men, it's very distressing. For many partners, it's very distressing. We tell men when they come to see me pre-prostatectomy, I say, these are the figures. 60% of men will experience this problem on at least one occasion. If it's going to happen at all, it's most probably going to happen in the first half dozen orgasms after radical prostatectomy. If it doesn't happen under those circumstances, it's unlikely to happen in the future. Avoid oral sex, towel on the bed, sexual activity in the shower to avoid this being a problem in the bedroom. Arousal incontinence is very different. There are three things that worsen a man's daytime continence. One is fatigue, not that he feels tired, but the muscles in the pelvis, your Kegel exercise muscles, those muscles get fatigued and can't control urine leak as much. Alcohol relaxes the pelvic floor and men leak more when they've had some alcohol on board. And then sexual activity, not even activity, just thinking about a sexual scenario. Men will say to me, my wife just gives me a massage, or she touches me, or she intimates that she'd like to make love, and I start leaking urine. That's called arousal incontinence. Penile length loss, or penile volume loss, more correctly stated, 70% of men have documentable penile length loss after radical prostatectomy. It averages about 1 centimeter. Now, what happens to the nerves when they get traumatized is they cause that muscle to go into a state of contraction. The penis becomes hypercontractile. So in the early stages after surgery, it's very common that men come in to see me and say, what happened to my penis? It's being brought back into my body. I'm circumcised at birth, but I look uncircumcised now. That's a hypercontractility phenomenon, which is not permanent. However, when men go long periods of time without having good erections, that muscle degenerates, right? That atrophy, biceps and the penis muscle, arm in a plaster cast for a year, that undergoes degeneration, and that can lead to permanent length loss. It's not uncommon for a man to come in and see me and say, well, my surgeon says my prostate was this long and therefore my penis is going to be that much shorter. That is untrue. The urethra is fixed inside the pelvis at a layer of muscle called the urodental diaphragm. So we don't pull the penis in, we actually pull the bladder down to the urethra. Okay? So this is early on temporary and resolvable, but in the long term, if you're not able to get erections regularly, if you're not doing rehabilitation, this becomes a significant consideration. What's interesting is there are 2 papers in the literature that suggest that regular use of these PDE5 inhibitor drugs, Viagra, Levitra, Cialis, and Stendra, are protective of erectile tissue. What about with radiation? There's no clear data showing that one radiation modality is better than another. I think all modern therapies, whether it be brachytherapy or external beam, whether it be proton therapy, are really more focused than they were 10 or 20 years ago. The problem in the literature is that you've got the proton centers comparing their data, and you've got the brachytherapy centers doing their data, and the external beam people writing up papers on their data. And there's no good comparative studies that really show this. So I don't spend a lot of time talking to patients about what modality of radiation therapy are they going to get. Interestingly, there's a honeymoon effect in most men after radiation, where for the first 12 months, at least in men who've had good erectile function before radiation, at least in those men, there's very little negative effects of radiation on their erectile function. If they have erectile dysfunction or sexual problems in the first year, it's either, most probably, psychologically based, or if they have been exposed to androgen deprivation therapy, they will see problems early on. The nadir is beyond 3 years after completion of the radiation for the reasons that I discussed earlier on in this talk. Recovery of erectile function, or probably more correctly stated, preservation of erectile function after radiation, is related to patient age, baseline erectile function, dose of radiation, and whether androgen deprivation therapy was used or not. I think the literature is fairly clear now that there is a negative effect of radiation, of androgen deprivation therapy, on erectile function if used. Certainly if in older men over 65 years of age, and certainly if for longer than 4 months duration of androgen deprivation. Patients come in to see me not infrequently before they've had treatment. I've met a radiation oncologist, I've met a prostatectomist. What should I do, Dr. Mulhall? The first statement out of my mouth is, I'm not a cancer doctor, Mr. Jones. You have to make that decision in association with your cancer doctors. But I do tell them this statement, that the erectile dysfunction rates after radical prostatectomy and radiation therapy approximately 3 years after intervention are about the same, provided you have good nerve sparing, and we're comparing that data to radiation as monotherapy, as a single therapy. If you have poor nerve sparing, that's a problem. If you have radiation therapy and you have a double up of radiation, which is basically seed placement first with external beam after, that's very high dose. Those erectile dysfunction rates are higher. And likewise when androgen deprivation therapy has been included. So it actually is very difficult to compare the two. They're a bit like apples and oranges. But essentially, good nerve sparing, radiation monotherapy, there is no difference in erectile dysfunction rates 3+ years after intervention. After radiation, interestingly, and almost no patients know this, 90% of men, a period of 5 years after radiation therapy, have no semen. That the radiation effects on the prostate, on the ejaculation ducts is such that they too also no longer ejaculate, just like every man who has a radical prostatectomy. There's very little evidence on orgasmic function after radiation therapy. And there's no data on sexual incontinence and penile length loss or volume loss in this population. What about androgen deprivation therapy? So I understand that this is critical in the care of many men with prostate cancer. Okay? The problem with having no testosterone, this is not just my testosterone level is low. This is basically I have no testosterone. I have undetectable testosterone levels, particularly with the newer agents, which are so effective at reducing testosterone. And it causes this erectile tissue degeneration, this atrophy, this collagen deposition, which again, as I said before, is permanent. Permanent ED appears to be associated with the use of ADT, for any reason, for longer than 6 months. The other issue to be aware of is that not every man who is exposed to androgen deprivation therapy will have recovery to normal levels of testosterone. The predictors of that phenomenon, where men are left with low testosterone long term, are men over 65 years of age, having a low baseline testosterone before hormone therapy, and more than 6 months of hormone therapy. The problem with the erectile tissue degeneration is it leads to the inability to respond to drugs like Viagra, Levitra, Cialis, and Stendra. If you have no testosterone, you cannot make semen. Even if you have an orgasm, you will not be able to produce semen. Semen is an androgen, testosterone-dependent activity. If you look at men who are actively on hormone therapy or who have very low levels of testosterone after hormone therapy has been ceased, those men really struggle with having an orgasm. More than 90% of those men fail to achieve an orgasm, or anorgasmic. Sex drive, likewise, more than 90% of men, while actively on hormone therapy, fail to have any significant sex drive. Now, sex drive is a very interesting thing to talk about as a sexual medicine physician, because sex drive comes in two fashions. Number one is called visceral sex drive, right? That is testosterone dependent for nearly every man. I see an erotic image, I think of something erotic, and I get aroused, and I want to have sexual activity. That's visceral. If you have no testosterone for 90+% of men, they do not have any sex drive. On a 0 to 10 point sex drive scale, where 10 is I can't stop thinking about sex, and 0 is I never think about it, what number are you, Mr. Jones? Oh, I'm a 0 to a 1, doctor. Intellectual sex drive is entirely different. I love my partner, we used to have great sex, I want to have sex. That's intellectual. That is testosterone independent. So there are many men who have an absence of visceral sex drive while on hormone therapy who actually have retention of intellectual sex drive. Penile length loss, if the muscle degenerates, that is the bulk of the erectile tissue. I told you when a man puts his hand around his penis, most of what's inside his hand is a muscle. When that muscle degenerates, there is length and volume loss, and that is most certainly associated with androgen deprivation therapy, especially when it's more than 6 months in duration. I'm going to make some declarative statements, and I'll talk to you about what I mean over the next few slides, and this, I hope, will help you in your understanding of what you need to do before your treatment to get the best sexual function, recovery, or preservation. We're in a phase now where we have what I call obsessive oncocentricity. Oncocentricity is the absolute focus on cancer outcomes. In prostate cancer, of course, it'll be your PSA, prostate-specific antigen, okay? But we cannot just, akin to what John Hewlings Jackson said, that quotation I used at the beginning of the lecture, we cannot just focus on the PSA when perhaps to the individual patient or couple, their sexual activity or their continence, their quality of life may be critically important. You think that your treating clinician will tell you all that you need to hear, when in fact, the physician will tell you what they think you need to hear. So if your sexual function is really important to you, it would be very important for you to go in there and declare that that's the case. It would be very important for you to make a list of the questions you want answered by that physician. If that physician doesn't have the expertise to answer those questions, seek a consultation with somebody who does. And if you don't get all of your questions answered, I would go back on another occasion and have those questions answered. I have many men who see me twice before their prostatectomy or their radiation. You mentioned something the first day, Dr. Mulhall. I want to ask some more questions about that. Just be cognizant that physicians are under tremendous time crunches. So go in with good questions written out on a notepad so you know what you're going to ask. And if you don't get them asked, go back on another occasion. Don't be afraid to ask why active surveillance is not an option for you. For many, many years, Gleason 6 cancer, Gleason 3+3 on biopsies, we had a radical prostatectomy or radiation. We now rarely operate on those patients because we know that nearly all of those patients survive and do very well on active surveillance protocols. So I think it's very reasonable if you have Gleason 6 cancer, even if you have Gleason 3+4, perhaps not so much Gleason 4+3, but in those categories, it's not unreasonable for you to say to the doctor, would active surveillance be an option for me? Before committing to a treatment, think seriously about how important your future sex life is. If you're a single man, that's a decision that only you can make. But if you're in a couple, I think that's important to have that discussion. I have many men who come in to see me post-prostatectomy who really don't understand or know what their partner's attitude is to sexual activity going forward. They've been married for 35 years and they've never spoken about their sex life. That is routine. We have a phrase in my practice, patient will go home and have the talk, in quotations, with his partner to try to find what their future interest is, their future goals and aspirations, and what kind of sexual activity they're interested in. I have many couples who have fantastic sex life and only have sexual intercourse, non-intercourse based sexual relations. That's fine for many people, but for some people it is not. So it's very worthwhile as a team sitting down and talking about this in a casual and non-confrontational fashion. Understand what your treating physician means by erectile function preservation or recovery. There are lots of different definitions. The definition, as I mentioned earlier, for erectile dysfunction is the consistent absence of being able to get or keep an erection. Both of those two things. Consistent, which means usually for a few months, right? Nowhere in that definition does it state with the use of Viagra or with the use of penis injections. But much of the literature, including some prostatectomy studies that suggest, for example, that 97% of men have really good erections after surgery, don't tell you that those patients were the youngest patients, the best nerve-sparing patients, and who were on pills or injection therapy to get those good erections. So make sure you're clear what your individual physician means by erection function recovery. I would say to you that let's say, for example, you've decent erections 1 out of every 10 times, and 9 out of 10 times you're unable to have intercourse, you're not going to be happy if intercourse is important to you. So consistency of response is also important, not just rigidity, not just sustaining capability, but the consistency of your erections in a sexual scenario. Get realistic expectations about the time frame. I've already alluded to 3 years after radiation and 18 to 24 months after radical prostatectomy. Talk to your physicians about that. This is Memorial Sloan Kettering data. On the x-axis on the bottom there is time, months from radical prostatectomy. On the left side, recovery of erection function good enough for intercourse without the use of a medication. And you can see that it continues to improve out to 24 months. So it'll be 2 years after surgery for the vast majority of men before I'll say to them, Mr. Jones, this is as good as it's going to get. This is erectile functional recovery after radiation. On the x-axis, you see different time points. 12 months after radiation, 24 months after radiation, and 36 months. And the white bars are the entire group. And the gray bar there, it's the group of men who had radiation therapy without hormone therapy. And the black bar is the men who got radiation with hormone therapy. And you can see out to 3 years, there's a steady decline in erectile function. This is with the use of a PD5 inhibitor. And you can see those men who have hormone therapy tend to do more poorly than those men who don't. I am never going to interject and say you shouldn't have hormone therapy. That's a cancer doctor's decision, not mine. Beware physicians citing incredible figures for erectile function recovery or preservation. You need to look at the literature as it exists at the moment with a slightly jaundiced eye, in the sense that single center, single surgeon, or single radiation therapy outcome papers, literature, is much better than those papers where there's multi-center, older men, the Medicare series, the SEER Medicare database. Those outcomes are always much worse than the single surgeon, single center series. I'll give you an example. A famous surgeon has done 2,500 radical prostatectomies, and the paper only has 250 of them, right? Often what happens is there's cherry picking done when data is being analyzed. The youngest men, the best nerve sparing, the best erectile function before surgery are those who are presented in the paper. And of course, those numbers are always going to be better than the older man who had slightly poor erections before surgery and had less than perfect nerve sparing. This is called a systematic review, which basically means the data is heavily statistically analyzed. And the red boxes around erectile function recovery 2 years after surgery in the literature with the use of a medication. And you can see that this is about 55 to 60% of men, which is a very reasonable estimate for men's ability to have intercourse after radical prostatectomy. But that means that there's 40% of men who will be incapable of having intercourse in the long term, even with the use of a PDE5 inhibitor medication. Back to baseline, I already alluded to it. On the left-hand side, you've got age, less than 60 years of age or 60 years of age or greater. And then the next column is using PDE5 inhibitors at 24 months to get back to baseline. And you can see that almost 1/2 of men under 60 years of age can get back to baseline using pills. And that figures about 16% of men who are over 60 years of age. If you go to the far right-hand column, not using any pills at 24 months to get back to baseline, that figures about 1 in 4 men under 60 years of age and about 4% of men who are over 60 years of age. So for the 65-year-old man coming into radical prostatectomy who sees me before surgery, I communicate very clearly. It is not likely that you will ever get back to baseline. And of course, when the surgeon comes out after surgery and says, Mrs. Jones, everything went great, what do patients think? I'll never be incontinent, my erections will be great, and my PSA will never recur. Okay? Back to baseline is very difficult to accomplish. If you have ED before treatment and sexual intercourse is important, it is essential that you communicate. It's important to the treating physician. When I see patients before surgery, or even before radiation, but to the surgery patients, I always say the same thing. The morning of your operation, the day of your operation, when the surgeon comes to see you before the operation, don't be afraid to reiterate, to mention again that, you know, doctor, my sexual function is critically important to myself and my partner, right? Very, very important. Or even if you're single, if it's very important to you, okay? Making that declaration before the surgeon goes back and sees you, might have been a month or 2 months before since the surgeon has seen you last. Don't be afraid to declare that again. Open versus robotic radical prostatectomy. So I think I'm correct in saying that in 2003, almost no prostatectomies were done using the robot. And now the overwhelming majority of prostatectomies are done using the robot. In fact, there are urologists in training, urology residency programs where the young surgeons never see an open prostatectomy anymore. The bottom line is, there really is no evidence to show that using the robot, that sexual function, urinary function, or cancer outcomes are any different, although it's $4,000 extra per operation. Saying that, the young surgeons will be trained only in the robot, and it's almost certainly the only thing that's going to be available to you. Physician experience is key to success. We mentioned this already. This is data from Memorial Sloan Kettering Cancer Center. This is Andrew Vickers and James Easom's data. On the x-axis is surgeon experience, lifetime experience as the primary surgeon with radical prostatectomy. On the left-hand side, the 5-year probability of being free from biochemical recurrence at PSA elevation. There are slides we could put up showing incontinence or erectile function on the left-hand side, and it's always the same. There's a learning curve involved in this. This is very interesting, complicated slide, but let me break it down for you. On the x-axis, the probability of having leakage of urine, incontinence, 12 months. On the y-axis, probability of having erectile problems. The circles are the lifetime experience. The bigger the circle, the greater the lifetime experience of the surgeons at Memorial Sloan Kettering Cancer Center. So intuitively, you would think that those surgeons who've been longer in practice with the greatest lifetime experience are going to be in the top right-hand corner of the graph, and the ones with the least experience are going to be in the bottom left. And that's not the case. This heterogeneity was quite surprising to us when we saw this. And the bottom line is that surgeons either do a good radical prostatectomy or they don't. Sometimes not completely directly related to their experience or the volume that they do. Okay? So you can see on this graphic there are some very tiny circles top right and some big circles at the bottom left. So choose wisely, and that's a difficult challenge for you. How do you know what kind of surgeon you should choose? I will tell you, almost certainly, listening to your primary care physician about which surgeon you should have your prostatectomy with is probably not the best way to choose. Almost certainly that PCP has never been in the operating room with the surgeon. The surgeon might be a good communicator, might be a nice person, might be humble, might be honest, sure. But the technical expertise is something that you really need to think about more carefully, and that's very difficult for you to figure out. Penile rehabilitation is the concept, whether you're a prostatectomy or a radiation patient, where we can do things to keep that muscle healthy while we're waiting for the nerves to recover from the trauma of surgery. Okay? So we talked about the arm in a plaster cast and the biceps atrophy and how atrophy in the penis is permanent. We can prevent that atrophy to a large extent after prostatectomy and to an extent in radiation patients by doing penile rehabilitation. Now, there are plenty of people in urology who will say, well, penile rehabilitation, show me the evidence that that actually works. Level 1 evidence-based medicine, large randomized placebo-controlled trials, which of course is the gold standard in proving that something is effective or safe, right? They just don't exist. There are 3 papers in the literature, all industry-sponsored, one showing a benefit to rehab and 2 showing no benefit, although there are all kinds of problems in the latter 2 studies. Now, I am probably the world's most avid penile rehabilitation specialist. So you have to bear that in mind as I say what I'm saying, but I would consider that if your future sex life is important to you, and if you don't want to go the rest of your life incapable of having sexual intercourse, why wouldn't you do penile rehabilitation after your prostatectomy or after radiation? Because the cornerstone of rehabilitation is just regular use of Viagra-type drugs, right? And if you're responding to those drugs, if you're getting a penetration hardness erection, that's all you need to do. As I mentioned earlier, they're just generally very, very cheap now. It used to be $60 for 100 milligrams of Viagra. Now you can get 100 milligrams for probably less than $2. Okay? Likewise after radiation. Why wouldn't you do penile rehabilitation to maximize your erectile function preservation? In men who don't respond to these pills in the early stages after surgery, which I already told you is about 85%, those men are faced with a decision about doing penis injection therapy to protect the muscle. I don't care if you've sex, Mr. Jones, or not. I don't care if you've an orgasm, but I do care. Blood flow, oxygen into your penis, and stretch of that muscle, which is what nocturnal, nighttime or early morning erections do for erectile tissue. There's no clear difference in sexual outcomes between the different radiation therapy modalities. I've already mentioned this. There's no clear evidence to show one is better than another, provided you're comparing radiation monotherapy from center to center to center. ADT is unfortunately the most penis-threatening thing you can be exposed to. I don't interfere with cancer care, but I do say to patients, why don't you speak to your doctor about what the survival benefit is? Now, this is very important when we get patients who are having radiation therapy, for example, and they're getting adjunctive hormone therapy, androgen deprivation therapy. And there's a discussion about whether that should be 6, 12, 18, or 24 months. That's where this concept of speaking to your doctor and asking them about the survival benefit of different durations of ADT. Remember, I told you that durations beyond 6 months are very challenging for erectile tissue and generally lead to erectile tissue collagen deposition, scarring, which generally leads to dependence upon penile injection therapy. When we see patients who've had triple therapy, surgery, radiation therapy, and hormone therapy, less than 5% of patients ever respond to a pill. And most of those patients need injections, and 50% of them will never respond to injections if they have triple therapy. Now, it's not zero, but it's only 1 in 2 chance if you've had triple therapy. If you need androgen deprivation therapy, don't be afraid to ask about how long does the doctor think you'll be testosterone deficient. So let's say you're on 6 months of Lupron and Lupron stops. It takes a while for it to wash out, okay? A few months for it to go away completely. And if you're 70 years of age, it might take you 1 to 2 years to get a normal testosterone level back, which essentially means you'll have spent 2 to 3 years being profoundly hormone deficient. The problem with no testosterone is it's well established. It's associated with osteoporosis, diabetes or worsening diabetes, worsening sugar control if you already have diabetes, and premature cardiovascular events, heart attacks and strokes. Now, I'm not talking about low testosterone. I'm talking about extremely low testosterone or no testosterone. So there are some problems with being left permanently testosterone deficient. If you're prescribed PDE5 inhibitors, Viagra, Levitra, Cialis, or Stendra, you should really get instructions on how to use them properly. It's still remarkable 20 plus years after these drugs were introduced, where men walk into my office and they're not using the drugs properly, and they're failing, in quotations, failing, but they haven't really failed. And there's very good literature to suggest that at least 1 in 3 men who walk into the office of a urologist having been prescribed a PDE5 inhibitor by a non-urologist, and they say it doesn't work, they've actually not used it properly. So Viagra, which is sildenafil, Levitra, which is vardenafil, and Stendra, which is avanafil, they are short-acting PDE5 inhibitors. Peak levels is about 1 to 2 hours after ingestion. An empty stomach is ideal. If you take these pills, and these pills are in your stomach at the same time as food or alcohol, you're going to drop the dose by about 30%, and you double the time it takes for those medications to get absorbed. Sexual stimulation is required. I tell our patients that who are using, let's say, Viagra, Levitra, or Stendra, I say, dinner at 7, take the medication at 5. The pill will be in and out of your stomach before food or alcohol go in there, and you have a 6 to 8 hour window. You're good till around midnight, Mr. Jones. That's the way to remember how to use those pills. If you're using these pills and they're not working, but you're not doing each of those things, empty stomach, sexual stimulation, and the duration of activity, then it's worthwhile going back and trying them again. Viagra, Levitra, an 8 to 10 hour window, and Stendra is about a 6 hour window, a window of opportunity where the drug is active. Side effects are the same for all 3 drugs: headache, flushing, congestion, nasal congestion, heartburn, and visual effects. 15% of men at maximum dose get headache, 10% get facial flushing, 7% get heartburn, 4% get nasal congestion, and 2% get visual disturbances. Blurred vision, double vision, or this loss of color vision. It happens to cross-react with an enzyme in the retina. That's not a major concern, okay? All of these side effects are usually mild. It's less than 3% of men who drop out of our PDE5 inhibitor program because of side effects. If you happen to have retinal disorders such as macular degeneration or retinitis pigmentosa, I am going to require you to have ophthalmological clearance from your eye doctor before you will use these pills. What about Cialis, which is tadalafil? Well, there's no food effect. There's no food impact on Cialis. However, it's a much more slowly absorbed drug, but it's a much longer lasting drug. This is a drug which typically takes about 4 hours to have its maximum effect, but it'll hang around for at least 24, if not 36 hours for individual patients. The side effects for tadalafil are the same as the other ones, except it's got a lower instance of visual side effects, but it has a different side effect of what are called myalgias, muscle aches. So long are these drugs in the system that the large muscles, the blood gets stagnant in those muscles, and there's muscle aches in the butt, in the thighs, or in the lower back. Penile injection therapy sounds awful, but it's the best drug therapy you have for ED. And I always say to patients the same thing. Never base your decision about penis injections on the mental imagery. I would like you to come in and try an injection, Mr. Jones, and if that day, injections, you say, now I know I can't do it, that's an informed decision. But it's a 29 gauge needle, mosquito bite, placed into the middle of the shaft. In my program, the average man gets an erection within 5 to 10 minutes, and that erection is lasting 30 to 40 minutes, and the average man is getting an 80% erection, okay? If you come to see me within 6 months of your radical prostatectomy, you have a 92% chance of being an injection therapy responder. So it's a very, very effective, very safe form of therapy. The only risk with penile injections is the risk of getting priapism. From TV, erections lasting longer than 4 hours, call your doctor. That's called priapism. The problem with priapism is that it deprives the penis of oxygen. And very much like a heart attack, where a blood vessel is blocked and the muscle is getting no oxygen, in the penis, the muscle is getting no oxygen. And this is an absolute urological emergency. In my practice, at 2 hours, they take 120 milligrams of Sudafed. At 3 hours, they're calling us. And at 4 hours, they need to be in the emergency room. That is the protocol for priapism prevention in our practice. And priapism rates in our practice are 0.2%, directly related to the level of education and monitoring of patients in the injection program. Triple therapy, surgery, radiation, hormone therapy, whatever order they occur in, doesn't necessarily mean that your sex life is over. I already told you that although the muscle degenerates, 50% of men who have had triple therapy are good penile injection responders. Remember, your ability to make PSA is dependent upon your testosterone level. So the PSA, the enzyme, prostate-specific antigen, is dependent on testosterone. If you don't have enough testosterone, you may not be able to generate PSA. Now, this is very important in men, let's say, who come in after radical prostatectomy and they're, let's say, 6 months after prostatectomy and their PSA is non-detectable, as it should be, but their testosterone level is incredibly low. There's a new movement in place for intramuscular testosterone challenge. Give the man testosterone. Let's see what happens with his PSA. Testosterone level will go up 5 days later. If his PSA doesn't change, then that patient may well be a very good candidate for testosterone therapy. If the PSA changes, that becomes a cancer discussion with the doctors who look after that patient. My testosterone level is low. I have symptoms. Can I receive testosterone therapy? The American Urological Association guidelines on testosterone therapy, of which I'm the chairperson, state very categorically, there is yet not enough evidence to show that testosterone therapy is safe, and I would extrapolate that, or dangerous, in the radical prostatectomy, active surveillance patient, or the patient who had radiation therapy for their prostate cancer. You probably need tens of thousands of men followed for 15 years to really answer that question. But I will tell you, our data at Memorial Sloan Kettering are surprisingly clean. That men with organ-confined Gleason 6, Gleason 7 cancer, there's no increased risk of prostate cancer recurrence in those patients. Our active surveillance patients likewise, and we're still accumulating our radiation therapy patients on that front. Beware of false advertising regarding restorative therapies. This is a hot subject now, especially in metropolitan areas, where restorative therapies such as shockwave therapy, stem cell therapy, or platelet-rich plasma are being put forward as a treatment for erectile dysfunction, including in the prostate cancer patients. I'll bottom line this for you. There is no credible evidence to show that these drugs are of any significant benefit, these therapies are of any significant benefit in the prostate cancer patient. There's no evidence to suggest that there are any harm, perhaps other than to your wallet, because these are all cash therapies, and there's a tremendous conflict of interest here. You go see a physician. Many physicians who advertise and administer these therapies are not actually even urologists. There are other kinds of physicians, anti-aging physicians, who are tagging on these therapies in a package for you, right? Cash business, conflict of interest, right? I think it's very unlikely you're going to get a balanced discussion from those physicians when they're pitching these therapies to you. Words of advice for the partner. I see many, many partners. In fact, I'm more likely to see partners in my practice of the men who've got prostate cancer than the men who don't have prostate cancer. And so I think be supportive as best as you can. Never emasculate your man. And don't be afraid, just like the man needs to be proactive, whether the partner is female or male. Okay? Be proactive in your concerns and your discussions with the man who has prostate cancer. And don't be afraid to broach the subject. Perhaps we should go see somebody who specializes in this condition and will get you fixed. And finally, let us not focus solely on adding years to life, but also pay attention to adding life to years. This is a survivorship concept, and we shouldn't be focused entirely on a man's PSA. We should be looking at the whole patient. And with that, thank you very much.
Hello, how are you, my friend? 25 years we've had a relationship.
It's My pleasure to be here.
Really? Is it because I'm here with you?
100%.
That's the perfect answer. We have a lot to cover. First of all, I'm not trying to be obsequious here. You've done this talk many times. That will end up being the most informative talk for patients, in my opinion, on the subject. Well done, sir.
I hope so. I hope so. Thank you.
Absolutely. This is the equivalent in your world of winning the Rugby World Championship. Does that help?
It would be great if Ireland won it, yeah.
Does Ireland have any chance of winning it?
Number 1 in the world.
All right, I want to bring up a slide for you to take a look at.
Sure.
That's my dog.
Grazie.
Yeah, see, very attentive, very excited you're here. And so I wanted to have a little levity before we go into something which I hope is the only slide that is 100% serious the rest of the way, because it's always fun having a little levity with you.
Mm-hmm.
All right, I didn't want to do this, but before I pull up the next slide, I did not want to do this, but I thought I've known you such a long time that I think it's important for the audience that we talk about this because it threw me for a loop, and I want to just see how this relates to everything that's going on. Now, when it says, "How are you, my BFF?" When I talked to you on the phone and you told me you were going through a health situation, that's all I heard. I didn't want to hear anything else about life. So can you please tell our audience where you've been and where you're going and why this is a big deal?
As I said to you on the phone, this is a very eventful summer. I was diagnosed with a brain tumor probably 3 months ago, relatively asymptomatic, picked up on an incidental MRI. And it's inside one of the fluid-filled spaces in my brain, the lateral ventricle.
Uh-huh.
But I had unilateral hydrocephalus from that. It'd been there a while.
And what's unilateral hydrocephalus mean?
So the fluid-filled spaces just get bigger and bigger. So there was a shift of the brain from the fluid accumulation. And I was asymptomatic. And
Asymptomatic.
the likelihood, they told me, was that it was benign. And of course, I'm a surgeon, so everything was focused on let's pick the right surgeon, let's do the right operation, let's get it done. But how it relates to the talk today is that there was a tremendous emotional component after surgery. Everything great, it was a benign tumor, fully resected, no further treatment required. However, there was that, oh my God, I had a brain tumor. So when I put up the slide saying cancer is scary, even to a surgeon, it's scary. So, I think, relate even better now. I'm 26 years in practice. I think I can relate better now to my patients in understanding, that fear factor that strikes them upon the diagnosis.
So this was just 3 months ago?
Yeah. My modeling career is over.
No, your modeling career is fine.
With the scalp incision, but yeah. So it really hit hard after. Not so much before, but after, for sure, yeah.
No symptoms, incidental MRI. And how much time did you take off after the surgery?
6 weeks.
That's it?
Yeah, and I was bored for the last 2 weeks, so it was.
You were?
Yes. You know me.
I think, but I do know you, but I also think, and I've known a lot of people who have run into this situation who are friends. And it always seems like there's one of two responses. Oh my gosh, I'm done with medicine. I'm gonna go sail the world. I'm gonna go find some other calling. There's only so much life left. The other response is, I'm more dedicated than ever to doing what I wanna do. Sounds like your response was the latter.
Well, first of all, it was a benign tumor, right? So if
I know, but some of these benign tumors can grow and be a problem.
Well, obviously I had...
The word benign tumor as an oxymoron, right? It's just funny.
Listen, if it had been glioblastoma multiforme, of course I would have traveled the world and et cetera, but it wasn't. So we just, we're all faced with these challenges. We get on with it and move on. And, I'm 61 years of age. I have 25-year-olds in my practice at Memorial Sloan Kettering Cancer Center who have less than 3 years to live from some rare cancer.
Yeah.
So, it gives you tremendous perspective on life.
Yeah.
And I think that you and I are certified workaholics, recovering now, right?
Yeah.
So I think our focus now is on trying to do things outside of work as well, as much as possible.
Do you remember that first day you went back into work after the whole thing was taken care of? Your first hour seeing patients again, was that? A little bit different in terms of enthusiasm, or
No.
no?
No, it's the same. I mean, I was working at home for the last 2 weeks, doing academic stuff. I'm an editor of a journal. The journal had to be maintained while I was away for the 4 weeks I was away from the journal and stuff. But no, just get right back into
And
it.
can I jump into that for a second? People don't realize out there that there is a major global journal of sexual medicine. We call it JSM in the biz.
Yeah.
And it's the definitive authority, in my opinion, not just saying this because you're here, in terms of breaking news and also reviews and what goes on in sexual health. And you're the editor-in-chief, right?
For one more year, yeah.
One more year.
I'm moving into my 10th year now, and pass it on to the next generation and new ideas. So yeah, no, it's definitely a labor of love, but I think it's a huge role to play in academics and crafting what the literature looks like, what gets published and what doesn't get published.
Yeah. Well, I'm just glad you're okay, because all I remember is we were talking on the phone. You said I had a brain tumor. It's benign, and I that's all I heard. I didn't want to talk about anything else. I didn't know where this was going.
Yeah, I'm back.
I'm glad you're good. I'm glad you're back. Okay. Let's bring my next slide up. Okay. Let me preface this. You had this book out a long time ago. It was very hot. People loved it. It was my go-to book for learning everything I needed to learn before, during treatment, and after treatment, how to save the sex life. But it's not out there anymore. Can you at least, for people that are trying to get a hold of it, and some people are paying too much for it, I know, because there's sort of illegal copies out of there. Can you tell us where this is going, and maybe you might give us an idea of, besides this talk, where people can go for good advice?
I'm not a massive self-promoter, so I don't want to be, overly, I don't want to discuss this overly too much. There was an absence of a book written for patients that wasn't written by either a surgeon or a radiation oncologist who was a dog in the fight, or somebody who was a real expert. And I'm a certified oncosexologist, right? I work at a cancer center, 600 new prostatectomy patients a year, hundreds of radiation and triple therapy patients. So this was an effort to try guide people, very much like the lecture, guide people eyes wide open what to expect, okay? It was published in 2008. The publisher that published it, Hilton Publishing, I think, has gone out of business. And a second edition is in progress. So I'm hoping in the next year that there will be a second edition. Sadly, in some chapters, there hasn't been a lot of developments. In other areas, for sure.
Yeah.
But I think that, again, just trying to empower the prostate cancer patient, wherever they are on their journey, to make the best decision for themselves.
Well, I mean, if people can still get a hand on a chapter, I still have my copy of the book, actually. And it was underlined in red, because I'm a traditionalist with that underlining thing like you. So at least the next edition will be out at some point, so people can look forward to that, right?
It'll be easier when I don't have the journal responsibilities, which is a massive responsibility.
But it makes me also think of the Sexual Medicine Society. Now, you and I know what that means, the SMS group.
Right.
I guarantee you the vast majority of people out there don't know what it means. Can you just give a little bit of a plug on what SMS is and why it's important for patients?
Yeah, so the Sexual Medicine Society of North America,
okay.
So that
North
accounts
America.
for United States and Canada, is a professional organization devoted to dissemination of credible information, conduct of research, education and training of the new generation of sexual medicine physicians. Most of the members are going to be urologists because it's an affiliate of the American Urological Association, but we've got a psychologist. Actually, the psychologist at Memorial Sloan Kettering, Chris Nelson, is the current treasurer of SMSNA. They have two websites, one for physicians, on which there is a member locator, so patients can go on there and try find where their local sex med expert would be. But they also have a patient website called sexhealthmatters.org.
Okay. So if I type in Sexual Health Matters, sexhealthmatters.org, that's the patient site.
Yeah.
Okay.
So there's lots of information on there, didactic information,
Yeah.
et cetera, et cetera. You can submit questions, there's topics, there's archive topics on there. So it's a very useful resource for people. If you happen to live in New York or Chicago, LA, there's going to be several sex med experts in the city. But if you're in more rural areas, it can be a challenge to find somebody close to you.
But the information you provide, the education you provide, and if this is one of those gold nuggets here, that if patients watching this can just go to some of those websites, pretty brilliant information.
Yeah.
I mean, there's some powerhouse people working with you on some of these committees.
Sure.
One of them is my colleague, Daniela Whitman,
Yeah.
who I like very much and puts out great material. So I'm just glad you mentioned that, because that's another educational resource that I think is still underutilized.
You raise an important point. In the modern era where the web rules and social media rules, as a consumer of that material, you have to be careful what you're going to believe and what you're not going to believe. I'm not sure I love the word fake news, but there's fake information out there, right?
Yeah.
So I think that you just have to be very careful. You need to make sure that you're going, as a consumer, to credible websites with credible information.
Yeah.
That's not always the case.
So that's great. We're getting a lot of stuff on my checkbox. So now let's shift this and talk about an area I like to talk about, which is the area of lifestyle and over-the-counters. Whether I know it's controversial, but let's first talk lifestyle before I move to my next slide. One of my favorite papers, I looked at every single paper that you published in the past 20 years before I came here, because I have no life. I didn't read the whole paper, I just reminded myself what you were doing. One of my favorite that I don't think got a lot of attention, and maybe it will strike up in your memory, and I know you're still following this kind of data, is that when you looked at Sloan, and I think other places, before people had treatment, the health of the person going into the treatment was very much a factor of how they were going to do in terms of side effects. In other words, I read that paper as heart healthy as erection healthy. In other words, the more heart healthy the patient was, the more likely their outcomes would be better. And I'm giving it a simplistic answer, but can you elaborate on that? I think it's an important message.
I mean, the phrase to remember would be, what's good for your heart is good for your penis. The penis is a big blood vessel. It's like an artery in the erect state. It's like a big vein in the flaccid state, right?
Right.
So look after your blood pressure, look after your cholesterol, look after your sugar, exercise. If you were to choose one thing to do to protect your penis, it's a structure that's laden with endothelium, and exercise is so good for endothelium. When we take men who come into our office who have an ultrasound for whatever reason, measuring blood flow in the penis, and they're 70 plus years of age, and they've got perfectly normal blood flow, 100% of them are exercisers.
That's
right?
interesting.
So blood pressure control, lipid control, sugar control, as best as you can, reduce stress.
Yeah.
Right? And so this concept that we want to be getting erections all the time, the purpose of that, those nocturnal erections that a healthy man gets regularly, is to protect the endothelium and the muscle inside the penis.
Yeah.
So what's good for your heart is good for your penis, right?
Yeah.
So they're the key things to remember, right?
Oh, that's fantastic, because I'm sure a million patients ask you before they have a procedure, when it's done, what can I do now to preserve function?
Sure.
And I know they want to hear about all the latest, greatest expensive drugs or not so expensive products.
Right.
But the idea that heart healthy is head to toe healthy, or what's good for the heart is good for the penis, is good for your sexual health, is one of the most important messages that can be sold. Let me tell you how much that gets into my brain when I'm thinking about you. So when I flew from Alaska yesterday to be here, at Delta Airlines, they gave me this tiny little straw to stir things. And I remember I attended a lecture of yours, I think it was 10 or 12 years ago, and you were mentioning the diameter of the blood vessels that feed the penis. They're very tiny. So if you look at this, I thought this is a couple millimeters. This is probably the size of a blood vessel that feeds your penis, yes or no?
0.5 millimeters in the flaccid state.
0.5.
1 to 1.2 in the erect state.
1 to 1.2
Our
millimeters.
And our coronary arteries are 2 to 3 millimeters.
3.
Right? Okay. So this is why erectile dysfunction is a harbinger of cardiovascular disease, a predictor.
Yeah.
Right? So if a man comes in, even in the absence of cardiovascular risk factors, no known hypertension, no known hyperlipidemia, right? Cholesterol and blood pressure are fine. If they come in with ED, there's an increased incidence of those men, developing cardiovascular disease over the next 5 to 10 years. And that is as strong, this is data from the PCPT, the Prostate Cancer Prevention Trial.
Yeah.
If you follow men who come in with ED and you follow them, they're just as likely to get, it's a stronger predictor of future myocardial events, heart attacks, as cigarette smoking is, right?
Yeah.
So ED is a future predictor of coronary artery disease. right?
Yeah,
So if you're 45 years of age and we do an ultrasound of your penis and you've low blood flow in your penis, right? We send those men off to see a cardiologist to get evaluated. Right. Now, of course, it's not just exercise stress tests, there's all kinds of funky anatomical and functional studies that can be done to look at that man's heart. But this is a real entity.
Yeah.
And it's been estimated that ED predates the onset of angina by 3 to 5 years.
Yeah, because you're talking about these tubes that are so tiny that the coronary arteries actually are much bigger than these. So if something's going to happen early, it's going to happen here early, right?
Right. It happens in the penis before it happens in the heart.
You'll never look at a coffee stirrer the same way, will you?
Well, I've been looking like that for years. So.
Anything else on lifestyle? My philosophy is, even though there's not a lot of money in lifestyle and sexual medicine, I know it's picking up. It will never be the point where I want it to be because I'm completely obsessed with it. But I think, before we move on to the next subject, I think it makes everything also, exercise and all these other things, also make the drugs work better. I think it makes the penile rehab. I think it makes the injections work better. I think that's been proven preliminarily in some studies, but don't you agree? The idea is if you're doing all these medications, you're doing procedures, and you're helping guys, and they're not doing something to help themselves, it's got to be frustrating.
Yeah. So I think it's worthwhile reiterating one of the topics I talked about in the lecture, and that is adrenaline is the world's most potent anti-erection chemical, right?
Most potent anti-erection chemical.
Stress, frustration, anxiety, lack of confidence. As a man, we're only as good as our last erection. If our last erection is bad, we walk into the bedroom the next time with anticipatory anxiety, right? And then things fail a second, and a third, and a fourth, and a fifth time. And then men will come in and say, well, it's not just when I'm with my partner, even on my own, because every erection becomes a test. So as much as we have these medications that can help, 15% of men with psychogenic ED do not respond well to pills. So high is the adrenaline load in the bedroom. That's human nature. That the reality is, I say to men, are you a golfer? Yeah. Do you know what the yips are? So worrying about missing a 3-foot putt, right? Tiger Woods went through that. That's the same in the bedroom. Whether or not you like the idea, it is a form of performance, right?
Yeah.
And so that's a real challenge. So we see lots of men with physically based ED. They were doing fine. They weren't as rigid as they were 20 years ago, but they were doing fine. And now they've had 1 or 2 bad episodes, and that's it. And so confidence restoration is important.
Okay.
And it's an opportunity for us to help them with lifestyle modification, etc. But that's a very important message, not just for patients. Partners need to understand that too, right? But also the non-sexual medicine physician needs to understand that.
I want to talk about 2 things that impact lifestyle, then we'll move on to the next slide. I personally believe, and we've done this at PCRI a lot, we've brought a lot of attention to alcohol. And I understand that when we were younger to have a couple beers and do this, but we've sort of become a nation consumed by alcohol. And moderation is now, the name moderation has changed. Moderation is just a lot more than what it used to be, it seems. And it's a lot more prevalent at all age groups. And I don't know if you want to comment on it, but alcohol and sexual function, does it get enough attention?
So it gets almost no attention, actually, to be honest with you. So there are several things to talk about. First of all, if you're using a Viagra, Levitra, Cialis, or Stendra, you're supposed to not be having a lot of alcohol. Why? Okay. Those drugs drop your blood pressure. A lot of alcohol drops your blood pressure also. The two together are bad, right? Number 2, alcohol for Viagra, Levitra, and Stendra slow the absorption. There's a gastric paralysis, gastroparesis, right? I take a glass of wine to help digestion. The idea is it slows down gastric emptying. Now the pill sits in your stomach with the food, and it takes a while to get absorbed. So you just have to be cautious, right? That's why I said when you're using Viagra, Levitra, and Stendra, take it 2 hours before a meal or cocktails or dinner, right? So the pill is in and out of the stomach beforehand, right? Okay. If you have massive amounts of alcohol, which will vary depending on who you are and your bulk and your alcohol history, it suppresses the trigger centers in the brain, the medial preoptic area, the paraventricular nucleus in the brain, which initiate the spark plugs of erection, right?
Right.
But if you're somebody who's got high levels of adrenaline, having a glass of wine might take the edge off things. It's a social lubricant.
A glass.
So it's a bipolar kind of effect that alcohol has. Right? I'm not advocating the use of alcohol to suppress your anxiety, walk into the bedroom, but it's reality.
What about all this talk about marijuana?
I think very much in the sense that alcohol will be social lubricant. I think in whatever dose is going to get you in a more relaxed state, it takes the edge off things for those men with high levels of adrenaline. I work in Manhattan.
Right.
You can't imagine how many high adrenaline men, young men I have come in to see me, right?
Yeah.
And high adrenaline turns off erectile function, causes the penis to shrink. So many of these young men who are getting penile augmentation procedures really just have hypertonia, high tone, contractility of their penis based on adrenaline, okay? So it's a muscle, and you'll feel, and their penis feels knotty.
Yeah.
But K-N-O-T-T-Y, right? You grab the head, the glands of the penis, you stretch, perfect stretch, right? Their muscle is healthy. They're just super high adrenaline.
I see.
And a lot of these men are going to have sexual dysfunction.
I thought though, because they're increasing the content of THC and all these other things, that it's going to be a problem in terms of creating erectile dysfunction, these substances.
There's no credible evidence that THC interferes with erectile physiology, right?
Okay.
Now, I suspect that there just hasn't been the research done on super physiologic doses
Yeah.
of THC, right? But at this point in time, I would not look upon it as a negative in that space.
Let's shift to a different topic. Another one of my favorites is the over-the-counter space. Yeah. The over-the-counter space in our lifetime has become a billion-dollar space. People want their products to get over the counter, especially when they become generic. Yeah. And I know there's been talk in a lot of countries of putting Viagra and all these, right? And over the counter. Yeah. But what happened in the past few months is something did come over the counter. Can you go to the next slide? I have no involvement with this company. This product's actually called Med 3000. It's a Roxxon. I could be pronouncing that. It's going to be for sale now in the next few months. An over-the-counter product that's being allowed to intimate that it helps with erectile function. And it's a lubricant, right? It's a gel. And so can you just talk the pros and cons of the first ever over-the-counter FDA cleared, or FDA gave a thumbs up to letting this be sold over the counter?
Let me take one step back to talk about the concept of over the counter or behind the counter.
Yeah.
Right, behind the counter being where you have to speak to at least a pharmacist before you can get the medication. The problem with Viagra type drugs, right, is the very dangerous interaction with nitroglycerin medications.
Yes.
Or with guanylate cyclase activators. Nitroglycerin for chest pain, angina, guanylate cyclase activators for pulmonary hypertension. They cause massive blood pressure drops. The average blood pressure drop, 100 milligrams of Viagra, standard sublingual dose of nitroglycerin, is 30 points. For you and I, we're going to have to lie down, we're going to get dizzy. For somebody with coronary artery disease who's using nitroglycerin, that might be a myocardial infarction, heart attack, or it might be a cardiac arrest, right? So that's the challenge in that space. The second thing is that there's a 30% placebo response rate in ED drug trials. If you take the Viagra trials, the phase 3 trials, the Levitra Cialis trials, you'll see 25 to 35% of men using placebo gave themselves much better scores.
I mean, think about that. That's 1 out of every 3 men.
That's a tribute to the fact that even men with physically based ED have a secondary psychological component, right?
Yes.
So if you give them aspirin, 325 milligrams of aspirin, and say, this is the latest new drug in ED, a third of them are going to say, I'm better. Now that tapers off over the course of a month or so, right? So a Roxxon, and in interest of full disclosure, I sat on an advisory panel with the company when they were doing their randomized placebo-controlled trials. A Roxxon is the placebo gel from that trial. As you and I have talked about before, right? If you're using anything for ED, there's a chance you're going to say it's better. Your erectile function is better, right? Placebo response.
Yeah.
Number 2, if you're rubbing something on your genitalia, whether it's your penis for a man or your clitoris as a woman, and there are these products for women, you're causing digital stimulation, manual stimulation of the organ, which is going to arouse you and may lead to better erectile function. Thirdly, this is menthol infused, so it's going to tingle, which is going to amplify the physical response, right? I think that for men who have physically based ED, the likelihood that this is going to help you significantly is very, very low. Okay?
What about if someone's been treated for prostate cancer and says, hey, Dr. Molo, I just want to use it along with everything else. Do you have a problem with it?
I wouldn't have a problem, providing, that becomes a price point issue.
Yeah.
Right, okay? So if it's not threatening to your wallet, then, why wouldn't you use it? What I wouldn't want to happen is I wouldn't want men to go down this pathway for 3-4 months and bypass classic rehabilitation where they might end up hurting themselves.
Yeah.
Right? So here's another classic example in our practice. A man who comes in who's flagrantly incontinent. Right? He's leaking urine, 6 pads, diapers a day, wet, always wet, real problem, right? And puts off his sexual function rehabilitation. That hurts that man in the long term.
Yeah, that's a good
So we
point.
say to those men, you don't have to have activity, right? I don't care if you have sex, I don't care if you have an orgasm. What I do care, blood flow, oxygen, and stretch. So that would be my only concern of an over-the-counter supplement.
Yeah.
The challenge also with over-the-counter supplements, as you know, and it's kind of, I won't say threatening, but I'm speaking to the world authority
I don't know
on nutraceuticals, right?
Yeah.
But the challenge is, as you know, many of these over-the-counter male supplements have included in them Viagra, Levitra, Cialis in generic form.
Contaminated,
right?
yeah.
And if you don't want to use those pills because your doctor says, oh, you're on nitroglycerin, you shouldn't use those pills, you must be very careful looking at those agents because they might actually contain the drug that in combination with nitroglycerin is going to hurt you. And then these other men's health supplements will contain other androgens, right? DHEA will be the classic one, right?
Yeah.
And I learned, and you correct me if I'm wrong, many years ago, that most of the DHA in the United States of America is derived from the Mexican yam and it's not bioavailable, right? So, you know, I think we just have to be very careful and counsel our patients very carefully. But it's very easy, $39.99, you can return it, men never do, and so they try it, but just be cautious about what's in there. And I think, I remember you saying that there's a proportion of these products that say they've got X, Y, and Z that don't have any of X, Y, and Z in there.
That's right.
Right? So just be aware of that as you're thinking about these supplements.
Yeah, I've come to the point where if there's no quality control seal that proves that what they're advertising is actually in the product, I don't think people should purchase it. And people say, well, the quality control seals cost a little more money, but you know, they're worth it, especially in the ED space. But I do, you know, since the last time I talked to you, I am more excited about the ED space over the counter. I know that you deal with, I'm sure you get questions about this, L-citrulline, some people talk about L-arginine, but I think the message that gets missed is in the actual trials when these products work over the counter, they're just using those most of the time as single ingredients and they're cheap. The idea that someone's got to spend a fortune over the counter and work with you makes no sense to me.
Yeah, I think that there's no, and I say this with my scientific hat on.
Yeah.
I have no conflict of interest, I have no relationship with any pharmaceutical industry company at this point in time. There is no credible evidence that an oral agent is of any benefit to erectile function. In fact, the American Urological Association guidelines said, right, that nutraceuticals really should not be used. There's no role for them at this point in time.
Yeah, I think the bad players have kind of crowded out the good players. And my hope is that in our next conversation we'll talk about a couple of trials that are showing some benefit. But I think it's a good point to cover. I want to play a new game with you. I have two games I want to play here with you. One's called the Con and Pro game. I love the Con and Pro game because it makes you think of the catch first versus the benefit. So we talk about the benefit second. So let's talk Con and Pro with Dr. Moyad. We already talked about lifestyle.
Pro.
It's very pro, right? Now I want to start going through some of the options. But the first thing I want to talk about is the thing that confuses me the most about penile rehabilitation, I think confuses most people watching, is if they're about to be treated for radiation or they're about to be treated for anything, they don't know what to ask for in terms of penile rehab. Does Mohal think that means a pill? It means an injection? It means a vacuum device? Does it mean one or the other? What am I even suggesting to my doctor of the type of rehab I need to be on pre, during, and after? So can you help me with that? What everybody out there should be asking their doctor to do before they start their treatment?
So we always start our patients prior to surgery or radiation on low-dose PDE5 inhibitors, right?
So like
Viagra, Levitra, Cialis, Stendra.
Is there one you favor over another?
Most of our patients are using either Viagra, which is sildenafil, or tadalafil, which is Cialis, right?
Okay.
But regular, meaning nightly, okay? And the purpose of that is endothelial preconditioning.
I'm taking this every single night before my treatment is what
We do
you're
it
saying.
for 2 weeks before their treatment starts.
2 weeks
right?
before, okay.
And by the way, for the radiation patient who gets ADT, that's 2 weeks before they start ADT,
Yeah.
okay? Then after...
Is that how you should think before you start any other treatment or add-on? You should keep thinking rehab. What else can I add here?
I don't think you need to do much additive. What you really need is you need endothelial protection, smooth muscle protection, both of which are done by PDE5 inhibitors, and then erection. So everything that's good for your penis occurs during erection,
Yeah.
right? And so in the early stages after treatment, we want them to try maximum dose. If they're getting a penetration level erection,
Maximum dose.
right, then that's all they need to do. As I said in the lecture, the vast majority of people do not get penetration rigidity post-prostatectomy with a maximum dose PDE5 inhibitor. The vast majority of people after radiation, if they haven't had ADT, will respond beautifully to a PDE5 inhibitor. If they're not a PDE5 inhibitor, or after radiation, when they stop being a PDE5 inhibitor, then they go on to the next treatment, which is injection therapy.
This is after you've been treated.
Yes.
So the one pharmacologic agent you want to focus on before your treatment is Cialis Levitra. There's no necessarily add-on at that point,
No,
besides
listen,
lifestyle.
if you say to me you're not getting any good, in an ideal world,
Yeah.
what we would do is we take men who had hypertension, dyslipidemia, obstructive sleep apnea, diabetes, low T, and you'd fix that.
Yeah, you cure that.
Before their treatment, right? And if
Yeah.
you've got a Gleason 3+4 organ-confined cancer that's low volume on your core, 4 of 12 biopsies are positive, you could probably put that off for 3 to 6 months and address those things, right? But that is not yet mainstream. I would like to see that mainstream in the future,
Okay.
right?
Yeah.
But the bottom line is that PD5 inhibitors protect your penis. Just their presence. You don't need an erection to do that.
And I want max dose.
Right? After surgery, after radiation, you want to challenge them and make sure they're getting really good erections. And that will require maximum dose. And 85% of prostatectomy patients will not respond in the first 3 to 6 months.
But how long am I staying on max dose after treatment? And so if I've had surgery or radiation, am I staying on it, am I going to at least go 6 to 12 months?
Yeah, so let's break out the different modalities.
Okay.
So with surgery, as the nerves recover over an 18 to 24 month period, I've told you 15% respond to pills at month 2, let's say.
Yeah.
That number, if you're under 60 years of age, good function before surgery, good nerve sparing, is 75-80% at 2 years. So there's a whole inversion. So the vast majority of men who go on to injection therapy after prostatectomy get off injection therapy.
I see.
Right?
Yeah.
After radiation, given that it's a 3-year nadir, right? The low point in erectile function is 3 years after radiation, then many patients don't need to use pills early on, but by the 3rd year, they have to take their maximum dose pill.
Yeah.
Because they're no longer getting a good erection, right? So it's about use of PD5 inhibitors regularly, which is just good for it's good for endothelium, right?
Yeah.
So I don't know if you were of Bob Kloner's paper that came out early this year, showing using a very large database that using regular use of PD5 inhibitors reduces the risk of myocardial events, of heart attacks and strokes, okay? We've known this for a long time, and I think, yeah, there you go, exactly it. And, you know, the pharmaceutical industry dropped a massive ball, by not exploring this. Like statins have been explored,
Yeah.
PD5 inhibitors should have been explored, okay? So I think PD5 inhibitors are good for your penis, getting erections, penetration hardness. Why penetration hardness? Because that's our average nighttime erection. There must be something evolutionarily, developmentally, to us getting nighttime erections that are around penetration hardness, oxygen and stretch.
Yeah.
So that's why we drive people to get penetration hardness in our rehab program.
Okay, so I'm taking this pill, right? So the paper he's referring to was in the Journal of Sexual Medicine, 2023. It was a paper published with a lot of different authors, but it was Kloner et al., right? And I love this last statement. It says there was a lower incidence in this large data set. There was a lower incidence taking Viagra and these type of drugs of major adverse cardiovascular events, cardiovascular death, and overall mortality. In other words, it improved the chances that you would just live longer. Now, if that's a drug that just came out, there would be an advertisement every day on TV.
That's why I said the
and it was
industry
such a
dropped the
powerful
ball.
paper. I didn't even discuss this with you before I saw you today, that I brought it in and I wanted you to comment on it. It's just unbelievable. And so,
But in the phase 3 trials for Viagra, Levitra, and Cialis,
yeah,
if you look at the treatment arm, there were thousands of people in the trials. It wasn't just one trial, but there were many trials over several years done before and early after approval. The myocardial infarction heart attack rate in those men getting the drug was lower than the placebo arm, right? Well established, well known.
Yeah.
We've known this for years. They are potent endothelial protectants.
but I think there's a huge confusion that some doctors have caused when you take these drugs for rehab. So some of the people will think that every time I take them every day, I have to have sex.
No.
Or do I have to stimulate or self-stimulate that area? They don't understand what it means during rehab when I take the pill. So you're just saying you take the pill like you take a daily vitamin.
Like a vitamin.
So you don't have
Going
to
to bed at
stimulate.
night.
You don't have to see something on TV that stimulates. You don't have to self-stimulate. You
Correct.
don't have to have sex.
Right.
So if you're taking it 7 days a week, you're just popping it at night. You said at night, right?
Yeah.
And then that's it.
Because it might induce a nighttime erection.
yeah,
Right? That's why we do it at night.
That's brilliant.
So there's very good evidence
Yeah.
looking at a technique called flow-mediated dilation, which looks at the ability for a blood vessel to
flow-mediated
expand, right?
dilation, yeah.
That's an endothelial function, right? If you take low-dose Viagra, 25 milligrams, every night for 14 nights, right? your endothelium is protected for at least 24 hours after the last dose, right? If you do that with Cialis, your endothelium is protected for a period of 2 weeks after the last dose. So these drugs are endothelial protective, even just their presence. They bathe your endothelium.
That's exciting. And the only other thing I want to add, I don't know if you want to comment on it, besides this paper saying this can help you live longer, they're now looking at funding some trials in terms of people that have cognitive issues, in terms of improving cognitive performance, in terms of increasing blood flow to the brain. So I don't know if that's gone anywhere, but...
So I'll say what I say to my patients. Mr. Jones, the further I get away from the penis, the less expert I am.
All right, so that helps me, except, all right, I'm going to take it every day, and it's such an important point. I don't have to self-stimulate. Let me repeat that. I don't have to have sex. I'm taking it like a nightly vitamin, but I'm taking the max dose because there's doctors, depending on the doctor, they have different rehab programs.
The nightly dose is low dose.
Okay, the nightly dose is low dose.
But the literature would suggest that 2 to 3 erections per week are protective of our erectile tissue. Remember, we get 3 to 6 every night, right? So you're getting 21, you're a 45-year-old healthy man, you're getting 21 erections at least every week of your life, right?
Okay.
But the literature would suggest that 2 to 3 erections per week after prostatectomy are protective. They improve erectile function recovery. So it's nightly low dose.
Nightly low dose. Okay.
And 2 or 3 times a week, we want you taking a big dose to get an erection. That you need to be taking, you need to be stimulating. Remember, for Viagra and Levitra, dinner at 7, take it at 5, good till after midnight.
Thanks for correcting me. Nightly low dose and then a higher dose a couple times a week. That's what you recommend. Okay, if that's so great for your penis and your overall health, why don't people just use other things along with that right after treatment or during? Why don't they just use the erection device, vacuum erect? Why don't they just go to injections early? Because injections are so helpful. Why do I got to wait around for a couple weeks? Why can't I just start injections a couple weeks later?
So first of all, there's no sexual activity 2 weeks after surgery. You have the catheter in, and there's an anastomosis. We want to protect that. We give them 4 weeks then to try maximum dose pill. At 6 weeks, we're supposed to see them. If they come in at 6 weeks, the pill's not working, straight to injections. Okay. Pill's working, great. You continue with the pill, maximum dose pills, just get erections. Okay? So that's the general flow. The vacuum device doesn't oxygenate the penis, right? I'm a big fan of the concept of oxygenation of the penis. Right? Now, this is not oxygenation from the outside. There was a company, I know, more than a decade ago, who developed a little oxygen tent for the penis that you put over your penis at night. That's not the oxygen we're talking about. It's the oxygen in the blood that occurs during erection, right? And so this beautiful balance, physiology is amazing. Beautiful balance between flaccidity and erection. For the healthy man, no problem. The erection protects the penis. But if you go through a state of chronic flaccidity, I haven't got an erection in 6 months, right? Post-prostatectomy. That's bad. Now the muscle degenerates.
So it seems like in your world, you're using the injections earlier.
We use injections as early as 6 weeks after surgery.
6 weeks is early, and so that's an important to ask about that once you hit that 6 week time period.
But because the vacuum device does not oxygenate the penis, we don't utilize vacuum device therapy as part of our rehabilitation.
You don't?
We do not.
You don't?
There are 2 papers in the literature, the Dalkin and the Kohler paper, which show very nicely you can preserve penile length with a vacuum device. You can also preserve penile length by daily PD-5 inhibitors, right? But there's no evidence to show that vacuum devices increases the ability for a man to get back to baseline or spontaneous erectile function.
So your rehab program is lifestyle, the pill,
possibly injections.
And the injections, and then what about Muse? You know, it's been around for a while.
So Muse is variably available anymore, right? So for most places, it's not available. The problem with Muse is it's pure prostaglandin at really high doses, right? The maximum dose is 1,000 micrograms, right? And prostaglandin is a pain mediator. That's why we take things like ibuprofen. It's an anti-prostaglandin drug, right? And so these patients post-prostatectomy or post-cystectomy or post-low arterial resection for rectal cancer get terrible burning pain in their penis, right? Because of the prostaglandin with Muse. So we don't use it. It's not very effective, it's not very consistent, but really the reason is that we don't use it because of penile pain.
All right, here's what I want to ask you though, since you taught me about the rehab stuff. Is it possible to talk to you after the program that we can put up as a part of your lecture today, just your basic rehab protocol? Is it okay?
I can send you a slide,
you can
which
send
you can include it in this session.
I just think this confuses the HE double toothpicks out of everyone. Just rehab. What am I supposed to ask for? What's the dose? How often? Which drug do you like best? Should I include the injections? You say 6 weeks. I mean, all these things
there
are bullet points that have to be taken to the doctor.
There is no pills that I prefer over the other. And we'll include a slide,
Really quick comment on these. I found this old ad.
Yeah.
It's a Viagra ad, and what I found so intriguing about it, and correct me if I'm wrong, is we also have to educate the fact that these pills make your equipment, for lack of a better term, they make your equipment work better potentially, but they don't necessarily make you want to use your equipment more. Yeah. So one thing that's not talked about in this space, we always talk about function, but I don't think we talk enough about sex drive. Right? So do you have any comment on that?
Yeah. So sex drive is very easy to talk about because there are only 3 causes of sex drive issues, right? There are medications.
Yeah.
So any psychotropic medication. If you've got a history of anxiety disorder, depression, mental health problems, and you're on drugs, for example, like Prozac, Zoloft, Paxil, right? SSRI drugs. Psychotropic drugs are a problem, okay? Other drugs are anti-testosterone drugs, estrogenic drugs potentially, and then 5-alpha reductase inhibitors. Okay, so finasteride and dutasteride. In the trials done for BPH, older men with large prostates, 5% of men had low sex drive, right? So there's drugs. Number 2, hormones, right? Low testosterone, hypothyroidism, hyperprolactinemia, a chemical that comes from the brain, a hormone that comes from the brain that's associated with benign tumors in the brain. So you just measure testosterone, you measure thyroid function, and you measure prolactin. And then number 3, psychological. And that's a big umbrella term for many, many different things. So when the man who's low sex drive is related to the fact that he's got ED, in those men you put them on a drug that facilitates erections, you may well see improved sex drive. Because their sex drive was related to the fact they're low confidence walk into the bedroom. Now that I've got erections back, hey, and the frequency activity goes up in those men. But it is not a libidogenic drug, it's not an orgasmogenic drug, it is an erectogenic drug.
I want to pause for moho moments. That means I want some wisdom from these things. Will you please comment just on the neurovascular bundles? And the reason why I'm so shocked at how many people get treatment. There's never a discussion of neurovascular bundles and the role they play, not just in erectile function, but possibly continence. I think this is on the Mulhall checklist, that you have to talk about neurovascular bundles during your consult. Can you just comment on that?
Yeah, so the neurovascular bundles in the book, I describe them as tiny microscopic fiber optic cables.
Yes.
That are embedded in a layer of saran wrap that's wrapped around the prostate that you need to think of like an orange. And that orange is going to be removed. So you have to split the saran wrap and pull it apart, and that traction or percussion injury causes stretch of those nerves, and those nerves go to sleep.
Okay.
Those nerves are the lifeline to erections, all right?
Yes.
There are multiple different layers. Fascia is the term we use in medicine, right? There are different layers, and depending on which layer you're in during the prostatectomy, the surgeon should be able to tell the patient.
Yes.
Right? Whether they were intrafascial, extrafascial, interfascial, how much nerve damage there was. At our institution and at some other institutions, there are grading systems. 1, 2, 3, 4, 1 the best, 4 the worst at our institution. That's on the up note. I see it. Mr. Jones, you're a 1 and a 3. Okay? I will tell you, and there are urologic oncologists who will disagree with this statement.
Yeah.
I don't believe that the neurovascular bundles are intrinsically involved in continence. I do believe that the level of dissection at the very bottom, the apex of the prostate, the bottom is called the apex, is what's involved. And if there's a lot of extra or unnecessary or aggressive dissection there, the neurovascular bundles will be damaged, but so will the continence mechanism.
You're damn
so they
right.
go, it's an association rather than causation.
Yeah. Shouldn't you discuss that for radiation treatment too? Because radiation can damage the neurovascular bundles.
The least important factor in the radiation patient is the nerves, right? The blood vessels, hugely important. The muscle. About 40% of radiation given to the prostate gets delivered to the back 1 inch of the penis because it sits right under the prostate. There's a layer called the urogenital diaphragm, which varies between 1 centimeter and 2 centimeter. The longer your urogenital diaphragm, the less radiation you get, right? So about 40% of the radiation delivered to the prostate gets to the back of the penis. So it's the muscle damage there And it's the blood vessel damage because radiation damages endothelium.
So then rehab after radiation would be just as important as rehab after
It's
surgery.
actually more important.
More important.
And we have much better data
More
in the
important.
radiation patient with PD-5 inhibitors. Randomized controlled trial from Memorial Sloan Kettering showing 2-year preservation of sexual function better in men who use pills versus placebo. So we have better data in the radiation patient because the primary means that radiation causes damage is endothelial, endarteritis obliterans.
Okay. And what about androgen deprivation therapy? What's your rehab, your pithy rehab program for people to just go on ADT or any sort of hormone therapy?
So again, start beforehand, the concept of prehab, endothelial preconditioning, because no sex drive, almost no sex drive, very challenging getting an orgasm, but the big thing is collagenization of smooth muscle. You need some testosterone for the muscle to stay healthy, right? You don't need a lot of testosterone for the muscle to stay healthy, but when you've no testosterone, that muscle reflexly turns to collagen, and that leads to a leaky valve in your penis. Mr. Jones, your penis is like a bicycle tire, 2 hoses going in and a muscle that contracts to control the valve. Blood stays in there, it can't leak. We have an orgasm, the valve opens. That muscle controls the valve. When that muscle degenerates, blood flows in, flows out, flows in, flows out, and that's called venous leak, venous leak.
Yeah. Okay. So you're doing rehab when you're on androgen deprivation therapy. Let's say you come off of it, you get some testosterone back. Can I regain my function? And can I regain? Because you taught me that on hormone therapy, you lose not only length, possibly, but width.
Volume.
Volume.
Yeah, penile volume.
Do I ever get that back?
If you have penile volume loss after being exposed to ADT, that is invariably the result of collagenization of smooth muscle, and that's a permanent phenomenon. That's why we do rehab. You can't come back a year later and say, okay, now I'm ready to start.
Yeah.
You really have to do it preemptively.
Dry orgasm, climacturia. I heard it again from someone just the other day. I was very happy with my treatment, but I had no idea that my orgasms would be dry. Shouldn't that be mandatory discussion before the treatment?
So as I alluded to in the lecture, you never know if somebody says, that's the first time I've heard of it, where they told that and didn't receive the information because they're so oncocentric in that pre-therapy phase, right? Or they just went told it. But there's literature showing 40% of men, when inquired within 3 months after surgery, don't remember ever being told they will not ejaculate.
Okay.
The ejaculation apparatus is gone. So it's orgasm, but no ejaculation. For gay men, that's very challenging. There's a lot of ejaculatory distress among gay men because they don't ejaculate anymore. 1/3 of straight men will say, this is a real bother in my life. Okay? So it's not something that's talked about unless you come see me preoperatively, and we will talk about that. You should have an orgasm. Most men don't understand that if you've no erection, you can still have an orgasm. Technically, you don't need a penis to have an orgasm because when you were younger and you had nocturnal emissions, right?
Yeah.
There was no sexual stimulation, it was just brain driven, right? But you should have an orgasm, but invariably early on at least, the nature and intensity of the orgasm is not what it was before. At 2 years after surgery, 50% of men will say it's less intense than it was before surgery. 40% will say it's about the same. It feels different, but the intensity is about the same. And surprisingly and consistently, 10% of men say the intensity is more. It's greater intensity after surgery.
So I'm having a dry orgasm after surgery. What am I having after radiation, and what am I having after hormone therapy?
So you can't make semen unless you've got testosterone. So they just don't produce semen.
So there's
the
just
machinery is intact,
Okay.
but they don't produce semen,
Okay.
right? After radiation, 90% of men by the 5th year after radiation will have no ejaculation.
Okay.
Just basically contraction and scarring of the prostate and ejaculatory ducts.
But like you said, rehab is just as important in those situations. Let's go to the next slide, please. I'm sorry, but this is all the rage out here in California and other places. And I actually saw this from the AUA, and I saw your name on some places. People have to understand there's this low-intensity shockwave therapy, and it's applied to the penis. It's,
So
shockwave therapy like a kidney stone, but it's actually on the
introduced
penis.
for stone disease, right? Then more than a decade ago, probably 15 plus years ago, shockwave therapy, low-intensity shockwave therapy was applied to infarcted myocardium with improvement in recovery. So, oh my goodness, we should be applying low-intensity shockwave therapy to muscle. The penis is a big muscle, so that's how it got used in erectile dysfunction.
Okay.
There are about 16 large papers in the literature on shockwave therapy. Half of them are randomized controlled trials, half of them are observational studies, okay? There are several that show no benefit. Most of them show mediocre benefit. And so at this point in time, the Sexual Medicine Society of North America The AUA, the American Urological Association, say that these therapies, shockwave therapy, stem cell therapy, and PRP, platelet-rich plasma, should be used under an IRB, so an ethics committee saying, yes, you can do this, and patients should not be charged. The reality is, however, that there are many, many practices that are charging people cash for this. There is a concern, theoretical concern, that shockwave therapy or stem cell therapy, for example, may reactivate cancer because they're kind of growth factor, that's how they function. They promote growth factors, and that so if you have a pelvic cancer and you're getting shockwave therapy to your penis, or you're using PRP, or you're using stem cell therapy, these have not been studied extensively in prostate cancer or cancer patients in general.
And what about these wands, these pulse wave devices? You can buy them on TV. You're supposed to take the wand and apply it yourself. I mean, it
is capitalism at its finest, right? Okay, so the problem is that a shockwave therapy, if you look at the wave, it's got a spike and it's got it's got a certain amplitude to be considered a shockwave. Pulse waves are just these low little whatever. They do nothing. They might warm your penis up. But they're not going to improve your erectile function.
All right. You mentioned this. You erectile dysfunction doctors have been a disappointment, because I'll tell you why. I'm not saying you, I'm just saying in general, you made us all excited about doing nerve graft. Remember the sterile nerve graft, and all these nerve grafts were going to change men's erectile function after treatment. It was going to be like stem cell. It was going to change the game. It doesn't sound like this is going anywhere, you're saying, but you want to comment on this?
If I was having prostatectomy and was going to have deliberate bilateral nerve resection, I would say to the surgeon, I would like you to do nerve grafting, because you take men who have no chance of ever being a pill responder.
You would say?
No chance of being a pill responder, bilateral nerve resection. And you change that to about 10% of men who become pill responders, right? It's not 90%. But if you're having bilateral deliberate nerve resection, I would ask to have nerve grafting done. The problem is that most people are not having bilateral nerve resection.
How am I going to get nerve grafting done? I know a doctor out in California that does it, so you just actually request that.
They're using to your prostatectomist.
Nerve graft as in stem cell nerve grafts?
Oh, no. Nerve grafts as in sterile nerve grafting or genitofemoral
so they're still using a nerve from a different part of the body,
right,
and then applying it there, and you're a
plastic
fan
surgeon.
of it. You're a fan of it. That's awesome.
Fan in the sense that it goes from 0 to 10% ability to be a pill responder if you have bilateral deliberate nerve resection.
Okay.
This is not somebody who has a little bit of damage on one side and a little bit of damage on the other side. That's not used.
Okay.
You're looking, sir, bad cancer, positive mark, I can see on the MRI, we're going to take out a segment of nerve. Yes. I would ask for nerve grafting.
So I would ask for nerve grafting. It's autologous. They take it from somewhere in your body and they put it
in the leg, which is the sural, or in the pelvis along the psoas muscle, the genitofemoral.
That is interesting. You and I have never talked about that. Next slide. You talked about TRT, testosterone replacement after cancer treatment, and I know Dr. Scholes will talk about this too in terms of another way, but do you want to comment briefly on the fact, let's just step out of prostate for a second. There was this trial finally called the Traverse trial that was supposed to show whether or not testosterone replacement therapy in men causes cardiac problems. Do you want to just comment on this trial that just published in the past few months?
So first of all, just to declare, I'm the chairman of the AUA guidelines on testosterone deficiency.
Of course you are. You're the chairman of everything.
So the statement is clear, right?
Yeah.
A man who has low testosterone should be told, we had a cardiologist on the panel, a man with low testosterone should be told that low testosterone is a risk factor for coronary artery events, major adverse cardiovascular events. The presence of low testosterone, right? Now, if you use 300 as a normal cutoff, really that literature is most robust for men with T levels below 200. So the presence of low testosterone is a risk factor for MACE, major adverse cardiovascular events. There isn't yet enough literature to show that testosterone replacement therapy, prostatectomy, radiation, active surveillance is safe. We have about 500 men now with Gleason 6, Gleason 7 organ-confined cancer. We have about close to 200 men with high-risk disease, 100 and something men on active surveillance, 100 and something men on radiation. There is no signal at this point in time that it's a risk. However, you probably need 85,000 men followed for 15 years to really answer that question.
So they did this trial, they said...
6,000 men, almost 6,000 men, no increased risk of cardiovascular events.
Okay, no increased risk of cardiovascular events. That's what I saw, especially people came out and said that in the press, especially those who have some conflict of interest. So what I mean by that is that there's other things that were not mentioned about that trial, and I wonder how you're teasing this out. There was a higher rate overall of pulmonary embolism in the people on the testosterone. There was a higher rate of atrial fibrillation. There was a higher rate of acute kidney injury. And I know it was just a tiny bump higher, but isn't that making us, shouldn't that make us nervous?
It wasn't clinically meaningful.
Okay.
All right. There was an increase in the absolute numbers, relative numbers, but not really in the absolute numbers, right? Okay. Biological plausibility is critical, right? There has to be a mechanism by which testosterone might cause kidney damage, etc. It doesn't. It doesn't induce atrial fibrillation, right? And so I think that's a bit of background noise.
Okay. That's good to know.
The clots. The pulmonary embolism is a significant issue, right?
Yes.
But in the trials, there was no control for the T levels. And if you're on intramuscular testosterone of high peak levels, you're more at risk for having, let's say, polycythemia, which is high hemoglobin. And that might be a risk factor for these clot phenomena.
Well, it sounds like the trial made you feel a little more comfortable that it's not heart unhealthy.
I've never been worried.
Okay.
Because if you take the 4 papers out, the Basaria, Finkel, Vigan, and G paper out of the literature.
Yeah.
With regard to cardiovascular events, every treatment, every study is neutral or shows that there's a reduction in cardiovascular events.
That's good to know, but I will tell you, I'm going to play Monday morning quarterback again on this trial that everybody's talking about. Not a single expert that I was aware of in the medical journal mentioned the average BMI of the man in that trial, which was 35.
Sure.
35.
Sure.
So now let me play devil's advocate or angel's advocate. I'm going to go maybe on one of these new drugs to help you with weight loss. I'm going to lose 50 to 75 pounds, and my testosterone's going to go up. Why do I even need it?
The amount of weight you need to lose to boost your testosterone to any clinically meaningful level is bariatric surgery.
Okay.
There's no evidence, this again is AWA guideline based, there's no evidence that losing 30 to 40 to 50 pounds is going to make a big difference in your testosterone. There's no evidence that doing exercise is going to improve your testosterone. Oh, resistant exercise is good, yeah, but the amount of T change is really minimal, okay? So I think the future is bright in trials that are looking at different endpoints for the GLP-1 agonists.
Okay, I was just wondering because there are a lot of guys out there in the prostate world too who are on testosterone replacement and they don't have BMIs of 35.
Yeah.
So, you know, one of those guys.
But if you took the low testosterone population in general, Mark,
yeah,
okay, they're going to have high BMIs, right?
Yes,
There's going to be a higher instance of diabetes and being severely overweight. So that's not surprising to me, right?
Okay. You're kind of the Conor McGregor of urology. I just want to, and that's in a good way.
I don't have that.
No, what I'm saying is, I mean, you don't have that kind of money and that, but
body.
you have, body, I thought.
That kind of body.
I don't know. I think you're a pretty handsome guy. That's my dog. I started with my dog, and
yes.
I wanted to finish with my dog. All right, 30 seconds. Anything that I miss? Kegel exercises. Do you even think men should do Kegel exercises?
For continence, yes. For erectile function, absolutely not.
Okay.
There's no good evidence that pelvic floor therapy improves erectile function, and from a biological plausibility standpoint,
okay,
there's no link between the two.
Okay, there's one thing we didn't mention that you actually know a lot about, and I think it's a good way to move toward end this, is Peyronie's disease.
Okay.
And
how long do you have?
Well, no, but the only reason I'm just mentioning is just an awareness comment. And are you a fan of the injections that have come out that now people are seeing all these TV commercials? Do you want to just provide your sort of take on this condition? What is it?
Peyronie's disease is a genetic condition.
Okay.
That occurs predominantly in European Caucasians. It's very uncommon in African Americans and very uncommon in Asians. It is a scarring phenomenon that the scar occurs in the outer lining of the erection chamber called the tunica albuginea. Okay. There's a scar, it doesn't expand. Man has a scar on the top surface of his penis. As he's getting an erection, the penis gets tugged, curved over to that side. 40% of men have pain. Pain nearly all goes away. The biggest problem is that many men have curvature that precludes them having sexual intercourse. So there's physical impairment, and nearly every man has psychological bother, with 35% of men having depression at the time of presentation with Peyronie's disease. If you have Peyronie's disease, if you think you have Peyronie's disease, go see a Peyronie's disease expert. Not every urologist loves Peyronie's disease in their practice.
Yeah.
Okay? Sexual Medicine Society of North America, smsna.org to find one of those.
Beautiful. And Peyronie's disease, do you see it after prostate treatment ever?
The risk of Peyronie's disease is increased after radical prostatectomy. Okay? That's accumulating yet to be published data.
Listen, I thought, what's a gift that no one has ever given you? That only the people on the inside that know the great Mulhall could give them. And I want to see if you can catch this gift, which is kind of serious. We went, in PCRI, money is no object. We'll skip mortgages if we have to get gifts to our speakers. I we've actually found this cup finally from Ireland. And it's from a town in Ireland.
Ringaskiddy, yeah. Sure.
Ringaskiddy. Have you heard of it?
Of course I
Do you know?
Ringaskiddy.
Do you know why Ringaskiddy? So Ireland is important to you. You may move back there one day, or you spend a lot of time there, but Ringaskiddy has an important place in urology because I read that tell me if I'm wrong here, I read that the big factory that makes
Pfizer.
The largest producer of Viagra around the world is in Ringaskiddy. Is that true?
I think it's the largest center in Europe, and it's purported that after the introduction of Viagra in 1998, the birth rate went up in the Ringaskiddy area.
So can you hold up that cup? You have a Ringaskiddy Ireland cup, which is associated with Dr. Mulhall and Viagra and all things.
I'll put this alongside my gold cystoscope.
Listen, I'm glad you're here. I'm glad you're doing well. Thank you very much. I really appreciate
my
your time.
pleasure.
Thank you. Absolutely.
I'm going to run to the airport.
All right, you're going to run.
Thank you, Dr. Mulhall, and thank you, Dr. Moyad. That was very helpful. I want to remind everybody to visit the exhibit hall on our conference webpage, where you can find many valuable resources and information on treatments, payment assistance plans, and more. Our next speakers are Dr. Steve Kurtzman, who's the Director of Prostate Brachytherapy at Western Radiation Oncology, and Dr. Ankit Agarwal, who is the Director of Radiation Therapy, also at Western Radiation Oncology. They're both experts in their field of brachytherapy. Now, Dr. Kurtzman has done over 7,000 brachytherapy procedures, and Dr. Agarwal does over 20 brachytherapy procedures a month. Between the both of them and their Q&A with Dr. Moyad, we will get an in-depth look at what is brachytherapy, who is eligible, and what are the outcomes. So without further ado, we welcome Dr. Kurtzman and Dr. Agarwal to our conference.
Hello, I'm Dr. Stephen Kurtzman. Let me start out by saying it's very much of an honor to be asked to talk for Prostate Cancer Research Institute. Thanks to Alex and Dr. Mark Scholes. Before I start, let me make one comment about Dr. Scholes. He is truly a unicorn. When my patients ask me should they get an opinion regarding localized treatment for prostate cancer, my answer is generally most medical oncologists don't know which armpit the prostate is under. Dr. Scholes, of course, is one of the most knowledgeable physicians I've ever met for prostate cancer, and very unique for a medical oncologist. Today, what we'd like to talk about is low dose rate prostate brachytherapy. My partner, Dr. Agarwal, and I will be giving this talk today. Dr. Agarwal joined me a little bit over a year and a half ago and has become an amazing prostate brachytherapist in his own right. And eventually he'll become better than me. Not quite yet, but eventually he will become better than me. Myself, I've been doing this pretty much nonstop since 1999. I started prostate brachytherapy in San Mateo, California in 1999, a single hospital-based facility. I was actually taught prostate brachytherapy by a commercial outfit known as Proceed from Bard Urologic. And it was actually a wonderful program that had proctors and staff support, and it really was a turnkey operation to learning how to do prostate brachytherapy. And I was taught by experts, and fairly shortly after starting, they came to me and said, hey, you seem pretty good at this, how about you come and travel and teach it as well? So for a few years, I actually traveled the country with them teaching prostate brachytherapy as well, which quite frankly was probably more of a learning opportunity for me than it was for the people I taught. I really did learn a lot every time I went out and taught prostate brachytherapy. One of the things that developed my practice as sort of a far-flung practice was in about 2000, I was introduced to a group of urologists in a town called Los Gatos, which is about 40 miles from San Mateo. And I was able to set up a program with this group of urologists that became very successful. And what it made me realize was that I could take this practice and expand it. I realized that people weren't going to come to me. They weren't going to drive over bridges and come long distances on crowded San Francisco highways. So I was able to bring prostate brachytherapy programs to the different communities. And today we do prostate brachytherapy in about half a dozen facilities in San Francisco. We do it in Fresno. We do it in Newport Beach, Palm Springs, and even Phoenix. And we continue to expand. And I'm very proud of that because I think we've kept this procedure alive and even expanded it in an age where it has not been expanding. What we'd like to go over today is several things. We want to talk about the actual procedure itself and the patient experience from basically consultation through the end of the procedure. Dr. Agarwal will do some of the heavy lifting. He's going to go over a lot of the clinical data associated with LDR prostate brachytherapy. He will then talk about the advanced technique that we use called real-time intraoperative planning, and he'll get into that in quite some detail. And then I'll come back and I'll discuss some of the advantages and compare and contrast LDR brachytherapy with other treatments. Brachytherapy has actually been around for quite a while. It started in the 1970s, and it was a very primitive procedure, and surprisingly, it still actually worked about half the time if you look at some literature. The way the procedure was done back then, it was an open procedure in the operating room, meaning they actually opened the patient, exposed the prostate, and then the radiation oncologist would essentially blindly, not blindly because they could see the prostate, but they would almost randomly place seeds directly into the prostate. There was absolutely no treatment planning system. There was no way to even evaluate whether you had a reasonable dose distribution. Also, they would actually do a pelvic lymph node dissection usually at the time, because in the 70s there was no good imaging studies to look for any pelvic adenopathy like we have now. And again, surprisingly, as primitive as that was, about half the patients did quite well with that procedure. In its modern form, prostate brachytherapy really began in the mid to late 1980s with the advent of transrectal ultrasound imaging, which really allowed for a coherent way of placing seeds within the prostate, doing it under direct imaging with ultrasound. The group that really advanced prostate brachytherapy the most was the group at the Seattle Prostate Institute. And that was John Blasko, Peter Grimm, and their associate, John Sylvester. And they came up with a way of very coherently placing needles, placing seeds, and what you saw was tremendous results, tremendously high cure rates, tremendously low complication rates based on the quality of the implant that they did. And they developed what we call a pre-plan technique, which is still commonly used. The next advance in prostate brachytherapy really occurred in the early to mid 2000s with the advent of what we call real-time treatment planning ability. And basically that's what we do. What we're able to do is we're able to capture sequential images of the anatomy on ultrasound imaging on our computer. We're able to create a three-dimensional reconstruction of the anatomy, including the prostate, the urethra, and the rectum. And then in real time, watching on the computer how the dose distribution is being created, we can then go ahead and place the needles and the seeds and literally watch the dose to the prostate, the urethra, and the rectum, making sure that we're giving a tumoricidal dose to the entire prostate, while at the same time minimizing the radiation to the urethra and rectum, which of course will minimize any risk of long-term complications. Dr. Agarwal is going to get into the details of that procedure. Unfortunately, brachytherapy really began to decline significantly right about that time. And the reason is a couple things. Number one, in the mid-2000s, external radiation techniques actually improved quite a bit. So you had the advent of what we call intensity modulated radiation therapy, which really superseded what we call 3D conformal therapy. I mean, it was a quantum leap in improvement. Again, and we're going to get into this later in the talk, still, I think, not quite comparable to what you can get with brachytherapy, but a big improvement, and quite frankly, it also reimbursed tremendously well. So there was a financial incentive to do IGRT rather than any other type of treatment. That kind of backfired on the radiation oncology community, because the other thing that happened was large urology groups realized, hey, we can get in on this party. They started building their own radiation oncology facilities because the reimbursement was so lucrative. So they started doing external radiation instead of things like prostatectomies or brachytherapy. Another thing that happened, quite frankly, was that there was a big scandal. In fact, this is where I trained. I trained at the University of Pennsylvania, And the VA hospital associated with the University of Pennsylvania, there was a big expose. The quality of the brachytherapy was terrible. Half the patients had most of the seeds outside of the prostate, and there was just, as you can imagine, terrible, terrible outcomes. And to me personally, this was not a surprise. I'll tell a personal story, because these are the guys who trained me to do brachytherapy, believe it or not. I was about a week into my residency training when I went to the operating room to do my first implant. And what happened was the attending physician basically just yelled at me the whole time to hurry up because OR time was expensive. I shoved a bunch of needles in the prostate. I shoved a bunch of seeds in the prostate. We left the operating room, and I thought to myself, I don't know anything about radiation oncology, but what just happened in that operating room could not possibly be right. And it turns out that that was true. It was just terrible quality, which again is one of the problems. We'll talk about this later as well. One of the problems with brachytherapy is that it's a very specialized skill set that really needs to be developed. So why do we believe in LDR brachytherapy when over the years it's declined in prevalence? Well, if you look at the data, and again, Dr. Agarwal will go over this, tremendously high cure rates across all risk groups, low, intermediate, high risk groups. Very low complication rates. Again, partly because we can do such a great job of minimizing radiation to surrounding normal tissue, and it's organ preservation, meaning we don't have to cut out the prostate, we spare the urethra, we spare the sphincter, so incontinence rate, impotence rates are a fraction of what you see with other treatments. And quite frankly, it's an extremely convenient treatment for patients. The implant itself is a 15 to 20 minute procedure in the operating room with them asleep. They go home an hour later and literally can resume all their normal activities immediately. One of the things that we need to be very conscious of when we're selecting our patients is what we call risk stratification groups, because not all patients get the same treatment. Not everyone just gets a seed implant. We really customize it to the risk stratification group. Low risk patients consist of patients who have Gleason score 3+3 disease, that's the least aggressive type of prostate cancer, a PSA of less than 10, and either no palpable disease or minimal palpable disease on digital rectal exam. Favorable intermediate risk category is basically the same type of patient, but has Gleason score 3+4 prostate cancer. So mostly type 3 and some type 4, okay? Unfavorable intermediate risk patients consist of anybody who has 2 or more intermediate risk factors or a Gleason score 4+3 cancer. High risk patients are PSA over 20, Gleason score 4+4 or higher, or evidence that the cancer has spread beyond the capsule of the prostate. That's called extracapsular extension in any combination of those. And then there's very high risk patients, PSA greater than 40, anybody with a Gleason score 9 or 10 cancer. So low risk patients they're going to do well with any type of treatment. They can do active surveillance. If they choose a treatment, they're going to have a tremendously high cure rate no matter what they do. Again, we favor brachytherapy because of the organ preservation, because of the controlled deposition of radiation, minimizing it to the surrounding normal tissue. Again, tremendously high cure rates, tremendously low complication rates. The intermediate or the favorable intermediate risk patients, again, patients with 3+4 and otherwise low risk factors, used to be a controversy. A lot of people thought those patients need a combination of both brachytherapy and external radiation. Several years ago, a definitive randomized trial showed that those patients do no better when you add external radiation. So our recommendation for those patients, again, brachytherapy alone. Unfavorable intermediate risk cancers, this is where there's a little discussion with the patient. So some of these patients, for instance, if a patient has low volume Gleason score 4+3 and otherwise low risk, I don't automatically tell that patient you need combination therapy. They have a small, probably single percentage point risk of having occult lymph node involvement. They have a small risk of having what we call extracapsular extension. But we can actually encompass the extracapsular area of the prostate with brachytherapy. Again, Dr. Agarwal is going to show some slides that show what I mean by that. Some patients, however, if they have 2 risk factors, generally we will recommend both seed implant and external radiation, which again will dose escalate to the prostate to get a very high dose to the prostate, again minimizing the surrounding normal tissue. Also will encompass some of the first echelon lymph nodes to eliminate any potential micrometastatic disease. High-risk patients, these are the patients that we virtually always recommend combination brachytherapy and external radiation. Very often we will add hormone therapy, androgen ablation therapy. The traditional thinking for these patients who get external radiation alone would be to keep these patients on hormonal therapy for a minimum of 18 months. However, there's plenty of compelling evidence that patients who get combined brachy and external rather than external radiation alone can probably be spared that long-term hormone therapy, which has a lot of benefits, both short-term and long-term. And again, Dr. Agarwal will talk more about that. And the very high-risk patients, these are the patients we throw everything at them. Seed implant, external radiation therapy, and these are probably the only patients that we do recommend stay on hormonal therapy long-term, 18 to 24 months. Okay, at this point, I'm going to turn this over to Dr. Agarwal, and he's going to go into the clinical data as well as the procedure itself that we do.
All right, thank you, Dr. Kurtzman. So I'll be talking about the evolution of prostate brachytherapy. You know, as we've talked about going from an open prostatectomy to a robotic prostatectomy, 3D radiation to IMRT radiation, similarly, brachytherapy has gone through a transformation in terms of types of techniques. So pre-planned brachytherapy is a technique that's still used a lot across the country. The way that's basically done is that patients are brought in a week or a month before the procedure. There's an ultrasound that's captured, looking at their rectum, their prostate, their urethra, and then based on that, a computer creates a plan saying, you know, put a needle into B7, put 3 seeds there, a needle into D3, put 4 seeds there, and recreate that a week or 4 weeks later. On the day of the procedure, you have to exactly put that exact same position of the patient, same ultrasound position. And essentially what you're treating is the grid, not really the patient on the day of procedure. That creates a lot of problems for some patients. Sometimes there's pubic arch interference, sometimes the anatomy doesn't exactly line up, and sometimes there's extra toxicity or not as good cancer control because you can't exactly put the seeds where you want to. Now, a lot of folks do great pre-planned brachytherapy techniques, so I'm not denigrating that, but there have been advances that allow us to be a little bit more conformable. This is how intraoperative planned brachytherapy is done. So just looking at the image first, you can see we capture in real time where the urethra is located, you know, that red arrow in the middle, that green circle, where the prostate is, the red circle, and the rectum, you know, the blue area in the back, as well as you can see there's a spacer gel separating the prostate from the rectum here. So we capture anatomy in 3D, reconstruct the prostate, the rectum, and urethra. We place the actual needles in, and then we actually put the seeds in the appropriate location for the patient. So we'll look at a video here. If that plays. Actually, we'll look at one slide here. So you can see I first, in this patient, placed the needles on the computer, but the needles were maybe, you know, a little bit off. I adjusted the needle location in real time, and then looked at the actual dosimetry and seeing whether I'm still covering the prostate well, whether I'm still sparing the urethra. And one thing you can see is that the green area around the red prostate is what we call the 100% isodose line. It's showing where the 100% radiation dose is going. So you can see we're actually treating areas outside of the prostate, getting that extra capsular extension treated as well. Here's another video. You can see that, you know, I wanted to bring the needle a little bit down, so in real time, I brought the needle down on the computer, looked at how that affected the doses, make sure I'm not overdosing something, making sure I'm depositing the seeds exactly where I want to according to the computer plan. This next video, I'm depositing a seed at the base of the prostate near the bladder and one at the apex, and that's exactly what I'm visualizing in real time. And then based on where I actually deposit the seeds, I may actually change the plan on the computer in real time too and see how that changes the radiation plan, whether I need to deposit extra seeds somewhere, add an additional needle, etc. Now this video clip is really important. I'll let it play first and then talk about what we're doing here. Essentially what we're looking at here is that central structure in the middle with a little of a black area and some white area around that is the urethra. That is a structure that's very sensitive to radiation. If you deposit a lot of radiation seeds around the urethra, patients will oftentimes get obstructed, will need a Foley, rarely even have urethral strictures. So in this case, I saw where the urethra was localized. I brought the needle a little bit down and deposited the radiation seeds away from the urethra. This type of real-time planning really allows you to optimize the radiation dose, decrease toxicity. So how is real-time intraoperatively planned brachytherapy different than old brachytherapy techniques? Basically, you have better anatomic information, more precise implants. I'm really changing the radiation plan as I'm going on the fly. You know, in the external beam world, we talk about adaptive radiation therapy, MR-guided radiation therapy, looking at patient motion, and that's exactly what we're doing, except we're being even more precise by depositing radiation seeds which don't emit radiation as far as something like external beam radiation would. So this, results in better cancer control, decreased toxicity. There's plenty of retrospective studies showing that. And finally, save time in operating room, right? I'm not trying to reproduce how do I get the needle to A3 to exactly where it was lined up 4 weeks ago. I can adjust the radiation plan and see, does this still work? Yep, if it doesn't work, I can adjust the radiation plan on the fly. So what is a patient experience? What do I tell a patient when I see them in consult in terms of what they expect with this procedure? So essentially, I tell them you're gonna come in at 7 a.m. in pre-op. There's gonna be an anesthesiologist who talks to you. You'll come in an operating room at 8 a.m. We'll put you to sleep in 15 minutes. We'll do the procedure over about 20 minutes. You'll be back in the post-operative area at 8:45, be waking up, say hi to your loved ones. We'll come say hello, tell you the procedure went well. You'll be home at 10 a.m. And essentially patients go home with no Foley, do really, really well. It's an outpatient, relatively quick procedure. How do patients do afterwards? So the only real limitation I tell patients is, one, because of the small amount of radiation seeds in their pelvic area, if there's any kids under 13 years old, you don't want them sitting on your lap for about 6 weeks. If there's any pregnant women you can be around them in the same room as them, but I would keep a 3 to 6 foot distance from them, again, because of the small risk of radiation to the fetus. And lastly, if you're a man who has sex with men, I would not have any anal receptive sex for about 6 weeks, again, to protect your partner. But otherwise, patients can basically return to all their normal activities immediately. They don't need any kind of prescription pain medicines. I tell them, you're gonna have a little bit of soreness, like the biopsy, for a couple of days, but you don't need any kind of prescription pain medicines. And the main short-term side effect is urinary irritated and obstructive symptoms. So getting up more at night to urinate, more urgency, more frequency, rarely some burning with urination. Typically, if there's no contraindications, I'll prescribe most patients tamsulosin or Flomax, as well as naproxen. And I'm actually not prescribing naproxen for pain, it's for inflammation. So, typically 7 to 10 days of naproxen or Aleve twice a day. And most patients have minimal to really no rectal symptoms, especially with modern rectal spacing. Long term, this is where patients do really, really well. We'll get into the cancer control, but what are the side effects? What does the patient's quality of life look like? So unlike something like surgery, you have no risk of urinary incontinence. Ultimately, this is organ preservation. We're not changing a patient's anatomy. They're not going to be leaking urine. And using modern intraoperatively planned brachytherapy techniques, the risk of long-term, what we call grade 3 GU or GI side effects or clinically significant side effects is about 1%, very, very low. And the risk of impotence, according to some trials like the PROTECT trial, is about 10 to 15% with brachytherapy, which is much lower than something like prostatectomy or external beam radiation therapy, and typically be able to be treated with Cialis or Viagra. The other side effect I do tell folks is that they probably will have a dry orgasm after brachytherapy. So, I talked a lot about intraoperatively planned brachytherapy, old techniques. Does that actually matter? One of the criticisms I often hear about brachytherapy is, sure, you're improving cure rate, but patients' quality of life is not as good. And that's just not quite true. So I want to talk about these 3 large trials and talk about toxicity and why it's different. So the ASCEND-RT trial, which is an excellent trial, shows great outcomes, had very few requirements for brachytherapy. Essentially, if you were enrolling on the trial as a physician, you had to have no prior brachytherapy experience. There was no training requirement specified. Essentially, patients were given stranded pre-planned needles. So they were said, here's 15 needles with 1, 2, 3, 4, or 5 seeds each, and you just have to deposit that based on the pre-plan. There was a little bit of a treatment margin, so you were treating around the prostate. There was no independent review of implant quality, so physician A may have been doing a great job, physician B may not have been. And as a result, you saw that the late grade 3 GU toxicity, that's things like late pain with urinating, significant frequency, hematuria or blood in your urine, was about 18.4%, quite high. Now, when you look at the R2G0232 trial, which I'll delve into what that is, that also didn't specify any prior requirements for brachytherapy. It did do mostly a pre-planning technique, but they said you had to visualize the urethra during brachytherapy and make sure you're planning around that. There was still no centralized quality control, but each physician had to submit their post-implant dosimetry, or basically what they were able to get with their brachytherapy plan. And the toxicity was much lower. So instead of 18.4%, it was about 8% for the combination of brachytherapy and external beam radiation therapy, and about 3.8% for brachytherapy alone. Now, this last study is really the modern experience of how brachytherapy is done, or how at least we do brachytherapy. This specified that any physician enrolling had to at least have treated 50 patients with brachytherapy. They all got a standardized brachytherapy training session. They used what's called a MIC applicator, which allows you to essentially put radiation seeds wherever you want, the base at the apex, specified throughout the prostate. It really allows you to adapt the radiation plan. And all of the patients got real-time computer-assisted intraoperative technique. And finally, there was quality control. A centralized group looked at what's called a post-implant dosimetry of all the patients, and it was done in the modern era, 2010 to 2012. And that's where you find that the late grade 3 GU toxicity was less than 1%, which is pretty incredible and is really the modern experience. So next I'll get into, how do patients actually do? If you have low risk cancer, intermediate risk cancer, high risk cancer, what do you expect in terms of your long-term outcomes? So let's go first into low risk and favorable intermediate risk cancer. This was a study that was just published in 2023. Essentially it was looking at about 9,000 patients treated across the world, the US, Japan, Canada. They were treated with palladium and iodine 125. Just quickly looking at this table, which shows what type of patients were involved, it was mostly folks in their 50s, some in their 60s, some in their 70s. About half of patients were what's called low risk cancer. About half of them had intermediate risk cancer. And effectively, the outcomes were very, very good. So, they did show that the outcomes for palladium were better than iodine. We tend to favor palladium 103 for a variety of reasons. But the 7-year freedom from biochemical failure, or basically not having your PSA going up, not having your prostate cancer coming back, not needing any more hormone therapy or something down the line, other salvage treatments, was 96.2%, which you can look across the data, other studies, really hard to find that good outcomes with any other treatment modality, especially with a sort of real world data with 9,000 patients like this. So next, as Dr. Kurtzman alluded to, what do we do with these patients with intermediate risk cancer? Are we just doing brachytherapy? Are we adding external beam radiation therapy? So this was a randomized trial of about 600 patients. They all got brachytherapy or brachytherapy plus external beam radiation therapy. Bottom line, the results were very similar. Essentially, the biochemical control rate at about 5 years was in that 85 to 88% range, regardless of what you got. But if you got the combo therapy, external beam radiation therapy, your toxicity went up, sort of your long-term quality of life was worse. It was a 3.8% toxicity rate for brachytherapy alone versus 8.2% for the combination. And frankly, we consider these results a little bit inferior, both in terms of toxicity, which is a little bit higher than what you see with the modern experience, modern techniques, and outcomes, frankly, are a little bit lower than what we would expect as well. So, people may accuse me of nitpicking, picking the studies that I like, and that may be true, but what I really like to direct patients to this website, Prostate Cancer Free, which is basically a constantly updating meta-analysis of a lot of studies that have been published out there for prostate cancer. On the y-axis, you see outcomes with 100% being, really good control rate, 0% at the bottom being the cancer, was not controlled. On the x-axis, you see how far out patients were followed after treatment. And the blue circle is basically all the brachytherapy studies for folks with intermediate risk prostate cancer. You can see generally they were in that high 80 to 100% range. You can see surgery was a little bit lower at the 60 to 80% range, and the external beam radiation therapy kind of right in the middle there as well. So I really direct patients to look at this data on their own, figure out which treatment truly provides the best cure rates. So let's go into high-risk prostate cancer patients. We see a lot of these folks, and this was a large trial primarily done in Canada, which looked at folks with high-risk prostate cancer and some intermediate risk, randomized them to external beam therapy plus hormones or external beam therapy plus ADT plus brachytherapy. And they found, bottom line, that the cure rate or the progression-free survival increased from 67% to 85%. So really, effectively doubled the cure rate for these patients with prostate cancer. The one criticism, again, was that the toxicity or side effects for the folks who got brachytherapy was higher, but they did use older techniques and different techniques. There was no centralized quality control. And I would still argue that a 20% improvement in cure rate is quite meaningful to patients. This was another interesting study, essentially showing that brachytherapy provides an ablative dose of radiation therapy. This was looking at folks, again, in that ASCEND-RT trial, looked at how many patients got a PSA of less than 0.2, or basically undetectable, if you got the combination versus just external beam radiation therapy. For intermediate risk patients, it was 91% versus 31%. Those intermediate risk patients who got just external beam did have a detectable PSA typically. For high risk patients, it was 77% versus 32%. So clearly a big difference in terms of providing ablative radiation therapy to the prostate itself. Again, bringing a prostate cancer-free graph here, the blue circle is folks who got brachytherapy plus external beam plus hormones, high-risk prostate cancer. You can see those are just far and above the surgery numbers or the external beam plus ADT numbers here. Finally, let's get a little bit into androgen deprivation therapy. It's certainly not the focus of this talk, but a lot of folks I see in consult or in follow-up tell me, the radiation or the surgery or whatever was fine. I hated the hormone therapy. I was tired, I was having hot flashes, my sex drive went down, and all of those things happen. And folks on long-term ADT, typically have cardiovascular metabolic changes. They can gain weight, they can develop type 2 diabetes, body habitus changes. So frankly, it has a big impact on the quality of life of patients. And typically, the NCCN says for folks with high-risk prostate cancer, if you're getting brachytherapy, maybe just a year of hormone therapy. If you're just getting external beam, a year and a half to 3 years. But this study, was just recently published, and it essentially shows that that's not true in a setting of brachytherapy. So this was a trial published in Japan. It was a randomized controlled trial of only high-risk patients with high-risk prostate cancer. All of them got external beam therapy plus brachytherapy, and they were randomized to 6 months of ADT versus 30 months of ADT. And bottom line, these were fairly high-risk population of patients. About 30%, 33% patients had Gleason 8, Gleason 4+4. About 15% had Gleason 4+5 disease. So quite a high-risk population of patients. And essentially, they showed no difference in outcomes. So the failure rate at 10 years, 9 years was about 10%, regardless of whether you got 6 months of ADT versus 30 months of ADT. And you save patients a ton of toxicity from that long-term androgen deprivation therapy. The median post-treatment PSA was 0.03, so most patients essentially developed an undetectable PSA after this combination therapy. And again, this was a study where they showed very little long-term toxicity from that combination therapy. So I typically argue, if you have very high-risk prostate cancer, you have a PSA over 40, you have Gleason 5+5 disease, you may need long-term ADT, 2 years, a year and a half, maybe even an addition of abiraterone. But other folks, especially with this new data, I typically say 6 months of androgen deprivation therapy is very reasonable if you're doing the brachytherapy combinations. A lot of folks say, hey, if I'm just doing external beam or 2 years of ADT or external beam plus brachy plus 6 months of ADT, that's a really attractive proposition to a lot of our patients. So let's just summarize. What are patient outcomes? Low-risk prostate cancer, the biochemical control rates anywhere from 90 to 98% with brachytherapy alone. Intermediate risk prostate cancer, again with brachytherapy alone, the outcomes are 85 to 98% biochemical control rate. And for high risk prostate cancer with external beam plus short-term ADT, again 85 to 91% control rate, which if you compare against any other treatment, really hard to find those types of numbers. So really harping on a point, brachytherapy outcomes are operator dependent. And this is sort of an interesting side-by-side comparison of two brachytherapy plans. You can see that on the left side, the yellow line is the 150% radiation dose. And what we're classically taught is you do not want that line to touch the urethra, or you're going to get toxicity. Patients are going to get obstructed. They may need a Foley. And you can see that the yellow line is touching that urethra. This is not a great brachytherapy plan. Versus on the right, you can see that the yellow, is sort of on the periphery. You're kind of dose escalating potentially in areas where they have more aggressive disease, but you're not really touching the urethra with that 150% radiation line. And so I'll just end again with this table before I turn it back over to Dr. Kurtzman, talking about the different toxicities. So, what I tell folks is there's a lot of excellent treatments for prostate cancer. But if you're going to choose brachytherapy, you want to make sure someone who's doing it has modern techniques. If you don't find someone who can do that, frankly, maybe don't choose brachytherapy because there's a lot of bad brachytherapy out there too, unfortunately. So I'll turn it back over to Dr. Kurtzman. He'll talk a little bit about different treatment options, why brachytherapy is not as prevalent as it could be. And thanks again to PCRI and Dr. Scholes and the entire team for having us out here.
Okay, well, this is actually my favorite part of the talk. Let's compare and contrast brachytherapy to other treatment options because quite frankly, that's what patients are interested in, right? They're really looking for what should I do, and their urologist is telling them something, the radiation oncologist down the street's telling something, their cousin from Cleveland has a strong opinion about what they should do, and it's a confusing mess for most patients. And again, we try to keep this data-driven as well as explain the rationale for why we believe brachytherapy tends to work better when we go through these things. So let's talk about prostatectomy, external beam radiation therapy in its various forms, proton beam therapy, and another type of brachytherapy called high dose rate brachytherapy. That's a picture of a Da Vinci robot. That's for doing robotic prostatectomies. It's a $2 million machine. This is a picture of a typical linear accelerator, which delivers photons or X-rays for all forms of external radiation. That's a picture of a proton beam unit. It's incredibly expensive, at least $50 million, and only located in a few locations because it's so expensive. And that's a picture of everything we need to do brachytherapy. It all fits in the back of my car, and there's my treatment planning computer, the ultrasound, the stepper stabilizer. Quite frankly, the most expensive piece of equipment in this slide is my car. Okay, so let's talk about external beam radiation therapy first versus permanent seed implant. So I'm a radiation oncologist. I'm trained to do all of this. But the problem with external radiation therapy, again, in all its forms, whether it's conventional, whether it's SBRT, which is a quicker form where you come in for maybe 5 treatments, the problem is it's always done with high energy radiation beamed from the outside at the prostate. Everywhere those beams enter and exit your body, by definition, it's going to radiate all the tissue along that path. Okay, that's just the physics of it. It's not avoidable. And the problem with that is this. It's not that it's going to cause crazy high-risk complications, but the reason it doesn't cause complications is that we have to stop at a dose where we won't get those complications. And quite frankly, that dose is significantly lower than we can achieve from a seed implant because, as we'll talk about, the seed implant is going to minimize the amount of radiation to the bladder and the rectum relative to external radiation. So it's what we call a poor therapeutic ratio. Higher dose to the normal tissue, which compromises our ability to get dose to the prostate. The other problem with external radiation in all its forms is that you are aiming the radiation at a target that you're not visualizing directly, meaning the prostate. And we know for a fact that prostate motion, both from patients moving during treatment and even internal motion of the prostate, can cause issues. And in fact, we always have to build a fairly wide margin around the prostate with the radiation to make sure that we don't miss parts of the prostate, again, increasing the amount of normal tissue that's going to be encompassed in a treatment field. So this is a picture of what I'm talking about. So if you look at this diagram, the teal area that you see is where the dose has dropped off to about 35% of the full dose that we prescribed. And you can see in this image, that 35% dose line is all the way out still at 10 centimeters, and everything closer is getting a higher dose. So it's a gradient from 100% of the dose at the periphery of the prostate, and it's just radiating a lot of that pelvic tissue, including the bladder and the rectum. So what is the advantage then of the seeds compared to external radiation? And fundamentally, it's exactly the opposite in all respects. So the radiation from the seeds, from the individual seeds, very low energy radiation. It's what we call 21 kV energy, kilovolts, as opposed to usually 6 million electron volts for high dose, for external radiation. And what this translates to is when we place the seeds within the prostate, because it's such low energy, it just doesn't penetrate. So we can escalate the dose to the prostate, but that dose of radiation is going to fall off tremendously rapidly, minimizing any radiation to the surrounding normal tissue. There is no targeting issue with seed implantation because we are literally placing the radiation directly into the prostate. So when the patient moves and the prostate moves, the treatment moves with it. And it's a continuous low dose application of the radiation to the prostate over about a 2-month period where it's decaying away. And here's an example of what I'm talking about. So again, if you look at this, the green line surrounding the prostate, which is drawn in red, the 100% dose, we're covering a small margin around the prostate in case there's any extracapsular disease. But if you can see there in the lower right corner, the dose of radiation down to the 35% line is by 0.7 centimeters, 7 millimeters. It's already dropped down to 35, as opposed to about 10 centimeters for the external radiation. A dramatic decrease in exposure to normal tissue. Okay, so let's talk about seed implant versus prostatectomy. So the advantage of seed implant to prostatectomy is that it's organ preservation. The problem with a prostatectomy is that anytime you open up a patient, cut out the prostate, have to reattach the urethra, you're going to have a much higher risk of both incontinence and impotence, especially if the neurovascular bundle can't be spared. Then you're going to have essentially 100% impotence. The other big problem with a prostatectomy is that it does not cover the extracapsular area. And this is what patients don't understand. And I understand this. Intuitively, you would think, well, if they cut my prostate out, how could that not work? And the answer is, it doesn't work because they leave cancer behind all the time. So we know that if you have one of two things, either something called extracapsular extension or a positive margin, and what this means is when they take out your prostate and they look at the tissue under the microscope, if the cancer has penetrated through the capsule surrounding the outside of the prostate, or if the cancer comes right up to the edge where they cut the prostate out, it's extremely likely that they left cancer behind. And then the recommendation would be to do a full 8-week course of daily radiation because they didn't get the cancer out. So the reason that the prostatectomy falls apart when it doesn't work is that they are not able to take a margin, as opposed to the seed implant where we automatically build a margin. So even if there is extracapsular extension, we can encompass that. And the problem with this, of course, is if you need radiation after a prostatectomy, it's a bad deal. I mean, you've now bought 2 definitive therapies. You're going to be at risk for all the complications associated with both treatments. And it's even worse because what happens is the bowel and the bladder pretty much falls into the area where the prostate was. So you're really just radiating a lot of bowel and bladder if you need radiation after a prostatectomy. Low-risk patients, this probably isn't much of a problem because they're probably not going to have extracapsular disease or a positive margin. But as you get into the intermediate and high-risk prostate cancer, to me, it's a bad idea to do a prostatectomy because it's not unlikely that they'll leave cancer behind and you'll need external radiation after the fact. Okay, let's talk about high dose rate brachytherapy, which is another form of brachytherapy. The big difference between high dose rate and low dose rate brachytherapy is how the radiation is delivered. So the procedure itself in the operating room is essentially the same. We go in, under ultrasound guidance, we place needles, but instead of dropping the seeds for high dose rate brachytherapy, we leave catheters sticking out of the perineum, that area between the scrotum and the anus. And then a treatment plan is created. The patient's under either general anesthesia or spinal anesthesia. A plan is generated. The patient is hooked up to a machine that runs a highly radioactive source into the catheters delivering the radiation. The procedure in the operating room generally takes about 3 hours, and then you have to repeat the process a week later. Because if you try to give all the radiation dose in one fraction, we know that that potentially increases complication rates because it's just too much at one time, and also has poorer cancer control, okay? So the procedure itself is just far more cumbersome than a seed implant. But in my opinion, that's the least of it. The other two things that I find somewhat unappealing about HDR is what I refer to as the physics and the radiobiology. And what I mean by the physics is that the energy of that source of radiation for high-dose rate brachytherapy is literally 15 times higher than the seeds. And again, like we talked about for external radiation, the higher energy, the more tissue you're going to expose. And again, you can see in this, the isodose lines are expanded far beyond a few millimeters. So you're again clearly radiating far more bladder and rectum when you use high-dose rate brachytherapy based on that high energy. And then the last thing, and the thing I probably like least about HDR, is what I call the radiobiology. And what I mean by that is the fact that the entirety of that radiation dose is delivered over a matter of minutes over 2 procedures, it's still an extremely high amount of radiation therapy to get over a rather short period of time, as opposed to the seed implant, which is gradually depositing the dose to the prostate over a period of almost 2 months. The problem with giving a big whopping dose of radiation over a short period of time is that it can overcome the ability of normal tissue to repair. So this is particularly a problem for the urethra. So you'll see something called urethral stricturing, not terribly common, but certainly more commonly than you would see with a seed implant because of that damage sustained to the urethra over a very short period of time. Okay, let's talk about proton therapy, because we get a lot of questions about proton therapy. Proton therapy, it's a good treatment. It's not a bad treatment, but I always refer to this as it's emblematic of everything that's wrong with American medicine. And what I mean by that is this: it's this wildly expensive treatment that has not only no better outcomes, but quite frankly, much higher risk of rectal complications. So again, terribly expensive treatment with really no improvement in outcomes and potentially even worse outcomes. The other problem with proton beam therapy is that it's only offered at a very few locations because, quite frankly, at $50 million plus per machine, there's just not a lot of them out there. So, for instance, here in California, people will have to go to San Diego or Loma Linda. There's other parts of the country. It's just an incredible inconvenience. And it still requires daily fractionation from as many as, say, 25 to 40 treatments per day. The advantage of protons over regular radiation is that it does indeed have a lower entry and exit dose. It is more conformal to the prostate. It does minimize radiation to other tissues, although the rectum is part of the problem because it's just so close to the prostate. But the other problem with protons is they do more damage to normal tissue. And because the rectum is in such close approximation to the prostate, there has been traditionally a much, much higher risk of rectal complications, including rectal bleeding down the line. So, in my opinion, again, proton beam therapy is not a bad treatment. It's just that it's hard to find anything that's compelling or compellingly better than other treatments that are more widely available. Okay, so if what Dr. Agarwal and I are saying is true, why then is it so hard to find people who do prostate brachytherapy permanent seed implants? And the answer is, it's really for all the wrong reasons, because as Dr. Agarwal showed, when you look at clinical outcomes, tremendously high cure rates, tremendously low complication rates. So again, why then isn't it more widely available? Okay, lots of reasons. Number one, there are just very few radiation oncologists that are comfortable with brachytherapy, that know how to do brachytherapy, or even want to do brachytherapy. It's a very, very different skill set than what most radiation oncologists have. Most radiation oncologists go to work in a department. Patient comes in, they get a CAT scan, the radiation oncologist contours out the anatomy that they want treated, hand it off to a physicist who comes up with a treatment plan. They look at it, they like it, they don't, they make some changes, they sign it, that's it. Patient then goes in for his daily radiation. It's not a hands-on manual dexterity skill, okay? So that most radiation oncologists just either aren't able to do it or have no desire to do it. The other problem is that over the years, there has been a complete lack of training. Many radiation oncology programs have almost no brachytherapy training. So residents are coming out into practice and they're barely even familiar with it. So of course, they're not doing it. Third, there's a bias. Back in the day, as Dr. Agarwal mentioned, there was some bad brachytherapy going on out there. So my biggest hurdle when I started getting into this, and even today when I try to introduce urologists to this, is a lot of them said, boy, we did that 15 years ago and man, we had terrible outcomes. And they're not lying, they may very well have had terrible outcomes, but again, with proper modern technique, lowest complication rates, highest cure rates. Next, the brachytherapy requires a lot more effort. To do brachytherapy, you are spending your time in an operating room. You are away from your department. Very few radiation oncologists have a situation like Dr. Agarwal and I do where we do nothing but brachytherapy. So we pretty much spend all our time in our office doing consultations and the remainder of it's in the operating room. Most radiation oncologists are required to be in their department while their patients who are getting external radiation for all types of cancer are on treatment. So it's basically an inconvenience. And then lastly, financial reasons. Brachytherapy actually does pay less than other treatments. So external beam radiation therapy, robotic prostatectomies, certainly proton beam therapy, they all pay more, not necessarily for the doctor, but certainly for institutions that own the machine. So if a doctor owns a radiation machine, if a hospital owns the radiation machine, they are much more incentivized to put patients on for external radiation than brachytherapy from a financial perspective. Finally, let's summarize. So with modern intraoperative brachytherapy techniques, we see tremendously high cure rates, tremendously low complication rates, and I think it stacks up more than favorably to just about any other option out there. There is a wide variety of quality of brachytherapy, and Dr. Agarwal mentioned. You really do need to make sure, if you want to get brachytherapy, you gotta make sure that the person who's doing it is very experienced and knows what they're doing, because it's pretty easy to do a lousy seed implant. So it probably requires a lot of hunting before you find somebody with sufficient experience to feel comfortable with it. Okay, and along those same lines, patients should seek opinions from not only a urologist and a radiation oncologist, but they should seek an opinion from somebody who's expert in brachytherapy. Because radiation oncologist, that term, does not necessarily encompass someone who knows both external radiation and brachytherapy, so it really is well worth the time to seek out an opinion regarding brachytherapy from somebody who does a high volume of it. Good. And in case you were wondering about the license plate on that previous slide, my other car says radiatum, so that's why I can. And that's it. Thank you very much.
Gentlemen, how are you? You have broken a new record at PCRI. We're going to put this in the Guinness Book of World Records at PCRI. We've had 2 speakers for one topic.
Wow.
Right? So we thought, why not?
Okay.
You're in practice together. We assume you like each other, right? You get along.
Yeah.
So
We'll talk separately.
okay, right. I'll find out the dirt on the other one privately.
You're fired.
Oh, man.
So, this is something different, and I actually think it worked well. So I appreciate the time, and I appreciate the perspective. So now why don't we just touch on some things randomly and see what you think. First of all, I'm always curious as to what goes on outside of prostate. Prostate's this wonderful world, but there's a lot of talk of brachy outside of prostate. I think when I Googled your name, there was something even on breast cancer. I don't know. This could have been somebody else. But what's happening in the world just before we go into prostate, outside of prostate? Are people using this technology outside of prostate?
So, you probably did see my name with breast cancer. Many, many years ago, I was involved with a new technology that was used a miniature X-ray tube. and we were able to do breast brachytherapy. Breast brachytherapy has really diminished because, quite frankly, it's another example of advances with external radiation.
Yeah.
We can get really great results with hypofractionated external radiation. A lot easier for the patient, great results, so more convenient than even the brachytherapy. It's kind of the opposite for prostate.
Yeah.
But yeah, so breast brachytherapy is not not nearly as prevalent as it was. It is used for GYN cancers. It can be used for certain head and neck cancers. But I would say the bulk of it's prostate.
Yeah.
In this day and age.
I spent about a month out in India where they didn't have enough external beam, access for patients with breast cancer. So they did a lot of interstitial breast cancer brachytherapy. So I did a little bit of that there. But again, it was folks where the patients were told you can wait 4 months and get external beam, partial breast radiation, or get interstitial brachytherapy. There's still some folks doing it for breast cancer in the U.S., but it's just not as prevalent. There's a lot of 5-fraction accelerated partial breast, regimens which work great. But gynecological cancer, absolutely, it's still quite relevant.
My first question, sometimes I have to think alphabetically through questions. And I always think there's something that we don't talk about enough, but it does come up, is age. And the perception, because there's always perception and reality in prostate cancer, the perception was radiation or brachytherapy was sort of an old guy's procedure. Can you comment on just age and what's the age range of the patients that you see today?
I have no age range. I mean, it's interesting. We still hear this, and I'll refer back to prostatectomies. The patients, well, they told me I'm 58 years old, I need to have a prostatectomy.
Yeah.
Do you know where that literature is? I don't, that shows better outcomes with prostatectomy.
Yeah.
Same thing with brachytherapy. I mean, the success rate, it's irrespective of age. I mean, this treatment works well. So I don't look at a guy and say, well, you're 52 and you really should get some other treatment, or you're 85, you're okay for brachytherapy. I think the implication of that statement is that it's probably not as good as some of these other treatments. So if you're an old guy, get it. And again, nothing could be farther from the truth. Look at the outcomes, highest cure rates, lowest complication rates.
So you have young patients?
Oh yeah.
Yesterday I saw a consular patient who was 45 years old, and then I also saw a guy who was 79, and my recommendations was frankly pretty much the same.
So you have patients in the 40s. What's the oldest patient you've treated so far?
I've definitely treated a few guys in their mid to late 80s that I try almost to talk out of treatment.
Really?
And they're good health. I mean, if someone has a limited life expectancy, forget it. I won't agree to do it. But these guys with essentially, they take no prescription medications. They're active. And they're just not comfortable watching it.
Yeah.
Which is as much of a quality of life issue for some as deciding to go at risk and treating it.
Absolutely.
So I've treated men in their mid and late 80s if they insist on it, and they're healthy enough.
That's interesting. Yeah. So I think that you saw that same thing. I would always see the perception issue. The perception issue is if you're younger, you should have surgery. Surgery is a young man's sport. That was the concept, and I guess you're trying to change that.
I just, again, if somebody could please point me to the literature that shows those outcomes are better, I certainly know of none.
Yeah, I don't think it's a reality. I think it's all perception based.
Correct.
And I think the other place, just to be candid with both of you, the other place I feel that people working in radiation have missed out on, they've sort of swung and missed. Again, I'm playing Monday morning quarterback, which is so easy because I'm sitting in a chair that makes me feel like Monday morning quarterback. I think sometimes there are these vignettes or these moments where people will say something and intuitively it makes complete sense. And I brought this up for almost 20 years here. But when you think about it and you learn about it, you should comment on it. So here's the comment that tends to get people all the time. Look, Mr. So-and-so, you're young. If I do surgery on you now and it comes back, we can then do radiation. But if Agrawal and Kurtzman do seeds on you and it comes back, I can't do surgery. So I get 2 shots at cure if I do surgery. I get 1 shot at cure at radiation. Do you want to comment on that?
This is one of my favorite things to talk about.
Okay.
It's a crazy apples and oranges thing. Okay, first of all, let's talk about the opportunities for salvage. If you do prostatectomy, you have 1 salvage opportunity, which is external radiation. That's it. If you do LDR brachytherapy, you have 3 salvage opportunities. Number 1, you actually could still do a prostatectomy because unlike external radiation, the surrounding normal tissue hasn't been changed to the point where you would expect horrific complications. However, you still wouldn't do that because we can do salvage brachytherapy. We can do brachytherapy, again, either focal or even whole gland, or you could do something like cryotherapy.
Yeah.
So number one, you actually have 3 salvage opportunities. But more importantly is this, the risk of a local recurrence after LDR brachytherapy is probably in the range of 1%, if done properly, local recurrence. It's probably in the range of less than 1% for high-risk patients with combined therapy. So you're talking about a prostatectomy, particularly in an intermediate and high-risk guy, which is likely to recur, and you're comparing it to a treatment that virtually never recurs. So it's a crazy comparison to begin with.
It's just, but you have to admit, intuitively, if I mention the sentence, you kind of go, huh. But the idea of, but perhaps this is because we've grown up at a time period where not as many people are doing brachytherapy. You know, the idea of getting treatment after treatment, you probably do that all the time. Where you provide a number of seeds, then you go back a second time and provide more seeds?
Oh, we almost never have to do it.
You never have to do it.
But
But if you have to, you'll do it.
So for instance, we'll do salvage therapy on guys who failed brachy, which again, luckily is exceedingly low. We'll do salvage brachytherapy on guys who failed external radiation.
Yeah.
We've done salvage on HIFU failures, salvage on proton failures. So again, the beauty of brachytherapy when it comes to salvage is that because it's exposing such a small amount of normal tissue, we can safely do it, whereas you could never do external radiation for salvage on that because it's just going to radiate too much normal tissue. But we can so finely minimize the radiation to the surrounding normal tissue that we can use it as a salvage for almost every treatment except a prostatectomy.
Okay.
Then all you can do is external because you don't have any tissue to put the seeds in.
Yeah, I hear that comment a lot, but I tell folks you want to get it right the first time. And then again, if you are in that 1%, 2% category of folks with local failures, there are still options. I've done salvage brachytherapy for folks, and those folks have a little bit more side effects than if you're doing brachytherapy or external beam radiation therapy the first time, but frankly, most of them do quite well.
Okay.
And quite frankly, just to add on one other thing sort of related.
I could tell this struck a nerve.
I love this
struck a nerve.
Because it really exposes how much illogical thought there is. So for instance, the guys who are going for prostatectomy, high-risk guys, we know they have T3 disease. It's on the MRI, it's palpable, whatever. And they're telling them, you're going to get a prostatectomy and you're going to follow it up with external radiation afterwards. So what you're saying is, we're going to do a treatment that we know isn't going to work, and then you're going to go get another treatment that, oh, by the way, you could have had that treatment without even doing the prostatectomy. From an oncologic perspective, that's crazy, in my opinion. It makes no sense.
I can tell.
Right? You're literally saying, we're going to do a treatment that doesn't work because you can get another treatment afterwards.
No, well, I see what you're saying. I mean, some people just want the thing out, right? I mean, there's no question.
Absolutely.
But what has always made me nervous is the idea that you can't get further radiation treatment when you've had an initial one. And that's always been very strange to me. I had to put this up here because, look, the reality is that, we hear about each other. It's a small world, but it's also a big world. So when I found out how many brachytherapy procedures you've done, I thought, no, I'm sure you got that 0 wrong. In other words, there's too many zeros there, because I would have heard somebody doing that many. So since you've done so many, what's the total number that you've done now?
About 7,000.
7,000. Let me repeat that. So that's 3 zeros. It's not 700. It's 7,000. And I think that you would agree that one thing that we all share in prostate cancer is, regardless of the treatment, the quantity and quality matters, right? So 7,000 is different from 700, is different from 70. So since you're one of the only groups out there doing 7,000 or having done a lot, why don't you walk me through basically, if I can't come see you, but then after this I'm going to talk about coming to see you, I want to know who's playing in the NFL versus who's playing high school ball. And what I mean by that is, I go see a brachytherapist, I go see a radiation oncologist, blah, 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 whoever I see. How many procedures is the person doing in a week, month, year in their career that I should start feeling comfortable with? They know what the heck they're talking about. I know you can't give a specific number, but in your head, and in terms of what you're doing, and you know how much of a pro you are now compared to, say, 7 years ago or whatnot, how do you answer these questions if someone asks you, because they do want guidelines?
It is a hard question to answer. I can't really give you a number like you said, but I
You
think
give me a range.
I think you want somebody who's been doing this for at least a few years. I mean, he has the benefit. He's been doing this really for, not including residency, basically 2 years. He's already got several hundred cases under his head. He is completely proficient.
Yeah.
Right.
This is all he does.
This is all he does. Right.
Yeah.
And he has demonstrated, certainly to me and to all the urologists that we work with, that he's proficient. Right. He's only been doing this for a few years. And he's doing now, what, 20 a month?
Right.
Something
Okay,
like
so
that.
he's doing 20 a month. So wasn't that a basic standard? How many?
No, I mean, I think you could,
First of all, wouldn't you want that many in the person that treats you? I wouldn't want someone doing 2 a month.
There is nobody in the planet doing 20 a month.
Right, 20 a month seems like a very large number.
There's no one else doing this.
So you're doing 5 a week.
And
roughly.
And the number, is one thing. I've heard of a colleague of mine, her chairman was still doing 3D radiation instead of IMRT for external beam in the year 2019. He probably has lots of, tens of years experience, but he's using older techniques. So hard to gauge, of course, as a patient. You're not going to get into, what is a brachytherapy technique you're using necessarily, but, there are probably guys who've done 100 cases, but are very proficient. Use modern planning techniques, were trained well versus folks who've been doing it since 1990s, 1980s and using older techniques.
Yeah, that's a good point, but I think that also sometimes we get lost in the total number, so someone's done a lot, but right now they're not doing any.
Sure.
So, or they're not doing that many, so this is in their career versus right now.
I mean, it's a little bit like asking a Major League Baseball player,
Yeah.
how many at-bats have you had, rather than what your average is?
Sure, absolutely.
Right.
But I'd like to know both.
Well, here's what
somebody better. Can we agree on the fact that someone better be doing at least 1 a week? They should be doing them every week,
right?
Or every 2 weeks.
They should be doing well into double digits every year.
Every year, okay, well into double digits. Okay, all right.
You agree?
Double digits every year, right?
At least.
Yeah.
All right, that's perfect. And I'm not going to go through the rest of that. I want to show the other slide, and then we're going to go through the rest of my questions. I think there's a second slide there. And let me provide some background, if we can, on that second slide. So I wrote my first prostate book in the 1990s. So my claim to fame educationally is we started putting together figures. This is a figure from a text in Promoting Wellness that came out, I think it was 2002 or 3. And I'm not saying it has to be up to date. I'm just trying to give some perspective. What we learned, and those people that don't hang out with seeds anymore like me, is that there are lots of different types of seeds. There's the iodine, the palladium, and you said you do mostly palladium now.
Mm-hmm.
There was cesium, and then there's the temporary. So I'm looking at a bunch of seeds being offered. You seem to offer a certain type. Tell me once again why you offer that certain type versus the others that are in that picture.
Yeah, so to be clear, the type of seed is not critical.
Okay.
So the reason I never really used iodine, the reason I never wanted iodine is the half-life is so long. It's 60 days. Patients are being actively radiated for like 8 to 10 months, essentially. Okay, it's just they tend to have relatively mild short-term side effects, but they just last longer.
I see.
Okay, I used cesium for quite a while, and I was pretty happy with it because the half-life of under 10 days, they would tend to get through their short-term side effect even quicker, but it was a little bit more severe. Okay. Palladium to me is the Goldilocks thing here. It's 17 days, not a whole lot longer, so they have a little bit longer duration of the short-term side effects, but they're not quite as mild as iodine, but they're not as severe as cesium.
Okay.
So, and in fact, when I switched back over to palladium, it was interesting. We do this always with a urologist. The urologist that refers the patient comes to the OR with us. Many of the urologists we work with said, hey, let's not go back to cesium because our patients aren't calling us with as many complaints.
That's interesting.
So, but again, all 3 isotopes are totally reasonable. Cure rates are no different. It's just, we choose it for that reason.
But you think you found a sweet spot in palladium.
Yeah.
And then what about, we used to memorize this in lectures, that each one is the size of a rice grain. Or is that true? Is that
I describe it as a little piece of mechanical pencil lead. So it's
Okay.
about, because it's smaller than a grain of rice. It's actually like the length of a grain of rice, but it looks just like a little piece of mechanical pencil
And then the
lead.
average number of palladium seeds that you might put in on a patient, I know it can vary, but what are we talking about? Are we talking about 8? Are we talking about 80?
Probably in the range of 30 for a very small prostate to, I think I did 100 once. But probably the average is around 50 to 60. And again, we typically capture an ultrasound on the patient a few weeks before to get a size of their prostate, figure out approximately how many radiation seeds they'll need. And on the day of procedure, I'm adjusting. So
Okay.
it may need maybe 40, 45, 50, but that's typically the range.
Okay.
Yeah, so what we'll do the ultrasound and we'll do what's called a pre-plan, which is sort of a virtual implant. And we don't use that to do the implant because, again, we're going to do that intraoperative planning. But that's what we'll base the number of seeds and what we call the activity of the seeds. So a small gland, like you said, we may order 40 seeds at a low activity. For a huge gland, we might order 100 plus seeds at a much, much higher activity. The dose is the same. So the patients get the same dose to the radiation.
Okay.
How many seeds we use, the activity of the seeds to get to that dose is a function of the size.
Is it going
of
to
the
cost
prostate.
me more money to have more seeds put in? In other words, the patient's going to pay more?
Not the patient, the
Okay.
insurance.
The insurance will
but
cover
the seeds are reimbursed per seed by insurance.
Okay, so you don't see any funny loopholes or situations where the patients get stuck paying in a certain situation more than other patients?
Well, so for instance, every once in a while we'll have a self-pay patient.
Okay.
And in that case, I will do my best. I'll probably order a little higher activity so I can order a little less seeds.
Okay.
So that we're not,
Well, that's interesting.
yeah, and because again, with our treatment planning, we can accomplish anything. We're going to customize it so whatever activity we have,
Yeah.
we're going to be able to optimize that.
Okay. So how many docs around the country, the U.S., have done on average and continue to do the number of brachytherapy procedures that you've done? Can you name more than 2 or 3? Because I can't name more than 1 or 2. And that's
I don't think there's anybody doing as much currently, but there's
Yeah.
John Sylvester.
John Sylvester.
Again,
Fabulous guy.
Fabulous guy, smart, does a great implant.
Yeah,
Continues
been
to do
around a
implants.
long time.
Been around, he was with Blasco and Grimm. He was,
Right, doesn't
he
mean
really
you're
was
old,
one of
John.
the.
It just means you're seasoned.
Yeah, no, he
I know Greg Merrick was in West Virginia. I know he's trying to figure it out there, but I can't. This is the most ridiculous area of prostate cancer in the sense that, we can talk all day about how great it is and agree or disagree, but where do you go for excellence? So now let's just assume we've come to the acceptance that a lot of people want to come west to be treated. So we talked about what to look for in an expert. Let's say someone decides that you're going to be their expert, but they live in Rhode Island, they live in Pennsylvania. How does that work out? Can they come here and get it all done in one shot?
Well,
How does this work?
We actually have a lot of patients that come from quite a distance. So we have a lot of facilities that we can offer. We have several facilities in the Bay Area. We have Palm Springs. We have Phoenix. We have Newport Beach. I have a guy coming next month from Abu Dhabi who's coming in for this. And it's easy because really all they need to do is come in a day or so ahead of time, and they can literally go home the following day if they want. So I have a lot of folks fly in the day before, fly home the day after.
So they can get it done, the consult can be done over the web, and then they can
Telephone
just
or
come
video
in.
consult, and they come in for their procedure and they go home the next day.
And how do they find you? If I want to come from Michigan and I want you to treat me, how am I even finding you besides this video?
There's other word of mouth. I get a lot of, my cousin did this and he has a friend. He said you should talk to me.
There's like a church in Albuquerque, New Mexico,
that's
where
right.
we've got a few patients from them.
Yeah,
'cause they-
no, I
they
mean,
sort of,
this will be a huge ad, and appropriately. But the truth is, okay, now I found you. Now I know where you are. Now I'm a possible candidate. How long do I wait? I want, people want to be treated ASAP when they decide. How long am I waiting if I come over from Rhode Island to be treated?
It's usually just a few weeks. I mean, the
Okay.
hardest thing to do is find OR time, but we have pretty good access to OR time, but usually just several weeks.
Yeah, usually if they call in, we'll get them in for a consult, usually within a week.
Within the same week,
Within the
okay.
same week, especially if it's a virtual consult. And then from there, we get the planning process going, and a month later, they should be treated. And then for folks who need the external beam radiation therapy, folks with high risk, they'll oftentimes go back home. We'll ship all their brachytherapy records to that external beam radiation oncology physician, and they can do that closer to home.
Okay, so I come in, just walk me through just the pithy parts, including, you evaluate me, anesthesia, time, out the door. Just walk me through what you're going to take me through in 24 to 48 hours. I land, I stay in a really great hotel, and I now come to see you. Just walk me through the average person.
So
the average
basically,
day.
in that circumstance, actually the first time we meet will be in the pre-op area, right?
Okay,
Because they're coming from
that's
out of time.
interesting.
So we'll have talked on the phone at least once, usually more than that. They'll come in, obviously I'll introduce myself, they'll talk to the anesthesiologist, we bring them back, patient goes to sleep. Once the patient's asleep, the procedure typically takes 15 to 20 minutes. They go to the post-op area.
You can get all the implants done, all the seeds, all the palladium seeds in 15 to 20 minutes.
How do you think we do 700 a year?
What about if I have a really huge prostate?
It might be 25 minutes, yeah.
Right.
Okay, so that time difference is not that much.
Negligible, yeah.
Okay, that's good to know. I'm sorry, I interrupted
So,
you. So they go in, they get the anesthesia.
They go to the post-op area.
What kind of anesthesia do they get?
Either general or monitored anesthesia.
Okay.
Which the generals they have a they have a tube protecting there, and sometimes we'll just do it under monitored. Basically, the way I describe this, I think this does the best people can relate to. I tell people it's very much like a colonoscopy experience.
Okay.
You go to the OR, you go to sleep, you
Like
wake
Twilight.
up, you don't really know anything happened, and you leave an hour later.
Okay.
That's the process.
So where do I go after I leave? I go back to my hotel room?
Yeah, I mean, it depends. So if I have people who are driving from LA or something, they might even just drive home the same day.
The same day?
Yeah,
Okay.
they can't technically drive, but they'll always
Their
come with their
spouse or someone,
somebody,
yeah.
Is there a certain place, because you operate out of a lot of centers, there's a certain place that I can get in faster than
Yeah,
others?
so there's
Can you
one
name
surgery
that?
center that we just tend to have an easier time getting.
And
over
where
time.
is that?
It's in Fremont, California.
Okay, so if I request Fremont, the chances of me getting in sooner are better.
That's right.
Okay, that's good to know.
Yeah,
All
so,
right.
and we know all this, so we'll, we do a lot of the out-of-towners at Fremont, and it's a wonderful facility because they will add cases on. For instance, I've started there as early as 5:30 in the morning.
Okay.
Most places won't do that, so they're very flexible about adding OR time.
Let's say you treat me and I decide to have a midlife crisis and I want to have a baby. Can I have a baby after you treat me?
Probably not, because it's not that the sperm count necessarily go down, but we're talking about dry ejaculate, right?
Yes, so you
the
have
delivery mechanism, and I don't know of any literature in this. I'm presuming
Yeah, it'd
that
be
not
difficult.
so. I do ask this question, especially to younger guys, and we would tell you to sperm bank ahead of
Okay,
time.
so you have guys at the sperm bank before the procedure?
Almost none, because usually these guys are
bit.
significantly older. But
Yeah, but you're in California, you know people have midlife
That's right.
crisis.
No,
but,
that's
but
definitely
the
something to
solution
mention.
is
Yeah,
really
yeah.
to be you really should sperm bank.
Yeah.
That's right.
Okay, so if they have a dry orgasm, is this thing that happens over a long period of time, or does it happen soon after the procedure?
It's fairly quick. I mean,
So it's quick like surgery. right?
These guys
Okay.
will, even at the 1 month follow up, they'll be like, wow, I have very little and it's very watery. So it changes pretty quickly.
Do you find that people are surprised that they have dry orgasms after radiation? Because it's sort of associated with surgery.
Well, try to tell them, number one.
Yeah.
And I heard your earlier talk when your discussion that people up to 40% of the time say they didn't have that discussion, and it may very well be that they didn't, or they just don't remember the discussion.
Yeah.
I very rarely find guys complaining of it significantly. Every now and then during a consultation, it clearly is an issue that bothers some of the patients, but boy, I would say it's less than 2 to 3% of the guys.
Yeah,
that
I just
seem
think
to
it's a
about
surprise factor, right?
Right.
Yeah.
And a lot of times why I actually believe some of the numbers is that the wife will be on the phone or the partner will be on the phone. They'll say, I definitely did not hear it. And then I go, okay, I believe it.
Right.
You know what I'm
Right.
saying?
Yeah,
So
absolutely.
it's, anyway, but it's kind of but no one ever says, oh my gosh, I feel like they did me a disservice. They just wanted to know up front. I almost had a little joke too. We were talking earlier, brachytherapy, brachy and greet means short, right? But to me, it means a short list of people that actually do it.
Yeah,
Right? I mean,
yeah.
that's just a medical joke. Sorry for people out there. That's a nerd joke.
That's a dad joke.
Yeah.
It's a dad joke. Which dad jokes are high quality, damn it!
Hey, I'm a dad.
When are we going to defend our jokes? Okay, who is a bad candidate for your procedure? And if you tell me no one, I'm going to laugh. Who do you clearly go,
But
whoa, this is a bad
I'm
candidate?
going to tell you this. There are bad candidates, but we can make them good candidates.
No, you can, okay, but then there are candidates I go, I've never seen that question asked. For example, there's a lot of people, I don't know why it's pandemic now, it's like an epidemic that have IBS, or they have inflammatory bowel disease, they have Crohn's, right? They already might have a rectal fistula. I don't know, they've already got perceived bad problems that could be associated with radiation. They already have these, so do you help these people?
This is perfect. So let me, before I answer the bowel issue, the guys that we won't take for brachytherapy are guys with significant urinary obstructive symptoms. Because
Okay.
they're set up to be miserable.
That
They're going to
is
end up with
really
a catheter.
interesting.
They're going to be on a catheter for weeks, if not months. However, those same guys,
Yeah.
we will recommend they go for a TERP or a green light laser or a Resume or whatever their urologist likes. I love that because 2 reasons. One, they will then sail through the brachytherapy because they're wide open.
Yeah.
2, they're going to be peeing like they're 16 for the rest of their lives.
Yeah.
So they're just thrilled. So we are very liberal in recommending to our urologists, hey, do something to get this guy peeing well. We won't take somebody with really bad urine.
Yeah, if
So these bad candidates, though, that you say get Resume or Hole Up, we have a lot
Mm-hmm.
of people doing a lot of that, and that carves out a lot of the prostate. A lot of the volume leaves the area. So then you'll do them?
So, it's interesting. I read these reports, like of a TURP, they'll be like, we removed 35 grams of tissue. It's extremely rare that we see a giant TURP defect. It really tends to kind of collapse on itself.
Yeah.
And I don't think I've ever had a patient, and we'll ultrasound these guys afterwards, and I don't think I've ever had a patient, I had a couple patients where I was like, this might be on the edge, because what the problem is, you need to have enough tissue to get the seeds in, to get a meaningful dose of radiation. Almost never do we see that there's such a huge defect that we can't do that.
Yeah, I think the classic teaching, when I was in residency, read my textbooks, they said if you've gotten a TURP, you cannot do brachytherapy. And frankly, if you're looking at the anatomy in real time, figuring out what the TURP defect is, and not depositing radiation seeds in there, those patients do fine. So I think anyone who has an IPSS score in the teens, I tell them, might be reasonable to consider a procedure, wait for 2-3 months, and then do the brachytherapy, and you'll do great.
Right, that would make more sense.
Oh, we do it all the
time. At
least
they have that option, get your whole up done.
Yeah.
Oh, I'm a huge fan of the intervention prior to brachytherapy.
Yeah, and then get your, and so then how long, then now you've got a tinier prostate overall, so does that person sail through? Is it a lot quicker, 15-20 minutes?
They say, well, the procedure's always 15 to 20 minutes. It's a.
I know, but I like the fact that it might be a little shorter. Everybody wants shorter.
Sure.
No, but really these guys, they tend to have pretty minimal short-term side effects.
Okay.
And like I said, more importantly, they're just happy for
But those are the guys with obstructive symptoms, so they can then lean on a BPH procedure, then come back to you and go to the area where they see fit to be treated as quickly as possible.
Right.
But what about the inflammatory bowel disease? What about the IBS people?
I used to have an absolute contraindication for those guys.
You did?
I did. I don't anymore. Only because over the years of talking to people, looking at some literature, and the advent of rectal spacing.
Yeah.
Spacor, Barrigel. We can do an amazingly good job of minimizing the radiation to the rectum using good brachy technique, but also with Spacor.
So you're allowing these kind of men sort of back in the pool, so to speak.
Yeah.
What about if they're coming in already, regardless of the etiology, they have rectal issues? Like I said, there are plenty of people with Crohn's that already carry around a partial, or they have a rectal fistula, it might be tiny. Is that a no-no, or?
Again, if a patient is incredibly symptomatic, I would shy away from that patient.
Okay.
Right, even with rectal spacing.
That's good to know.
Yeah.
Okay. How do I know that you've helped me? In other words, everybody knows that after you get a radical prostatectomy, you're supposed to have an undetectable PSA. But you still have a prostate after I'm treated by you. What number am I looking for? Am I looking for an undetectable PSA? Am I looking for a 0.2? Am I looking for a flat PSA?
Yeah. I mean, the PSA should go down. So I tell most folks if your PSA was 8 coming in, it should be about half 3 to 6 months after. Get your PSA checked every 6 months. The vast majority of men have a PSA of about 0.1. But frankly, if you have a PSA of 0.5, 0.7, as long as it's flat, it means you have no prostate cancer.
Okay, so
now,
you're looking for flat.
Exactly. Now there's a phenomenon in some men where there's a little bit of a PSA bounce. So 18 months after brachytherapy, their PSA goes from 0.5 to 1.2. I tell folks, for the vast majority of men, it's a PSA bounce. Measure their PSA again, it'll go back down. So the vast majority of men, a few years out, they're at somewhere below 1. But if you're at 1.2, and as long as you're staying at 1.2, you're still prostate cancer free.
But when is this bounce most likely to occur? Because that would freak me out.
Right, that's the worst part about
does
the bounce.
Does that happen very, very early in the game, in the middle? I mean, how soon did you say the bounce could happen?
I've seen it typically at 18 months, 12 to 18 months after the brachytherapy.
So how big is that bounce usually? Is it a full point? Is it a half a point? How big is a bounce? Because that would just, like I said, it would make me nervous.
It's about 20 to 30% of men, and it's typically about a point. I've seen 2 points as well. But,
and then it will go back
that's right.
to where it was?
That's right.
Over generally another how many months?
Essentially the next time I get their PSA, it's down.
Okay.
Essentially 3 to 6 months after that bounce.
And the problem, why it's a little frustrating, is we're kind of helpless because there's really nothing you can do, right? So so a urologist might call and say, I'm going to biopsy this guy. It's like, no, because the problem with the biopsy is the tissue they see can look like viable cancer, but it's actually not. It's actually, it looks like viable cancer, but it's on its way out anyway.
Yeah.
So for up to 2 years, a biopsy for those guys is worthless.
Okay.
So it is kind of a helpless feeling, and all we can do is kind of reassure them that, look, when we see this happen, it pretty much always resolves, and that's a true statement.
Well, the first papers I did, and I did this for Blasco, and they were running all sorts of journals, some of your colleagues, is they asked me one time to comment on diet and supplements before brachytherapy or after. And the reality is, people talk about diet a lot with prostate surgery and other areas. Do people talk to you about, is there a diet I can go on to help me during brachy, or is there a pill I can take along with brachy? Or some of the philosophy over the past 20 years has been, I don't want you taking a lot of these over-the-counter pills, these vitamin pills, because they could basically quench free radicals. I mean, the philosophy is everywhere. So do you have a philosophy in your office when someone says, hey doc, how do you feel about diet and supplements in this procedure?
I'm a bit of a wise ass, and I usually say that may not make you live longer, but it sure will seem like it.
So does that mean?
You
don't care?
I generally tell people, look, as long as you're eating a reasonable diet,
Yeah.
obviously if you're eating double cheeseburgers every day, you gotta change for other reasons. With regard to getting rid of your prostate cancer, we're gonna do fine.
Okay, but what about if someone says, hey, I have this philosophy, and I want to take 5,000 milligrams of vitamin C after or during brachytherapy. Do you have a problem with it, or do you think it can interfere with it?
I tell them that theoretically, you want to avoid high doses of antioxidants.
Theoretically, yeah.
Right.
And
Because that is how radiation works, by creating
It is,
free
and the question
radicals.
is, there's two camps now. The question is, the energy applied is so great, good luck taking whatever you're going to take. And
That's why I say
we don't know.
theoretically.
Yeah.
So that's just it. That's interesting to know that stance. How do I know that I don't have lymph node disease when I go have brachytherapy with you? I mean, are you sending everyone for PET CT? Are you relying on the MRI? I mean, because you're not doing lymph node dissection. So how do I know that you're treating my cancer in the prostate and I don't have cancer outside my prostate?
Well, so risk stratification group.
Yeah.
Right. So if you're low, favorable, intermediate risk, you have virtually no risk of that. We just know that empirically. The guys that I have the longest consultations with are the unfavorable intermediate risk guys, because what I'll tell them is like, look, we can go two ways here. We could do brachy. Let's say it's got 2 cores of 4+3, a PSA of 6, and no palpable disease. I say to them, we could do brachytherapy alone. The risk is, and it's a single-digit risk, most likely, you could have occult lymph node involvement. So even if your MRI is negative, even if your PSMA scan is negative, you could have occult lymph node involvement. Okay. Right. The brachytherapy alone is going to almost guarantee us getting rid of your cancer in your prostate, but if we guessed wrong and you have disease in the lymph nodes, then it will potentially progress in the future. So I make that decision together, because 2-3% may sound like, well, I'm not going to do the radiation if you're telling me I have a 97% chance that I don't need it. But some other guy might look at that and go, well, I don't want to take the 3%. And I make that decision together, because I don't think there's a right or wrong answer for that person.
So will you do an add-on in that situation, or will you just tell them brachytherapy is...
I will reassure them that I think either one is very reasonable, and I bend over backwards to tell them, like, look, I don't think I have the absolute answer. If 2 or 3% sounds like a lot to you, get the external radiation.
What are we going to come to the point where everyone just gets PET CTs before your procedure?
I mean, a lot of men do.
It's almost at that point now.
We're almost at that point now.
But again, if they have microscopic disease, it's by definition, it's not going to show up on anything, right? Because it's microscopic.
If it's microscopic, but if it's a little bit macroscopic, or
I feel extremely more comfortable not offering external radiation than I used to be.
Yeah.
Because of the PET CT.
Well, I was just saying, apart from the cost, which I know it's saying, apart from the cost is everything. Why not just get a PET CT before a procedure?
I love the PET CT.
I know you've got the technology.
I love the PET CT.
For anyone with a high-risk prostate cancer patient, I definitely advocate for the PSMA PET scan, and certainly many of the folks with unfavorable intermediate risk.
Yeah. Okay, that makes a lot of sense. I like that. And then now this is the era of genetics and BRCA testing. So there are some men that are going to come up BRCA positive, 1 or 2. They're going to have a mutation that's concerning. It's suggesting more of a high risk than what they are. Are you suggesting some men go get that testing now, when someone comes with that test that's positive? Are you more nervous about doing that implant? Where are you now with all this? Because let me set this up for you. 5 years ago at this meeting, of course you want to espouse and get excited about the predictions you get right. You don't want to mention the predictions you get wrong. I said, I think everyone's going to get BRCA when they're advanced. Now everyone's getting it. Now my next prediction is within 5 years, everybody who's been diagnosed will get BRCA testing. Yeah. I don't think it's just going to come down to genetics.
Or GPS or just
they're going to get something.
Right.
So the way I look at this is it's hard. It actually confuses things, because let's say I have a low-risk guy who comes in with a Decipher score that says he's high risk. Am I now going to say to him, let's treat you like a high-risk patient, and I think you should get seeds, external radiation, hormones? I don't do that. And my rationale is this. Well, two things. Number one, we don't have clinical data that shows patients with a high Decipher score, GPS, does better by adding that. It's not there yet, right? Maybe we'll have that at some point in the future. We don't have that. And two, my experience over doing this for 25 years is guys who walk in the door prior to all these tests never failed. So I can't imagine changing my entire treatment paradigm based on the traditional risk stratification group solely based on something that's discordant with the genetic
I see
test.
what you're saying, but does the surveillance increase?
So that's where I use it. So where I use it, I might say to a guy who comes in who's otherwise low risk, maybe this is a nudge to treat it rather than watch it.
Yeah.
But I don't use it to say I don't let it trump the more traditional, longer-term data we have with risk stratification.
Okay.
Does that make sense?
For folks with unfavorable intermediate risk prostate cancer or favorable intermediate risk, even if they do have a high Decipher score, I may be a little bit more prone to giving them 6 months of ADT.
Of hormone therapy. Okay.
Right.
And then you've treated me. I'm happy. I'm out in a day. How often am I now following up? Do I have to come back and follow up with you every 3 to 6 months? Or if you tell me I can follow up with my local urologist,
That's what we do.
how often am I following up?
PSA twice a year.
PSA twice a year, right from the get-go?
Yeah, basically, so
right from the get-go.
So we usually the first PSA is about 3 months. And our experience is it's usually about half of what it was. It doesn't nadir by that point. Usually it's about half. That's not a really meaningful one. By the time you're out a year or more, it's usually nadired to well below 1.
Okay.
And as long as the PSA does not rise, they don't need biopsies, they don't need imaging studies. So what we generally tell them is like, look, you can come back for follow-up. You certainly don't have to, because you're going to get your PSA with your urologist twice a year, and you have an open invitation to call with any questions, issues, anything. So we don't. I think as radiation oncologists, we traditionally have over-followed patients.
Yeah.
And when you start asking them, did you want to come in? They're like, no, I only came because you told me to, because they're doing fine. So now it's like, just get your PSA and call me if you have a problem or a question or an issue.
Yeah. So it's just 3 months, boom, another 9 months, twice a year.
Twice a year.
Yep.
Okay. Do you ever deal with radiation-resistant tumors? Like some of these people in external beam talk about, or maybe they end up being different types, or maybe they're neuroendocrine, maybe they're weird.
It's hard, right? It's hard to know because we don't have a 0% local failure rate, of course, with our treatment.
Right.
We have a very low. But is it because there was a cold spot? Is it because there was something about the genetics of that tumor that was different, that was radioresistant? Who knows?
So you see them, but these are still extremely rare.
Extremely rare.
Okay. So you mentioned the side effects. You mentioned urgency. You mentioned taking naproxen. I think you said tamsulosin is standard. Right. How long am I taking those after you treated me? I'm taking Flomax. People know it as Flomax. People know naproxen, for example, as a leave if they want to take it over the counter, right? So how long am I taking that?
I tell them a leave twice a day for 7 to 10 days after the procedure. In terms of Flomax, it kind of depends on the patient. I tell them, take it for a couple of months. You're a month and a half, 2 months out, you can stop taking it. If you feel that your urination's fine, then stop taking it. If you feel that, I'm getting up more times a night, then just continue on to Flomax. I found that most folks have very few side effects with the Flomax. Some people get lightheaded, and I do warn them about that. But the vast majority of folks say, regardless of the prostate cancer, frankly, I'm feeling better with the Flomax. So it's really variable. I tell them after 2 months, you have an option to discontinue if you want.
What if people want to take Cialis or Viagra too right after because they're nervous about function? Do you have to take that?
I think they should be taking it even, ideally beforehand.
Okay.
Yeah.
So
there is literature suggesting that low dose, Viagra anyway.
So you're a fan of that?
I'm a big fan of that. Yeah.
There's an old drug that's been used since my daddy was in urology. It was called phenazopyridine. It's a urinary anesthetic, and it's still used in hospitals when sometimes people get urgency or they have sort of irritative symptoms. And now there's an over-the-counter version called Azomax. I don't know if people ask you about that anymore, about taking it after radiation. Do they ask you?
I don't recommend it for all folks, but once in a while there'll be a patient who calls me and say, hey, I have some burning with urination. I'm 3 weeks out, and I typically give them Azo, and I say So
you do give them Azo over-the-counter?
That's right.
Pyridium was the prescription,
That's right. My experience, though, those guys with dysuria, it doesn't really help, and I'm not necessarily
You think it's more placebo?
No, I think it doesn't help. I think they usually say it just didn't help, and I'm not sure. Well, it's a very small number that has persistent dysuria. I mean, I tell everybody, we're going to put a catheter in it after you're asleep. We'll take it out before you wake up. The first time you pee, that's going to curl your toes a little bit, like that day of the procedure. But that usually goes away by the next day. There is a subgroup of patients that have persistent dysuria, and quite frankly, I'm not exactly sure why. But it's a pretty uncommon longer-term, short-term side effect.
So a Viagra-type drug, tamsulosin, ibuprofen. I'm sorry, I said ibuprofen, but you like naproxen.
Ibuprofen's fine. They just have to take it more often.
Yeah, the half-life shorter, right?
Right.
So, okay, they're starting it the day of or the day after the procedure?
I actually like them to start the tamsulosin even a week ahead of time.
Okay, a week ahead of time.
Sure, why
okay,
not?
That's awesome.
I mean, I just made that up. There's no clinical data, but my thinking is the better they're emptying their bladder going into this, the less likely they are to have more significant short-term side effects.
The one thing that used to scare the living daylights out of us about brachytherapy was that we would start seeing papers on what's called seed migration. Remember that? Okay, the seed was in the prostate. Next thing we know, it's like in the lung tissue or something. Right?
What happens?
It happened. So is that just the result of someone that's not an expert, or does this just happen once in the blue moon?
No, so if seed migration is going to happen, it's going to happen, and this is one of the arguments for doing pre-planned with stranded seeds, is that it's not going to be able to get into the lung because it's stranded. The way a seed gets into the lung is at the time of the procedure, it's going to get into the dorsal vein complex, the complex of veins sitting right in front of the prostate. And then it is going to migrate to the lung, which sounds horrible.
Yeah.
It's utterly inconsequential. So back 20 years ago, we used to have a policy. We would get a chest x-ray 30 days after the brachytherapy to see if a seed went to the lung. And two things. Number one, we hardly ever saw it. And when we did see it, we would shrug our shoulders and go, oh, there's a seed there.
There's a seed there.
And we wouldn't do anything.
Yeah.
So nobody even bothers with that anymore. But luckily, it's probably under 1% that it happens.
Are you doing focal seed therapy? Everyone's talking about focal therapies. I'm going, is there this focal therapy thing? I know people get excited about, but I know prostate cancer is a multifocal disease.
I have very mixed feelings about focal therapy.
Because?
And it's because we don't know, and what I'll counsel patients on, and I'll do it, but I really bend over backwards to counsel the patient that there is no absolute way to know that there's not cancer elsewhere in the prostate. Okay. And in fact, a lot of and this isn't necessarily a bad thing, but there's a lot of just purely focal biopsies now, where we're not even sampling the contralateral side of the prostate. We're just biopsying an MRI, MRI lesion, which I think has its upside. But again, my good friend in Seattle, his name's Alex C., just published a paper. It's like something like 42% of the patients who fit that bill, when he did saturation biopsies, had cancer on the contralateral side.
Yeah.
So what I'll counsel a patient is like, look, this very well might cure you, but there is some risk that you're going to be back at some point to treat this. But the good news is you didn't burn any bridges, because you can actually still treat.
Yeah.
So I think focal therapy has a role, but I think some people are a little cavalier about doing it, and I think the patient really needs to know that, hey, there's some potential higher risk that this we're going to leave some cancer.
So if I leave a lot of power in your hands and I'm a patient, it's your druthers that you'd rather extend the playing field. You'd rather go beyond, just to make sure.
It's clearly the safest way to do it.
There's merit in that, right? Because you're a one-and-doner.
Yeah, I tell folks, you're focal therapy, you'll save yourself some short-term side effects, but frankly, you're going to do fine long-term, whether you get focal or whole gland therapy. So, might as well have a little bit more 3 to 4 weeks of urinary symptoms and do it right the first time.
Get it done right.
But there's some folks who are very focused on focal therapy, which is fine. That's their right. Yeah.
And I actually really like focal therapy for a local recurrence after treatment.
What about cancer that's just beyond the prostate, say the seminal vesicles? Can you do anything? Or what do you do?
Generally, though, we're going to recommend combined therapy, because that's one of the advantages. We're going to escalate
so you'll do
the dose.
Combined.
But I have even done prostate seed implants on SV failures alone.
You have?
Yeah, because you can now. HDR is actually really good for seminal vesicle. Like a lot of people say, well, you can't really get the seeds in a coherent pace. You actually can. So the guys I've done focal therapy on the SV recurrence, they've done great. But I think HDR and seed implant for those guys are both really good options.
So are you saying to me that you put seeds outside of the prostate?
Well, I routinely.
Is there any other areas besides that area you might put seeds?
No, basically just the prostate subnavesicals.
Okay, but you can do that.
So I've actually gone out of my way in the last several years to really make sure that I implant where the junction of the base and the seminal vesicle.
Yeah.
I like to get a seed, if not into the SV, right at that junction, because in the rare local recurrences, that's what we've seen, is they've recurred in the SV.
Yeah, patients need to know that you can go back up in there.
And I do, routinely. We
That's
do that
good to
pretty
know.
much.
'Cause, I mean, how many seeds could that take?
Couple.
Couple, right?
Yeah.
I mean, couple as in a couple?
Well, I mean, maybe
Like 5?
maybe two to two. I mean, maybe 2 to 3 on each
And
side.
how long does that procedure take?
No, it's the same procedure. You
So
literally
you get
just
15
place
to
the
20
needle
minutes.
a little bit more cephalad right into the SV.
Okay, I like that. I like that overall. Any comment on only comments on catches like secondary cancers after radiation? It's a big discussion. You know, you threw a bunch of radiation in there. It's going to radiate other tissues. You're going to give me another cancer 20 years later. Do you have any comment on that?
What do you think? 1 to 2%
I
risk
think the
max
data
at a time?
for external beam is 0.1% every 10 years.
Yeah, that would be
And,
more concerning, external beam, right?
Right, and even for external beam, it's very, very low, 0.1% every 10 years of additional secondary malignancy because of the radiation. Brachytherapy, obviously much more focused, so not great data for what the number is, but it's probably 10x less than that.
Okay.
And you know, the problem with that is, of course, guys get bladder cancer, guys get rectal cancer. If they did get one, nobody would ever be able to say, well, this is because you had radiation, or is it coincidental? So it's kind of really hard to tease all that out anyway.
And testosterone reduction after seed implant? Any comment?
I
still a
think I speak for
controversial
both of
issue.
us. I am less of an androgen ablation pusher than most, because
But do you think the seeds themselves can actually, the radiation given off can actually lower testosterone? Like there's a discussion sometime in external beam?
I honestly
There's
don't know the
been
answer to
a
that
discussion
question.
that there's such scatter with external beam that eventually that can affect areas that produce
I think
testosterone.
the
But this has just
testicular
gone back and
dose,
forth in the literature.
from the seed implant would
You
be
probably don't see much.
minuscule.
Okay.
Yeah.
All right, we give gifts. Again, money's no object here. I mean, if this costs us our entire budget, we'll do it.
These are nice
So we
t-shirts.
decided to both get you a t-shirt. We were convinced that you definitely don't own, so I want you to hold it up. You can see that our organization is run by mostly young people.
Yes, I could
Because
tell,
we're
yeah.
too to use their language too. And I know these are too large, but these will shrink.
fine, yeah,
So they both have the same shirt, and it says, "Radiation therapy is my jam." And then there's a picture of jam. So I hope you cherish that the rest of your
definitely.
Oh my God,
lives.
yeah.
I'm wearing this right when I
You
walk
should.
outside
I'm wearing
here.
this to bed tonight.
And never give it to anyone. Thanks you guys for being
That was
here.
a
I
real
think it's
All right.
awesome. It's
was
really
fun.
great.
Thank
Fun,
Thank
great,
you so
yeah.
much.
Segment is a sponsored talk from Janssen Pharmaceuticals, where we're going to be learning about a recently approved treatment called Akiga. It's a treatment for patients with metastatic castrate-resistant prostate cancer with BRCA1 and BRCA2 mutations. Now, this talk is going to be presented by Dr. Tracy McGowan. She is the therapeutic area head for the prostate cancer division of Janssen Scientific Affairs. She's a true expert in her field and has also helped many of the treatments that we see in cancer today come to market. She's a good friend of mine, and I've learned a lot from her over the years, and I'm honored to have her today. I hope you find this talk informative.
Good afternoon, everyone. Thank you for the introduction, Alex. It's such a pleasure to be here with you today. I wish I was in sunny California. I am calling in today from a very rainy East Coast where Tropical Storm Ophelia is bringing us lots of rain, but we're all safe, so that's good news. But I am excited to be here today with you virtually to tell you a story about an exciting new product called Akiga. Before I get into that, I want to tell you a little bit of a story about prostate cancer in general. Many of you have probably seen a picture such as the one that I'm showing here. This is a very bare bones schematic of what a prostate cancer patient's journey might look like. And I'm going to go through this just a little bit to make sure any words that I'm using later make sense to you. But on the far left of the screen, you can see what we call clinically localized disease. That's when someone first finds out that they have prostate cancer most of the time. And decisions need to be made, whether you may have surgery or radiation. You may have that with some other therapies as well. And everybody here knows that then you get your PSA checked. There's another disease state called biochemical recurrence that happens if your PSA starts to rise. Now, if your PSA starts rising, but there's no evidence that your cancer has spread, we call that non-metastatic CRPC, which you may be able to see. I think I have a pointer here. Let me try to do this. Is the laser pointer working? Let's see if I can do laser pointer. So this would be called non-metastatic castrate-resistant prostate cancer. Some patients find out that they have prostate cancer and it is unfortunately already spread. We call that metastatic castrate-sensitive prostate cancer. So they kind of enter the patient journey here. Collectively, we call this early advanced prostate cancer. If this remains untreated, or if therapies for these two disease states are no longer effective, a patient may end up with metastatic castrate-resistant prostate cancer, which we call late advanced disease. When I started working in prostate cancer drug development 14 years ago, 2009, the only medicines we had available for patients who were out here were pretty much chemotherapy and some drugs that work to bring testosterone down, but not to super low levels. I'm very excited to tell you that one of the first drugs that I worked on was called Zytiga, or abiraterone acetate. And in 2011, that product was approved for patients who had castrate-resistant prostate cancer here. And it was a big and exciting time because the way that medicine worked was to take testosterone, which most of you know is the fuel for prostate cancer, to almost zero. And patients did really well. This was an oral medicine. It improved patient survival. And eventually, that drug was actually approved for earlier use for patients who sit here, and eventually for patients who sit here. But interestingly, what we learned was that while testosterone or androgens are the primary fuel for prostate cancer, some patients, cancer still grows. It doesn't seem to be just driven by testosterone. So a lot of research was done to understand why would this happen? What else is driving prostate cancer in some patients that's not just androgen or testosterone? And what we found out was that there's some patients who harbor mutations, which are problems in DNA. And these mutations in their genes, which collectively we call homologous recombination repair genes, that's a mouthful, HRR. If there is a problem in those genes, these patients' cancers can be much more aggressive and resistant to therapies that just lower or block testosterone. The most common one of these genes is called BRCA. Many people have heard of BRCA outside of prostate cancer because it also drives a lot of breast cancer as well as ovarian cancer. This gene runs in families. It's important to know that if patients have BRCA gene mutations in their family, women can be at risk for breast and ovarian cancer and some other cancers, and men can be at risk for prostate cancer. So knowing this led to recommendations to screen patients for BRCA mutations. There's two ways to screen people. You can either do a mouth swab, and that's for the inherited type of BRCA mutation that you may find running through families. But that's not the only kind of BRCA mutation. Sometimes it just happens out of the blue. It doesn't run in families. It just is what we call an isolated mutation. And to find those, we actually have to test the prostate tissue, either through the biopsy, or if a patient had surgery, you could take the whole prostate and test it for a BRCA mutation. So it's really advanced the science a lot to understand that mutations like BRCA are why some patients don't respond as well to drugs like Zytiga that just target androgen or testosterone. So here's the good news. Once we knew that there was something to target, drugs were developed called PARP inhibitors that specifically attack the BRCA mutation cells. We're able to take advantage of the fact that the same mutation in your DNA that can cause cancer also causes those cancer cells to be susceptible to these medicines called PARP inhibitors, which when they're exposed to it, those BRCA mutated cells will die. So I'm very excited to talk to you today about a new product that J&J, Johnson & Johnson, where I work, had approved by the FDA just 6 weeks ago on August 11th. The drug is called Akega, and it's a special drug, and I'll tell you why. Not only does it work on cells that harbor these BRCA mutations through PARP inhibition, but it's the first drug in oncology to actually have 2 different cancer medicines in one pill. So we took our PARP inhibitor, niraparib, and combined it with Zytiga, the drug I told you about that's been around since 2011. And we have one pill that can do 2 things. One half of the pill, like you see on the left, is the PARP inhibitor, specifically selectively causing cell death in cells that are driven by BRCA. But we're not taking our foot off the brake for the cells that are being driven by testosterone. So we have abiraterone, keeping the brakes on testosterone, and we have niraparib, putting the brakes on these BRCA-driven cells. And together, we did a trial to show that the patients who were not doing as well with Zytiga alone would do better with this combination. So let me just tell you a little bit more about that and what we got and how we got our approval. Before I do that, I am required to tell you that all drugs have side effects, and there is important safety information to understand with this combination, because now you have 2 drugs, a PARP inhibitor with its side effects and Zytiga with its side effects. In our warnings and precautions, we do talk about the fact that over time, patients who have PARP inhibitors, who have been taking PARP inhibitors, may have secondary cancers. We've not seen that with our drug yet, but other drugs in this class have seen this. Because of the Zytiga part, you can have some blood pressure issues and some electrolyte issues, but your doctor can check for that and will check for that. You can also have some liver enzyme abnormalities. Again, if you're taking this medication, your doctor would be checking for this frequently. I won't go through all of these in detail, but suffice it to say that if you were to be prescribed this medication, your doctor and your doctor's team would go through this thoroughly with you to understand all of the potential side effects that you might see. So moving on to the actual clinical trial that we did to understand if giving this combination of Zytiga or abiraterone acetate with niraparib, which we now call Akega, would see patients doing better than just Zytiga alone. But we didn't want to do this in everybody. We really felt that it was highly likely that the patients who would benefit from this combination would be the patients who had the mutations. We didn't want to not study patients who didn't harbor these mutations in case there was a benefit there too. But we did it as almost 2 separate trials. We didn't want to fool ourselves into thinking that the patients who didn't harbor the mutations were getting benefit if they weren't, by lumping everybody together and not being able to tease that out. So we were very thoughtful when we did this trial to make sure that the patients who had mutations were in one group, and they either got Akega or Zytiga, and then the patients who didn't have mutations got either Akega or Zytiga. And what we saw pretty early on was that the patients who didn't have mutations were not getting an extra benefit by adding a PARP inhibitor. So we stopped that arm and decided that we would only continue to study the patients who did have a mutation. Over half the patients who had a mutation actually had a BRCA mutation, which is by far and away the most common mutation that's seen in men with prostate cancer that have one of these mutations. And here you can see the curve, we call it the curve, that shows you that the patients with a mutation who took a Kiga versus just placebo and Zytiga did much better. The green line on the top shows you the numbers of patients or percent of patients that were surviving without disease progression. And the line on the bottom shows those patients who only got the placebo plus Zytiga. And you can see that the addition of the Kiga, the niraparib part of this, really did provide a benefit as witnessed by the patients who were doing better over time, which is the top line. In fact, there was a 47% reduction in the risk of death or disease progression when the patients received the combination products. These are the most common side effects that patients saw during the trial. They're listed in descending order of frequency. You can see musculoskeletal pain and fatigue were the most common, followed by constipation, hypertension, nausea, etc. Most of these were only grade 1, 2. We grade side effects on a scale of 1 to 4. Things that are mild to moderate or grade 1 to 2 are usually very manageable. And I'll just skip to the next slide. And you can see here that 85% of patients with the BRCA mutation remained on a Kiga without having to discontinue due to side effects. So most of these patients, if they had a side effect, sometimes they needed their dose reduced, or sometimes they needed to have the drug held for a little while and restarted. But the majority of patients were able to continue on their therapy and receive the benefit that you saw, despite some side effects that we're seeing. So I think that is my last slide on a Kiga. These are just other resources that Johnson & Johnson provides as part of our comprehensive educational support for patients with cancer and their healthcare providers. So if you were to go to one of the Johnson & Johnson websites, these are some of the resources that we do have available to support patients and their caregivers. And with that, I'd like to thank you for your attention today. But more than just thanking you for your attention today, I want to just put out a couple other thank yous. I really want to thank the patients and their families who participated in the clinical trial that brought this data to you. I'm sure some of you have participated in clinical trials or are a caregiver of someone who has, and that's a brave thing to do, and it helps us get these answers that we so desperately need to figure out why some patients aren't doing as well as other patients on trials, and if there's new drugs that we can bring that may make a difference for those patients. And I also want to thank all of the doctors and the care teams that take care of prostate cancer patients, and a special thank you to groups like Prostate Cancer Research Institute for providing education and the opportunity for us to have these kind of dialogues and bring information to you in a setting like this. So I don't know if there's an opportunity to answer any questions or if this is just a one-way presentation, but it's just been my pleasure to be here with you today. I hope that you're as excited as we are about this dual action tablet. And thanks again.
Okay, our next speaker is our own Executive Director, Dr. Mark Schulz. Many of you have seen him on our channel. He's a world-renowned medical oncologist with over 30 years of experience treating all types of prostate cancer. Dr. Schulz is the founder of PCRI and dedicated his life to making sure prostate cancer patients and their families have access to free education and a focus on better quality of life. Today, he will be giving us an overview of treatments in advanced disease. Here is Dr. Schulz.
Overview of advanced prostate cancer. Advanced prostate cancer is becoming, thankfully, less and less common. We're getting better and better at preventing advanced prostate cancer. But it is an entity unto itself. There's a group of people that develop metastatic disease and need special care. And this talk is going to give an overview of that situation. Only an overview because obviously there's a lot of information, a lot of detail that we can't cover. But I think an overview will be useful because you don't want to miss out on something obvious. So we're going to go through and cover the basics and hopefully put it in perspective so people will know how to prioritize the different decisions that they need to make. When you talk about advanced prostate cancer, it is a little ambiguous because if the disease is coming outside the prostate gland, locally advanced prostate cancer, that is considered a serious development, especially in the historical sense where everyone was getting surgery, because the surgeons wouldn't be able to get all the cancer out. We are learning, however, that some degree of spread outside the prostate is not invariably associated with spread to other parts of the body. We call that metastasis. And it's the metastasis that really drive the storyline. Without metastasis, with a number of modern tools, radiation in particular, disease that's outside the prostate and that hasn't spread to the rest of the body can usually be cured. So it's the metastasis or the absence of metastasis that defines whether or not we have advanced cancer. Now, certainly there are different types of advanced cancer, and there's a lot of different staging systems. But in simplistic terms, you're going to define these differences based on where the cancer is, and of course, how much is out there. The number of metastases will be important. But are they only in the lymph nodes? Have they spread to the bone? Or most serious of all, have they spread to the liver? This constitutes very different types of advanced prostate cancer. The other thing that defines advanced prostate cancer is how the cancer has behaved under the duress of different types of treatment. If treatment responses result in complete remission, then obviously that's a less worrisome type of cancer. The cancers that progress through our best treatments, radiation, hormone therapy, chemotherapy, are more serious types of advanced prostate cancer. And we're going to elaborate on these themes as the talk goes on. So our main tools for treating advanced prostate cancer are hormone therapy to block testosterone, a very effective form of treatment, different types of chemotherapy, radiation therapy, which can be delivered through an invisible beam at targets in the body, immunotherapy, treatments to stimulate the immune system to attack the cancer, and then different forms of injectable radiation therapy into the bloodstream that circulates around and attacks the cancer at its different locations in the body. Historically, we've always started off talking about hormone treatment and chemo treatment, and the idea of radiation treatment being a priority as treatment for advanced metastatic prostate cancer hasn't been on the table too much. We've always had the technology to do it, to give invisible beams of radiation to metastatic sites, but our imaging studies were so poor that we knew we were only treating the tip of the iceberg. This has changed with the advent of PSMA PET scans. And with these types of new scans, we are seeing 80 to 90% and sometimes 100% of all the cancer that's visible. That opens the door to utilize very accurate beam radiation to eradicate metastatic sites. So the types of scans that have been historically used are called T99 technetium scans. And you can see a picture of sort of a blurry picture on this slide that represents the rather poor quality that was available previously. There are better F18 PET scans, but those scans are not disease specific, and if someone kicks you in the shins, they can light up and falsely show what is thought to be metastatic disease. Disease-specific PSMA PET scans and, to somewhat lesser degree, Axelman and C11 choline PET scans are much more disease-specific and only light up, in general, for prostate cancer. FDG PET scans have typically used to detect other types of cancer, lung cancers, lymphomas, but in some cases we'll pick up particularly aggressive types of prostate cancer when it's in its very advanced stages. So as we talked about before, not all types of advanced cancer are the same, and the number of metastases is one way to look at how serious the situation is. There's been a threshold of 5 or more metastases versus 5 or fewer than 5 metastases as defining less serious and more serious types of metastatic disease. We already pointed out that the men that have lymph node disease only have a much better prognosis than those that have developed spread to the bone, and then have a better prognosis than disease that spreads to the liver. And response to treatment, which we alluded to previously, can be measured by whether or not the PSA goes all the way down to undetectable levels in response to treatment. And now with these better scans, we expect the PSMA PET scans in particular to show disappearance of disease activity if the treatment is effective. Men that don't get complete disappearance or who can't get their PSAs down to less than 0.1, that would be the appropriate PSA nadir, have a more worrisome type of cancer. So when we talk about radiation treatment, there's a lot of confusion about what's actually going on. Many of my patients seem to envision a heat beam that's burning cancer cells in the pathway of the beam, and this actually is not at all accurate. The radiation damages the coding inside the cells, the DNA, and the cancer cells actually continue to function until the time when they want to replicate. And when that happens, because they have messed up software, that's when they die. And when people undergo treatment with beam radiation to a metastatic site, it may take several months, 6, even 12 months, before you'll see the PSA decline completely. Sometimes it takes a little patience after radiation is administered to a metastatic site to see results. When I'm talking about radiation for metastatic disease, as I mentioned before, it's the PSMA PET scans that have brought this about. The technology for giving accurate treatment has been evolving over the last 20 years, just for historical reasons. Seed implant radiation, where the radiation is put right in the target, not usually used for metastatic disease, is obviously very accurate because the doctors are visualizing exactly where the radiation is being placed. IMRT, or intensity modified radiation, came around 2005. SBRT, which is a much more rapid form of treatment, became popular around 2015 and forward. And in particular, these treatments, when administered to the prostate gland, have become much safer due to the development of techniques such as gel between the rectum and the prostate. But repurposing these treatments, brachytherapy, IMRT, and SBRT, to treat metastatic disease was always feasible if we had clear sight of what we wanted to treat. And the technology to treat prostate glands has been evolving now for 20-25 years. It turns out that treating metastatic sites, in most cases, lymph nodes or a spot on the bones, is very easy for a radiation therapist. These targets can be easily visualized on a PET scan, and therefore the cancer can be completely sterilized in the target. So radiation therapy, which was very much in the background for metastatic disease until the recent advent of PSMA PET scans, now is becoming a very prominent player. Now I'm going to talk just briefly about some of the other treatments besides radiation, and then we'll try and see if we can show how one selects amongst these different types of treatment. So hormone therapy is an acknowledged, very effective form of treatment, and it can play several different roles. If you give hormone therapy in combination with other treatments, they can have a synergistic effect. 1 + 1 can equal 3. So hormone therapy does synergize with radiation. It does synergize with chemotherapy. Hormone therapy has been a mainstay for treating disease that we couldn't see because the scans were so poor. So as an insurance against possible small bits of cancer that were not visible, such as what we call so-called micrometastatic disease, hormone therapy was often administered as a panacea to cover that eventuality. But the mainstay for hormone therapy has always been to treat men with known metastatic disease, and it can be very effective. It tends to be somewhat more effective in lymph node only disease, and it can be very effective in metastatic bone disease, but will not be as universally effective as it is with lymph node disease. So here are some of the names of different types of hormone therapy, and as people consider embarking upon the treatment, there are really two main categories. Medicines such as Lupron that block testosterone coming from the testicles, and medicines such as Zytiga, Xtandi, Erleada, or Nubeqa, which block testosterone that the tumor itself can produce. To get maximum anti-cancer efficacy, the typical policy is to use one of these medicines from each of these categories to bring about optimal remission rates. When we talk about chemotherapy, Taxotere, otherwise known as docetaxel, has been on the market since it was FDA approved around 2004. Jevtana is a very similar medication. Carboplatin is a type of chemotherapy typically used for lung cancer, ovarian cancer, that also has efficacy for prostate cancer. The other category of chemotherapy for prostate cancer is called PARP inhibition. And these medicines are only going to be effective in about 10% of men that have prostate cancer. This is who these 10% are is determined through genetic testing, which we'll go into. So there are 4 products on the market right now, Lynparza, Rubraca, Talzenna, and Akega, that work through a mechanism of PARP inhibition. How does one know if he has the appropriate genetic mutation for PARP inhibition? And that is a fairly simple process. A blood test such as Guardant 360 or Foundation 1 can detect micro bits of DNA that are floating around in the blood that are released by the tumor cells. And the mutations are diagnosed via that means, and if they come back with a mutation such as a BRCA1 or BRCA2, the likelihood of those PARP inhibitors being effective is very high. One other thing that DNA testing with Guardant 360 or Foundation 1 can accomplish is to detect another rare mutation called microsatellite instability. In these patients, an immune medicine called Keytruda has very high response rates and would be the treatment of choice for that individual. There are other mutations that can be detected through this genetic testing, and we'll talk a little bit more about that later in the talk. Immunotherapy, as we already alluded to Keytruda, the FDA approved so-called vaccine for prostate cancer called Provenge came out around 2010 and is an effective medication for men who are in developing resistance to Lupron. Radiation therapy to metastatic sites has an additional benefit beyond simply killing the tumor in the target region. When those tumor cells die, the immune system comes in and sweeps up the debris and learns about that cancer in a way that allows it to attack cancer cells in other parts of the body. This is called the abscopal effect. So there are 2 benefits from spot radiation, one being the destruction of the tumor that's being targeted, and the other is a stimulating effect on the cancer cells, generally speaking. Other immune therapies, such as ipilimumab, are rather effective in certain situations. They are unfortunately not yet FDA approved, and costs can be a barrier. But there are good studies showing effectiveness in advanced prostate cancer. When we talk about Provenge, the vaccine that administers a boost to the immune system, the methodology used is rather unique. There are dendritic cells in the blood that detect and multiply and stimulate our immune systems to go attack invaders. Dendritic cells, through this treatment, are removed from the body and stimulated at a special facility and then re-administered to the patient to cause their immune system to attack the cancer. This particular study points out that immune therapy tends to work much better when there are fewer cancer cells. This is a principle of all metastatic disease and even earlier stage prostate cancers. And the amount of survival advantage observed in patients that had high PSAs over 134 compared to PSAs that were less than 22 when they administered the Provenge to them, showing that there was a 3 or 4-fold greater improvement in survival. This was further elaborated in another larger observational trial showing that when this immune therapy was given to metastatic disease in men that had PSAs less than 5, that their survival was augmented quite a bit more. This brings about the whole issue of how do we utilize all these different tools in the most effective way? The medicines that are available all potentially come with side effects. And one could envision a favorable scenario where all these medicines had no side effects at all. And for safety reasons, we would, and anti-cancer effect, we would just give everything together up front. That could be more costly, it could be more toxic. So there has been perhaps a policy reacting against overuse of medicines that typically has relied on a sequential approach where people after diagnosis first have an operation to remove the gland. If the PSA rises, radiate where the prostate used to be. If the PSA rises, give some hormone treatment with Lupron. If that stops working, administer some Provenge. If that doesn't keep the disease in check, take some chemotherapy, or the most common type of chemotherapy called Taxotere. If that doesn't work, try a PARP inhibitor such as olaparib. If that doesn't work, perhaps an injectable radiation such as Pluvicto. If that doesn't work, go on and have a clinical trial. It's rather surprising to me that this one after the other approach is by many thought to be the only way to treat prostate cancer. And that's certainly unfortunate because there's good evidence that will show shortly that combinations of treatment up front can be more effective. So what are the advantages and the disadvantages of this sequential versus combination approach? The sequential approach that I just showed you is it's an established approach. People are comfortable with it. When you only take one treatment at a time, there are less side effects. Some doctors are comforted by the thought of having some more treatment held in reserve. Since this is the standard approach, insurance typically will cover it. And prostate cancer can be very slow growing, and if a person is more elderly, they will die of natural causes before they run out of options. The problem with that approach is that if the treatment is not curative, we give the cancer an opportunity to develop resistance to that treatment. And it's possible that the disease that is left after leapfrogging over that treatment it will become more aggressive and more difficult to treat as time goes on. So the advantages of using 2 or 3 treatments together in combination at an earlier stage is that the treatment, of course, is more potent. It will result in higher disease control rates, longer survival, and if we can reduce an emission that allows them to go off hormone therapy, their quality of life could even be better. The downside is more side effects when combination treatment is administered. I think the best way to illustrate the interplay between these 2 different treatment approaches is to simply describe a case. A man that was diagnosed back in 2001 at the age of 64. He had a Gleason 9 with a PSA of almost 5. He was treated with radiation therapy to the prostate. Unfortunately, 2 years later, his PSA was up to 15, and an MRI showed that he had a metastasis in his hip. He went on standard hormone therapy for that era, which was Lupron and Casodex, and then had radiation to the hip. Now in 2005, that was definitely unorthodox, as there was really no established policy of giving radiation to metastatic sites back then. But there didn't seem to be too much downside, and as things have turned out, it seems like he may have benefited. In addition, he was also given a short course of chemotherapy called Taxotere. This put him in remission for if we do the calculation here, about 8 years. But in 2014, his PSA started to rise, and a back then newer form of PET scan called a C11 PET scan showed a new metastasis in his rib. He had radiation to the site on his rib, as this is starting to pick up popularity, giving radiation to metastatic sites, and was put back on hormone therapy. His remission was rather brief, and when this PSA rose up again in 2016, he was reinstituted on hormone therapy, Lupron and Casodex, and unfortunately, his PSA started to rise. And this was occurring at a time when he was on hormone therapy. So we are talking about hormone resistance. This is the typical window when Provenge or immune therapy is covered by insurance, and he underwent that therapy. He also started on a second generation form of hormone blockade, the type that can block testosterone inside the cancer cell, called Xtandi. He also was noted soon thereafter to have a metastatic site in his lymph node near the lung. This was biopsied and confirmed to be cancer, and so radiation was administered to that spot as well. These more recent treatments then resulted in a complete remission, and in 2022, after having a low undetectable PSA for a very extended period of time, he stopped his Xtandi treatment and started on testosterone. Being as elderly as he was, at this point he is in around 80. His testicles had been in remission for so long that he was unlikely to ever make testosterone on his own. And for quality of life reasons, he was put on testosterone. Now, of course, we have PSMA PET scans, and when he started getting testosterone, his PSA rose up to 2.1 in October of 2022, but his PSMA PET scan showed no metastatic disease. He had a further rise in PSA up to 2.2, and so in May of 2023, another PET scan was also clear. What we've learned is that there are about 10% of patients with advanced prostate cancer who are not going to show up on PSMA PET scans, and so he underwent another type of PET scan called an Aximum PET scan in June of 2023, which was also clear, generally reassuring us that his cancer situation, despite the rise in PSA, showed no imminent danger in this now 81-year-old gentleman. Now we are left with a situation where he's feeling much better on testosterone. His PSA is rising, but he has no detectable disease. We're thinking of getting either a C11 or maybe an FDG PET scan to make sure he doesn't have some strange metabolic variant of prostate cancer. For now, we're going to keep him on testosterone. And it looks like I did a bad calculation on the age. Actually, he's 86 now. So when we're looking at the decision making about giving combination treatment versus sequential treatment one at a time, studies have been done looking at survival outcomes in people with metastatic disease. There are two main categories that we look at for trying to decide how to administer combination therapy. One is in people who show up at the doctor and already have metastatic disease at the time of diagnosis. We call this synchronous metastasis. So they clearly have disease in their prostate. They also have disease that is somewhere outside the body. Studies that have been done looking at giving just Lupron versus adding some other effective medication as listed in the column on the left, Zytiga, Taxotere, radiation, Xtandi, or Erleada, all show better survival if instead of waiting for the Lupron to run out of gas, the men get a combination of Lupron plus Taxotere or Lupron plus Xtandi, Lupron plus Zytiga, those men will have better survival and live significantly longer. It's not a big surprise, really, because giving more potent treatment to less established disease is, of course, very likely to result in better outcomes. More recently, in 2022, studies have looked at giving so-called triplet therapy. So if Lupron plus Taxotere gives better outcomes, does Lupron plus Taxotere plus Zytiga give even better outcomes? And the answer to that question is yes, it does. Since these different treatments all work by different mechanisms to attack the cancer, the comparisons between giving Lupron and Taxotere alone versus Lupron, Taxotere, and Zytiga show that the latter group has better survival compared to the former. Now remember, these former groups, they will get the Zytiga at some point down the line. It's not like they're denied the treatment. It's just a matter of timing. So getting all three medicines immediately versus two medicines now and the third one later, by postponing that third one till later time, results in shorter survival. So since we know these facts, these are large randomized studies published in very reputable journals. Some questions arise. If giving all three medicines is beneficial, aren't there certain more favorable types of metastatic disease that maybe can get by with just two and have less side effects? It seems that they're leaning towards thinking that it's the men with lymph node only disease who maybe don't need the Taxotere. They can get by with just the Lupron and Zytiga. Another question that arises now that we know in that 10% of people that have BRCA mutations, maybe taking something like olaparib instead of Taxotere would be a logical substitution. And then the last question comes, in men that have these metastatic disease situations, when they get complete remission, when their PSA goes all the way down to zero, when their PSMA PET scans show disappearance of all activity, how long do they need to remain on Lupron and testosterone deprivation? The studies at this point are not completed, but it appears that after perhaps 2 years of treatment, that further ongoing treatment in people who are in a complete remission may not have any durable benefit as long as they're monitored when the treatment is stopped. Now, when we think of metastatic disease, oftentimes it's another situation where men have disease that was treated with radiation or surgery at some time in the past, and now there's a rising PSA and metastases are detected on a scan. The idea on how to manage these men, of course, is very different, because a disease that takes 3 or 4 or 5 years to show up after the radiation or surgery sounds nowhere near as scary or dangerous as one in which the man is diagnosed and has disease already all over his body. So it's becoming more popular now to use a more minimalistic approach if there's, say, only 1 or 2 lymph nodes, to simply treat those lymph nodes with some radiation, maybe with a short course of testosterone blockade. When men have multiple spots, then the typical approach would be to regress to the triplet aggressive approach that gives maximum anti-cancer treatment effect. After a person has been in this war zone for a while, there are going to be some individuals who develop resistant disease to the things that we've talked about, to immune therapy, to hormone therapy, to chemotherapy. And that brings about not an uncommon situation as to what do you do next. Well, fortunately, there's a recently FDA-approved radiation treatment that is kind of like a smart bomb. It can be injected into the bloodstream and find all the metastatic sites and treat them with potent radiation called lutetium-177 or Pluvicto. This is very well tolerated, the most common side effect being dry mouth because there's some spillover effect on the salivary glands. And it also can cause low blood counts. Prior to lutetium being on the market, we had another injectable form of radiation treatment, radium-223, or so-called Xofigo. The disadvantage of the Xofigo is that it would only cover spots on the bones. Lutetium will cover spots anywhere, whether it be in the liver, the bones, the lymph nodes. Xofigo is still a useful treatment because bone-based prostate cancer is common. It's also an injectable form of radiation. An interesting treatment that gets a lot of press and in my experience has not been that effective, but it can be effective, is to re-administer testosterone to men who have had low testosterone for a long time and now they're becoming resistant to the low testosterone therapy. In this case, men are given an injection of high-dose testosterone on a monthly basis, and for some reason, that can confuse the cancer and people can develop remissions. The reason I mentioned it also is, of course, these men that have been deprived of testosterone for many, many years are tending to feel much better getting their testosterone back, and this type of treatment gets a lot of attention. In my experience, the remissions are not particularly durable, and there is a risk that the testosterone can stimulate the cancer, so men have to be monitored very carefully. I said I was going to come back to genetic testing because sometimes in the course of genetic testing, they find a mutation that mimics mutations seen in other cancer types, maybe lung cancer or pancreas cancer. And there are treatments that have been developed for lung and pancreas cancer that are based on a genetic weakness in the cancer cell. So while it's not proven that that same medicine in prostate cancer will be effective, it's logical to assume that it may, and genetic testing sometimes will point to a treatment that's FDA approved in another cancer type that could help out in prostate cancer. And then the last form of treatment in this situation where people have become resistant to all the known FDA-approved treatments is to pursue investigational trials at academic centers where new medicines are being studied. That is, again, the same diagnostic test, Garden 360 or Foundation 1, which other mutations are sometimes detected besides the ones that we're looking for in prostate cancer, such as BRCA. So in wrapping up this overview of metastatic prostate cancer, advanced prostate cancer, the landscape is changing so quickly, it's critically important for patients to be educated about all these different options. There's also an unevenness in the delivery of care. Some centers specialize in prostate cancer, others are doing it more in their spare time. And the physicians these days are very busy with all the new developments and all the different cancer types. And it's important to get to physicians that are, for whom prostate cancer is a mainstream pursuit. As a baseline, if you look at people who are going to do better or worse, those that pursue strength training and keep their muscles strong, those that stay away from animal protein, this is for the advanced stages of prostate cancer. There are medicines to support bone health because loss of testosterone can cause weakening of the bones, and medicines such as Xgeva, Prolia, and Zometa can counteract that. There are ways to detect who is going to have immune side effects from radiation or Keytruda through a diagnostic test called ProstTox. There is a pill that can prevent breast enlargement, a common accompaniment of men who are taking testosterone deprivation. And lastly, it's always routine when we administer Taxotere to use a medication called Neulasta, which stimulates the immune system. I have seen a number of patients treated outside facilities that for some reason their physicians wait until an infection occurs before they start giving the immune stimulating medicine. Neulasta is covered by most insurances, and it typically has no side effects, and I think patients need to be aware that this product exists and request its use routinely whenever Taxotere is being administered. What do we have looking forward? I think what I've described to you today is a forward-looking approach to prostate cancer. I'd say the one thing on the horizon that looks exciting is an enhancement of injectable radiation called actinium. Lutetium-177 has been a big breakthrough. We're very excited about it, but if you look at the responses in men with very advanced disease, perhaps a third get fantastic responses, a third get stabilization of their disease, and another third start to have progression soon during or soon after the treatment. I've had 2 patients in whom actinium seems to have brought about durable remissions in men with otherwise very advanced disease. It's quite a bit more toxic, however, and it's not yet FDA approved, but it is available on clinical trials. The future for treatment of metastatic disease is going to be partly preventing metastasis in the first place, and that occurs through earlier diagnosis and more aggressive treatment, combination treatment up front. The exciting thing is that there are many, many new discoveries coming out due to the vast amounts of funding from both private and government sources. Prostate cancer is the most common cancer in men, and it's a huge marketplace, and research is progressing very rapidly.
Super hot seat, right? Usually we're doing Zoom together and we're not in the same room. So isn't it incredible that you're in the same room with me?
It's delightful here in Marina del Rey. Yeah. I showed a picture of the place where we're staying, and it's been a great weekend.
It's been great. So we're going to do a little thing I call Dr. Moyad's pro and cons with Dr. Scholes. So we're just going to look at a lot of little subjects, and I want to know the positive and I want to know the negative about these subjects. And then the rest of this we do on Zoom. We've got a whole other big conference session on Zoom. So are you ready?
Ready.
All right, here we go. First of all, I can't, and you talked about this in your talk, I can't stop talking about bone health. And the reason why is because of a paper we brought up, and we talked about at the last conference. It was actually a men's health conference, that when they did a survey of all the men on androgen deprivation therapy, less than 10% of them were getting DEXA scans. So 9 out of 10 men aren't getting standard of care in terms of seeing whether or not they have osteoporosis before, during, or after getting hormone therapy. They actually came out with the number 8%. I think that's almost being generous. Will you comment on what is the problem of getting a bone mineral density test right before or during the time you're on androgen deprivation therapy? Why isn't this standard protocol?
Well, I think prostate cancer is unique because it's being managed primarily by surgeons, by urologists, where medical oncologists are taking care of all the other types of cancer. And if you look at modern treatment of cancer, there's been a huge shift in the last 40 years. If you go back 40 years, everyone was getting surgery to have tumors removed. And if you look at it now in 2023, it's mostly about medicines. And medical care has been in the domain of the internal medicine doctors and the oncologists, whereas surgery is in the domain of surgeons. If you look at medical treatment for advanced prostate cancer, just as we've reviewed, a lot of it's just different types of medicines. Why are surgeons doing that? It's just the way it's always been. And unfortunately, very obvious and necessary things are being overlooked on the day-to-day management of men with advanced prostate cancer. So I think the take-home message for patients that are in this situation is look for a medical oncologist to manage their advanced metastatic disease. Don't stay in a urology office and get your primary care from a surgeon.
But there are all these bone drugs that you've used in your career. I call them bone protecting agents, right? How do I know if I'm supposed to be on one or not? Because they are approved for men with advanced disease under certain conditions. Why aren't we talking about this more at the conferences and other places? Because, and here's the question. Who do you put on these bone drugs? You know, what are the drugs and who do you put on them?
Everyone who is on a testosterone blocking agent.
Okay.
Any Lupron or any of its similar types of medication, any Zytiga or similar types of medication. These men are all known to have accelerated calcium loss and high incidence of osteoporosis, and it can be prevented with the medications that you've listed.
So you're more likely to lean putting someone on there if they're not going to be on hormone therapy indefinitely? They're just going to be on it for a short period of time. Do you still lean toward giving them a bone protecting agent?
It's a good question, because now with the advent of PSMA PET scans, we're giving more and more short course hormone therapy for only 6 months. And I think your point of why don't we get a scan and see if they are already depleted then we certainly would be putting them on treatment. But if they've got robust, strong bones, and we're only going to administer the treatment for 6 months, perhaps just observe it and check again. We check bone density tests in all of our men, not just the ones that are getting hormone blockade, because bone loss with age is common, and hip fractures in the elderly are disastrous. It's a simple test. The exposure to radiation is minimal, and therefore should be routine, probably in men that are over 70, to get a bone density test.
And the bone drugs that you give, do you give the injectables? Do you give the orals? They come in a variety of forms. Which type do you like?
Patients actually could probably pick the ones that they like. The orals, such as Boniva and Actonil, are a once-a-month pill. The injectables are convenient because you can take a shot every 6 months. The injectables often are covered by insurance, whereas the orals may not be, so you can save money with an injectable. But I think they're all relatively equally efficacious, and they are generally well tolerated, and I don't have a strong opinion in terms of one approach over the other.
Do you remember long ago, for this conference, long ago in my mind means 5 years ago now, it's not very long, where people thought the bone protecting agents might prevent metastatic disease. They thought they could protect from the cancer going into the bone itself. Where are we with that philosophy? Do we have any answer to that?
It turns out that with really high doses of denosumab, or so-called Xgeva, that they could delay the onset of bone metastasis in men who were hormone resistant. About 20% delay in the onset of bone metastasis. It didn't get FDA approved for treatment for that role because there was a lot of osteonecrosis when men were getting denosumab shots every month. So high doses cause jaw problems that are really nasty. So it has been proven in a double-blind randomized placebo-controlled trial that these medicines do indeed prevent the onset of metastasis to some degree, but in high doses it comes at a very high cost.
Yeah.
So we've taken sort of a middle road in using these medicines, but at the same time cutting back to maybe every 3 or 4 months for the injections rather than monthly, to try and get the benefit, hopefully, without inducing the problems with the jaw necrosis.
So you're not giving them that often, but they're clearly effective even when not given that often.
Yeah, I mean, people could argue that technically there's no proof that lower doses will translate into the same benefit that was seen as higher doses.
Yeah.
But the dangers of higher doses just are just unacceptable in my view.
I want to leave that topic unless there's something else you want to add about bone health.
No, the fitness, a little bit of calcium at bedtime, check your vitamin D levels, all those part of the picture.
Yeah, I mean, at least a baseline, at least checking the vitamin D just to see where it's at. Some people will come in astronomically high and they're not doing much. Some people will come in astronomically low and they're actually taking something. But, screening for, you and I agree, but vitamin D screening in general is not endorsed. But you'd think that people on hormone therapy would at least know that number one time. And that's another thing that probably happens less than 10%. It's not just the DEXA scan.
Well, vitamin D, here we are in California, people get lots of sun. We see vitamin D deficiency that is below the threshold that is stipulated by the labs is what is normal. In probably 15 to 20% of men that are just screened in the general population. So it's very common for people to be vitamin D deficient.
Well, speaking of something that adds to bone loss, and I just pulled this out of one of our journals. This is side effects of steroids, including prednisone. Can I read you this list? This won't scare anybody if they read this. Let's see, a round face, high blood pressure, high blood sugar, increased risk of infection, cataracts, glaucoma, bone thinning fractures, adrenal crisis, thinning of the skin, bruising, stretch marks, poor wound healing, muscle weakness. That's it. You don't have to look forward to anything else but that. So now why in the heck am I being put on a steroid with abiraterone? Because a lot of men out there are on abiraterone and they're being told to take prednisone, but they're hearing horror stories about prednisone. So why am I taking prednisone with abiraterone? Can you please tell me that?
Well, a little bit is good and a lot can be very dangerous. The amount of prednisone that's being given with abiraterone is designed merely to replace the amount of cortisone that we normally make in our adrenal glands. So the company is recommending 10 milligrams a day to reestablish these levels. Same amount was oftentimes given with Taxotere as just a matter of course, which we don't typically ascribe to. But let's say we cut the dose in half and give them 5 milligrams of prednisone. Probably not going to see much of any of those side effects that you've described. There are other alternatives. There's a diuretic called Inspra that could be substituted for prednisone for people that are particularly concerned about it. And in some cases, that's what we do.
INSPRA.
Correct.
Yeah, so that's a really good point. It's like aspirin. If you take too much, it could put a hole in your gut. If you take a little bit, it can cause blood thinning and maybe prevent a second heart attack, right? So the prednisone that you're asked to take on abiraterone is so low, and I get nervous sometimes if men don't take it because they can run into the toxicity. The toxicity becomes more serious of abiraterone. Okay, let's move on from that topic. We're doing well. I'm giving you a B+ so far in this interview. CAR T-cell therapy, immune therapy. If you came these different types of immune therapy, we'll talk about the ones you talked about in your talk, but where's this CAR T-cell therapy that was supposed to be so magical and save lives and do all these things? Is it really? I know in lymphoma and leukemia, it's been a game changer. No one's ever used that word before. I'm coming up with the terms game changer. But I haven't heard much in prostate anymore. I've just heard about it in leukemia and lymphoma. Can you give me an update?
It is powerful enough to bring about remissions in men with really bad prostate cancers. The problem is that you're looking at treatments that seem to have toxicity on the same level as like bone marrow transplantation in these elderly men who are heavily pretreated and don't have the same physiology that younger lymphoma patients have who can withstand that type of a hit. So I think that, I'm not an expert in CAR T-cell therapy, but I think right now they're looking at whether mitigating the dose can make this something that would have some practical use. But as things stand right now, though I have seen patients who have had their prostate cancer growth impeded by CAR T-cell therapy. In almost all cases, it just shelled them out as a human, and unfortunately, the treatment was at least as bad as the disease.
Okay, I appreciate your honesty on that. Let's stay within the immune category. Provenge is sort of the forgotten FDA-approved product. I don't know, you just don't hear about it discussed much, but Provenge is still something that you use. And when I listen to your talks, I always get the idea that the lower your PSA, and I think you mentioned that, right? Plus the earlier on when you're at CRPC officially, that's when you might see a benefit. Is that right, or is there something else to add to it? Because I just think that's still sort of the forgotten weapon in the whole game that you're involved in.
I think it's tragic, after this crazy brush with COVID that we've had, we've all heard all the excitement about vaccines and the pushback against vaccines, and you've seen the exact same problems in professional opinions about Provenge, which is like a cancer vaccine. And there's people who are strident believers and other people who think it's all a hoax. Sadly, to me, the evidence is it was approved with double-blind placebo-controlled trials. It's not like it wasn't proven to prolong life. There are other problems beyond that. The other problem is simply the complexity and the nature of what, when I described this timeline of different treatments, you could see where we placed Provenge right after Lupron resistance is a tiny little window, because it's much easier for, many times these patients are being seen by urologists, it's much easier for them to simply write a prescription and put these patients on a pill than put them through a somewhat involved immune process that Provenge entails. They have to go have plasmapheresis and get infusions, and urology offices aren't set up to do that. So much easier to put them on some Xtandi or Zytiga, which have magical anti-cancer effects. They go into remission, and by the time they start running out of gas on Xtandi and Zytiga, all of a sudden the cancer is so serious that they're really not a very good candidate for a vaccine any longer.
Well, let's say they were put on those drugs, and then they turn around and they talk to you and they go, wait a second, I'm 3 weeks on those drugs, Zytiga, Xtandi, and I want to do Provenge. What do you say now? Do you say
oh, yes.
Do you say fine?
Let's do it. Yeah. There's nothing that precludes you giving them at the same time. As we hopefully got across in the talk, that the complexities are not simply picking what to do, but whether or not they need to be administered in combination or not.
You use Keytruda, pembrolizumab, right? So this is another immune drug, and you talked about it in your talk. You said if you qualify with a certain marker from a test, you can deliver Keytruda, right? And you give it how often if someone qualifies for this immune boosting drug?
Well, the protocols are changing. Historically, we would give it every 3 weeks. Studies now seem to indicate you can give it every 6 weeks.
And you give this as sole therapy, or you give this as an add-on to everything else they're doing?
In the patients that we are giving Keytruda to, these are typically people with very early small amounts of metastatic disease that want to try and suppress their disease progression without having to block their testosterone. Okay. And in some cases, the Keytruda can be effective in that role.
Okay, let me go outside of FDA approval for a second, just think outside the box. You also talk about in your lectures oligometastatic disease, where people have a couple spots here and there. They could be in a certain region, they could be scattered, and you believe, I know you have a lot of patients that get radiated to that area and then they're fine for years and years. But the concept is, do you have people that get radiation to oligometastatic sites that also can potentially qualify for Keytruda, or because it would seem to be a natural fit to test the possibility of radiating these small sites and using that immune therapy early to put them in remission longer, or maybe this is a dream. What do you think?
I think the problem, of course, is that measuring outcomes with immune therapy, you're not always going to know what's working, and Merck Pharmaceuticals, who manufactures Keytruda, has been very generous in providing compassionate use Keytruda. So we have used it in that very role that you've described, and we've also used Provenge in that same role. So if people are undergoing Provenge, we often will consult a radiation therapist and say, hey, this man has, let's say he's got more than 4 metastatic sites, and normally speaking, we wouldn't radiate them all, but why don't we just radiate one of them along with the Provenge, because we know that can have an immunostimulatory effect.
Do you worry about oligometastatic disease, a couple of people getting radiation over and over again? Do you worry about radiation-resistant disease eventually when people get hit multiple times, or is that just something that happens with very bizarre tumors?
The amazing thing about modern radiation is that essentially 100% of cases, it will sterilize the tumor site, assuming the radiation is done professionally and appropriately in that area. So radiation-resistant, no. New spots that can show up, and then after some period of time where too many spots have been treated such that you don't have enough bone marrow reserve to keep in that path, that can happen. But radio-resistant disease, no. It's the radiation therapy, if it's given in a large enough dose, will sterilize the tumor 100% of the time.
And to end the topic on immune therapy, what are you looking for? Because I remember in the early days, Provenge did not cause a PSA reduction, even though it helped you live longer. Is that still true? That you don't see a PSA reduction with Provenge, but you can see benefit?
Well, no, it's not a matter of seeing benefit. Who benefits when they have a COVID vaccine? We can see in a large population study, before COVID vaccines came out, we had patients, 3 patients that died of COVID. And we had, throughout Southern California area, we had ICUs that were full of people on respirators because of the seriousness of the COVID. Since the COVID vaccines and the boosters came out, we have not had a single patient who's gone to the hospital. Of course, now, more recently, we have Paxlovid. But even without that, we were not seeing in individuals really serious forms, although people were still getting infected.
Yeah.
So the same thing is true, I think, many times with immune therapy in prostate cancer. One interesting example of how silently our immune systems work, this came up recently because a patient of mine needs a lung transplant, and he has a small tumor in his prostate. We've been watching for 10 years. It's never done anything. And the transplanter, who's going to be giving immune suppressive medications, said that you have to have that tumor treated in your prostate, because when I take your immune system away, that little tiny tumor could kill you. And you say, that's ridiculous. I had a patient who died who had a small tumor in his prostate, and they didn't know back then. And after he had, I can't remember what kind of, I think it was a liver transplant, he ended up dying of metastatic prostate cancer. So all these small little tumors that we say are so harmless are mostly harmless because our immune systems quietly and effectively can keep them in check for a long period of time.
Yeah.
But we don't have a way to really measure that other than we know that, our immune systems keep 4 or 5 pounds of bacteria in all of our guts in abeyance, which is an amazing thing. There's like a bioreactor going on in our guts, and yet we live on for 70 or 80 years without infection.
I mean, the immune system is amazing. Sometimes it's sort of unappreciated, but you bring up a good point that made me think of a question, because we're seeing a little bit of an uptick in hospitalizations right now in COVID in September around the country. But if you follow the data and you follow practice, that COVID was especially harmful to the cancer population. There's much more higher mortality rate, higher hospitalization rate. So in this day and age, why wouldn't a cancer patient, especially a prostate cancer patient, get the latest vaccine and/or when traveling, talk to their doctor about traveling with Paxlovid if they qualify, the antiviral. You have so many patients. I know a ton of people who go to Turkey, they go to Africa, they're traveling all the time, they're living their life, but they're not traveling with any antiviral medication, and they're dealing with cancer. So I don't know where the question is there, but this makes no sense to me.
Well, 2 things. One, 80 to 90% of our prostate cancer patients are essentially not metastatic. So there are the patients with metastatic disease, and that's what we covered in today's talk.
Yeah.
That's actually a minority of my practice. So the average prostate cancer patient is a more typical elderly man. But your suggestion that we should travel with Paxlovid, I think, is like kindergarten level obvious. I mean, it's a very effective antibiotic, and there are patients even here in the United States that aren't informed that if they test positive, and Medicare will pay for 8 tests a month. If you're over 65, you can test yourself twice a week for the rest of your life at the federal government's expense. And if you test positive and take Paxlovid in a timely fashion, I think you're going to abrogate almost all of the significant symptoms.
I just think, as you do, that the cancer patients should talk to their oncologists about traveling with it. I think it's to have this medicine. And if I had a dime, all cancer patients, if I had a dime for every person that found themselves in the middle of some island and then called me and said, "You're not going to believe this, I got COVID," and they're not traveling with Paxlovid or something, I'd have a lot of dimes. I mean, it's just unbelievable to me. All right, I dealt with that overall. Can we talk about chemotherapy? I only have 5 or 10 minutes, but I just want to cover a couple other topics. You know what people have told me that outside of you in oncology that have big practices like you? And this really surprised me. They've told me lately that their perception of chemo has gotten better with more approvals of drugs in the castrate-resistant population. And I said, wait a second, that's counterintuitive. We have all these new drugs. Why is your perception better? They said they've begun to appreciate its broad impact in that population. Do you want to comment on that? Because that may not surprise you, but that surprised me.
Well, the word chemotherapy, the word cancer, the word radiation. The radiation therapists really burned a lot of people, 20 years ago, and are still living down that reputation. The type of chemo that was given to people 15, 20 years ago was not that effective and was 5 times more toxic than what we have now in 2023. So it's a horrible word. And to counterbalance that is there is enough genuine efficacy, anti-cancer horsepower in Taxotere for prostate cancer specifically. And the toxicity, other than some brief hair loss and some transient fatigue after the injections, is just not that big a deal. So I think after 20 years of using Taxotere in men with metastatic disease, people are realizing that when it's used in an appropriate role, it's very effective and quite useful.
People know about these two, Taxotere and Jevtana, but you mentioned carboplatin. You don't hear that word very often except in other cancers. So can you just re-emphasize or bring me back up to speed? Are you using this often, or is this rare to use carboplatin? You're clearly using the first two a lot, and they have a great track record, but when do you add on this other drug or another chemo? Is this in rare circumstances?
So you talked about Taxotere, Jevtana. They're actually very similar medications. And the approval that Jevtana achieved when the FDA started covering it was based on a trial where men had already had Taxotere, stopped, and then restarted Jevtana. And they showed that the ones that restarted Jevtana compared to a placebo lived longer. And the idea was that, wow, there's actually more value in taxanes, these are both taxane-based types of chemotherapy, than simply giving it for a short period of time. That more extended time will actually help people live longer. But given the fact that it's the exact same medicine, or very close to the same medicine, it's logical to say, well, what other type of chemotherapy that works by a different mechanism could juice up the Jevtana if you are on your second round? It's always more worrisome to be on your second round of something than having an untreated person. Your response rates are going to be much higher in the untreated, whereas someone that's been previously treated, your response rates are going to be lower and the duration of response is going to be shorter. So it's very common for us to give both Jevtana and carboplatin when we use Jevtana. The use of single-agent carboplatin in our practice is not very common. So I would say that the primary role is to try and enhance Jevtana response rates by adding some carboplatin.
How long can a person be on chemotherapy before you say, this is not working or it's working? Do you know immediately within weeks? Do you generally wait out 3 to 4 months? What's your patient's level, and what's the patient level of the patient be in this situation?
No, this is a really good question, because I'll see patients that have been in other practices where they've been on treatment for 6 months and their PSAs have been rising throughout, and you're, what are they thinking?
Yeah.
Unlike the immune therapy situation, which we described, and where PSA does not correlate or give you much indication as to how much you've accomplished, with Taxotere and Jevtana, it's immediately obvious what's working and what isn't. And the specific answer to your question is 2 cycles. So 2 injections of 3 weeks apart. Check the PSA a couple weeks after the second injection. And the PSA, if it had been previously rising, which is almost always the case, should at least be stabilizing.
Okay.
If it's continuing to go up in a unremitting fashion, it's time to move on. And the idea of just going on and on with something that's not working oftentimes really bothers me.
So the PSA is an excellent indicator with chemo. It's not an excellent indicator with Provenge. Is it an excellent indicator with Keytruda that we talked about the immune therapy? I mean, or not?
No, I think it is.
Okay.
Yeah, I think with Keytruda we expect to see marker results if we're going to continue treatment, especially since it's a off-label indication. You can't keep giving a medicine that is perhaps only going to benefit 1 out of 5 people indefinitely, unless you have some encouragement or results in that individual showing that maybe this individual is in that segment of the 1 out of 4.
You used a word I haven't seen you use in one of your talks before. I mean, you emphasized it more than the previous talks I had seen, because we were talking about chemotherapy. You talked about Neulasta, and you said on your slide it prevents infection. And you said, you're implying that not enough people know about it and are on it. Fine, that makes sense. How does it prevent infection? What does this do? Why are you so excited about it? What does this drug do?
So one of the common side effects from chemotherapy, I mentioned hair loss and tiredness. In the past, we had other problems with chemotherapy, nausea, and that can be, I didn't mention that because the medications such as Zofran completely eliminate nausea. And then the other huge problem was lowering of blood counts, neutrophils in particular, with the result of those intestinal bugs that I told you about getting released into the bloodstream, where people could have life-threatening sepsis. Neulasta stimulates the bone marrow to produce extra white blood cells, and if it's administered at the time of the chemo, instead of seeing a drop in white blood cells to a very low nadir that stay down for 5 to 7 days and then recover, which is what we dealt with for much of my early career, now we see a really brief and short spike, such that I can't remember the last time we've seen an infection in any of our Taxotere-treated patients.
How long does it take for Neulasta to work?
So it covers a period, so the chemo is given on a 3-week cycle, and the typical timing for the low point, the nadir of the white count, is about 7 to 10 days after the injection of chemo.
Okay.
So you give the Neulasta at the same time as the chemo, and it keeps the white cell count up for about 2 weeks.
Okay. I have asked every speaker who is an oncologist or works with advanced disease this question over 20 years, except you.
Okay.
And I bet you don't know what it is, and this is why I have such power here. It's a great question, and I'm thinking the one person I probably should have asked was you, but maybe because I talk to you all the time, or we used to talk all the time until, you know, this whole thing blew up on YouTube, and then suddenly, you know, no one's got time for more yet. No, but seriously, I always asked everyone with advanced disease who dealt with it, what's the latest miracle you've seen? Because we always sometimes talk about non-responders, and can you just elaborate on that miracle? I know you've seen countless miracles. I never ask you that question because we talk so much, but I'm asking you the question officially. Let's stay in Positive Town here. Let's be the mayor of Positive Town. You see miracles. Can you remember the last miracle you've seen in treatment and give us a little bit of hint about what it was about and the circumstances?
Oh, I have a list on my desk because I need to publish these results. It's not a miracle, it's a list of miracles. And the miracle is more of a category than an individual. We never expected that we would be curing metastatic disease with some regularity. The training in oncology when I first got into this in the late 80s was that any metastasis translates into eventual certain death. So spread equals demise, and that of course is still true with a number of cancer types. In prostate cancer, due to improved treatment, improved detection, better scans, and aggressive early treatment, I'm going to have to publish the significant list of men now that are 4 or 5 years out after treatment for metastatic disease with recovered testosterone levels, undetectable PSAs, 4 or 5 years after their last treatment.
And these are people on all types of treatment, or just you're seeing this, or just?
These are people that usually at some point along the way had metastatic disease radiated. And they had some other, perhaps combination of chemo or hormone or immunotherapy to try and goose it, and who have never had their cancer come back. That is not uncommon in my practice, and it's totally unexpected.
So there's that synergism there, that combination. So are you to the point now where you look for these almost every few months? I mean,
Yes, yeah, we've.
I love that story. Yeah. I can't believe I never asked you that. That's my fault. But then again, like I said, we talk.
It's a paradigm shift, and I think that the patients that I'm describing had to have been diagnosed with old-fashioned scans, whom we pursued aggressive oligometastatic therapy with spot radiation. So if we were able to accomplish that with crummy, old-fashioned scans, the degree of enhancement that we're going to see now with these modern PSMA PET scans, I think it's going to be dramatic. And I think it's going to change the way that we treat prostate cancer, in that we've been so much back on our heels being very aggressive with hormone therapy to go after micrometastatic disease, because we know that if it got momentum that they would eventually die. So men are getting 18 months of hormone therapy routinely. All you have to have is a Gleason 4 + 4 = 8. Well, now with the PSMA PET scan showing no metastasis, the idea of, well, why don't we just try and get rid of the 4 + 4, because we know that the PSMA PET scan will be correct 80% of the time. So 4 out of 5 of those men will stay cured if they have their primary tumor in their prostate radiated. And what about the 20%? Should we just let them die? No. If their PSA even starts to come up a little bit, we can find the disease with a PSMA PET scan and go after a cure on the second go-around. So then the people that really need the aggressive treatment get it, and the ones that didn't need it are spared it.
Let's talk about castrate-resistant prostate cancer. Let's talk about advanced disease, you can call it that, right? I just want to mention a couple biomarkers, because I've been looking at some papers before we decided to get together this time. And I just want to hear your comment, and then I'll go with the final question. You know, you're always looking for a marker. As it becomes more and more advanced, you're always looking for a marker for success, right? So there was a paper that came out recently that got a lot of attention, and I had seen you use this before in your practice. It said we should be looking more in CRPC patients at the blood marker chromogranin A. Do you agree with that? Do you want to explain that? Because everyone's always looking back on PSA, but PSA is okay. You're always looking for other hints that something's working. So whether it's alkaline phos, whether it's LDH, right? There's all these markers you and I have talked about. I was surprised to see this paper say chromogranin A, something I had seen that you pulled 10 years ago. I don't know if you still pull it, but do you have any comment on that marker at all?
I think that's just the tip of the iceberg. One indicator of multiclonal disease that is a end-stage phenomena in really bad prostate cancer. And there are other indicators besides chromogranin A, you mentioned them, LDH, these sorts of things.
Yeah.
Thankfully, we don't see that very much because we try and prevent things from getting to that level. Other things beyond the tumor markers that you mentioned to consider came up briefly in my talk: FDG PET scans, C11 PET scans, Axon PET scans. Because of the multiclonality of very advanced prostate cancer, if you just do a PSMA PET scan and it shows nothing, you can't just hang up your hat and say we're done, because if someone has a rising PSA, something's causing this. So we need to find out if it's a rare variant, and it can be detected not only with blood tests, but also with PET scans.
So it sounds like you're still incorporating all of these and more.
I'm devolving more towards the PET scans than I am toward the
leaning on these
blood markers, because they're non-specific, whereas the PET scans are very targeted.
Another question I've asked many people in oncology, I just never asked you, because again, I take for granted that I know you very well. You know, you're like the older brother that looks up to the younger brother, me being the younger brother, right? And I'm sure you constantly adore me and look up to me as a celebrity, and I appreciate that thinking. But one thing I notice about you, and a lot of people do notice, and I'm not asking you to get specific, I'm asking you to be generalized here, because I've talked about it, is before we end today, you have been very consistent as a doctor in your faith, in your belief in a higher power, in your faith. We can call it religion, we can call it spirituality, we can tag it with whatever we want. I have found that has kept you steady and made you a better physician. And I have found it's the one topic in patients and in medicine that actually has data, whether it's quality of life in other areas, that we shy away from because we're too worried that that's gonna be the hot zone, that that's gonna get us in trouble talking about religion or faith. I don't think we should shy away from it. Can you just describe to me at the end here how important your faith is to you, and do you talk about faith and spirituality with patients still?
Yeah, I mean, in terms of important to me, we could talk for hours about that. But in terms of the struggle that patients are going through in their battle, I think there's two levels. One, of course, is being able to pray and believe that God can help you. I think the other thing is to look at the circumstances and take something positive out of the difficulties. I think that we're all, not just cancer patients, but humanity is characterized by difficulties. And sometimes we get a persecution complex and we think, why me, why me? And, but successful people look at, well, how is this guiding me to a better life? There's a faith that forces bigger than yourself allow these difficulties to happen. And we know that our stubborn human nature doesn't allow us to just go out and, run our half mile and lift our weights and swim. We have to be motivated somehow. And I think that the circumstances of life motivate us to become better people if we turn it to a positive. So yeah, it comes up all the time, actually.
Yeah, I think that's well said. I think it's important as a practitioner to let people, I'm not saying sell it. I'm not saying sell the Kool-Aid, but to let people know that you think that's an important aspect of life. And it comes with certain benefits if you are a part of that. Now, if you choose not to be, that's your choice. But I'm really sorry that in the area of cancer, we've kind of stayed away from it because I think people fear it's a hot button issue. I don't think it's a hot button issue. I just don't think people can explain it well.
Yeah.
So I appreciate you sharing that. Now, on a lighter note, I worked with some very talented people at the PCRI to provide you with a tennis ball.
Okay.
I hope you're appreciative of this. This is not only a tennis ball. This serves another function. It's an advertisement that I know that you stand behind very much, and I want you to show the camera. It's a Pen 1, right? Mm-hmm. But it also comes with an ad that I know that you back up tremendously, especially when I'm talking to you. Do you want to guess what the advertisement is?
I have no idea.
Take a look.
All right. It's for what, green?
The advertisement says, I love surgery. Hold on, get this in the camera.
I love surgery on everything but the prostate.
I thought you would really enjoy hitting that tennis ball, of course, because how much I love surgery.
I can take out all my
right, so you can take it out, right? Exactly. So in one way, I look at it as a gift. in
That's
another
a
way.
big step for the child of a urologist.
I love surgery. I'm just saying, even though I know you're not a big fan of it, at least you can hit it. You can take all your anger and frustrations out on it. What better gift is there to give? I was thinking about giving you a car.
It's very self-sacrificial on your part. Yeah.
All right, listen, I am going to see you again, but I won't be in person. I love seeing you in person. I think it's great that we got to be together, and I'll see you soon, definitely. And this is going to be another great conference.
Thank you, Mark.
Thank you.
Yeah.
For that fantastic presentation. Thanks to everyone who joined us today for day one of our conference. We're going to be back bright and early tomorrow at 8:30 a.m. Pacific time with Dr. Matthew Cooperberg, who's going to give us a presentation on active surveillance. And we also have Dr. Eugene Kwan, who's going to give us a presentation on advanced treatment and side effects. And we'll end tomorrow with Dr. Scholes and Dr. Moyet again in their Q&A session, where they're going to recap everything that was discussed and answer some of our questions. Also, thank you to our sponsors, Bayer, Janssen, Pfizer, Astellas, Novartis, Dendreon, Sumitomo Pharma America, and Sanofi. And I'd also thank you for joining us this afternoon. I look forward to seeing you tomorrow.
Therapy used to treat certain men with advanced prostate cancer. Provenge is customized to each individual and is made from his own immune cells. Immunotherapy is the prevention or treatment of disease with substances that may stimulate an immune response. The immune system has memory and can recognize substances it has encountered previously. Immunotherapy is designed to boost the immune system to target and attack advanced prostate cancer. This is why immunotherapy empowers the immune system to fight the cancer immediately and allow the effects to last over time. Indication: Provenge is a prescription medication used to treat certain men with advanced prostate cancer. Provenge is an established cellular immunotherapy and is customized to each individual by using his own immune cells. Important safety information. Before receiving Provenge, tell your doctor about any medical conditions, including heart or lung problems, or if you have had a stroke. Tell your doctor about any medicines you take, including prescription and non-prescription drugs, vitamins, or dietary supplements. The most common side effects of Provenge include chills, fatigue, fever, back pain, nausea, joint ache, and headache. These are not all the possible side effects of Provenge treatment. Provenge is made from your own immune cells, which are collected during a process called leukapheresis. The cells are processed, returned, and then infused back into the patient through an IV, intravenous infusion, approximately 3 days later. This process is completed in 3 cycles, about 2 weeks apart. Each infusion takes approximately 1 hour and requires 30 minutes of post-infusion monitoring. Provenge infusion can cause serious reactions. Tell your doctor right away if you have signs of a heart attack or lung problems, such as trouble breathing, chest pains, racing or irregular heartbeats, high or low blood pressure, dizziness, fainting, nausea, or vomiting. Have signs of a stroke, such as numbness or weakness on one side of the body, decreased vision in one eye, or difficulty speaking. Develop symptoms of thrombosis, which may include pain and/or swelling of an arm or leg with warmth over the affected area, discoloration of an arm or leg, shortness of breath, chest pain that worsens on deep breathing. Have signs of infection, such as fever over 100 degrees Fahrenheit, redness or pain at the infusion or collection sites. Tell your doctor about any side effects that concerns you or does not go away. For more information, talk with your doctor. You are encouraged to report negative side effects of prescription drugs to the FDA. Visit www.fda.gov/medwatch or call 1-800-FDA-1088. Please see accompanying full prescribing information.
One thing my prostate cancer hasn't changed: this place. We've made some great memories here, and we're making one today with a little help from Nubeqa.
Nubeqa is a prescription medicine used to treat adults with prostate cancer that has not spread to other parts of the body and no longer responds to a medical or surgical treatment that lowers testosterone.
I was on hormone therapy, but my PSA was rising, so my doctor recommended Nubeqa.
In a clinical study, men lived 2 times longer without their prostate cancer spreading when they added Nubeqa to ADT. Nubeqa may also extend survival. Nubeqa may cause serious side effects, including heart disease and seizures. Tell your doctor right away if you have chest pain or discomfort, shortness of breath, loss of consciousness, or seizure. Nubeqa can harm unborn babies and cause loss of pregnancy. Common side effects were changes in liver function tests, decreased white blood cells, feeling more tired than usual, arm, leg, hand, or foot pain, and rash. Nubeqa helps you live for what you love. Ask your doctor about Nubeqa.
The Prostate Cancer Research Institute is an educational organization for prostate cancer patients, their caregivers, and their families. We put patients first and are an unbiased source of information and support. For over 20 years, our goal has been to meet the educational needs of prostate cancer patients at every stage of their journey. Medical technology is advancing rapidly, and new treatments are becoming available. Patients have to make complex choices which have lasting implications. They face unexpected industry biases and doctors who may not be up to date on the latest research. Your donation helps men receive the latest, most up-to-date information, which empowers them to make informed decisions. Our website, PCRI.org, is a wealth of information and resources. Our conferences and webinars are a way to get patients' questions answered by leading physicians and researchers. And we have a helpline for men to call with questions about their diagnosis, treatment choices, and side effects associated with these treatments. Each week we produce multiple videos covering concepts and every patient question that we can think of about the disease in a straightforward and easy to understand format. This was a brief overview of what we do at PCRI, and to learn more you can visit our website. Your donation directly funds our educational programs, which give life-changing information to men during a very vulnerable time in their life, and we thank you for your consideration. You can visit PCRI.org to learn more.